Hi, we'll give 2 extra minutes because people are trying to get the registration and everything, so we'll start in 2 minutes. So, hello. We'll be starting while people will continue to come. And first of all, I have like a big welcome for you and several thank yous that I want to make. And first of all is welcome. I think we're truly delighted that we're having this conference. I think that in the last 2 decades, we've seen amazing breakthroughs in our understanding of AD in DSAD and autosomal dominant AD. I think this has been incredible for the field as a whole, for understanding Alzheimer's disease. But we were lacking a specific forum to discuss among us. I think that we got diluted in the big AD conferences, and we thought that it would be really important to have a forum to really connect and discuss the advances and foster collaboration among us. So really, we're truly delighted that this could happen. And that takes me to my thank yous. And first of all, I want to thank the DSAD-PIA and our colleagues in the ADAD, from ADAD that are in the scientific committee for their support and hard work in making this conference happening. I have a very big thank you for the Alzheimer's Association and especially to Heather. I think that Heather Snyder has been very instrumental in making this happen. And I also want to thank personally Arcadi Navarro from the Pascual Maragall Foundation. The Pascual Maragall Foundation matched the funding of the Alzheimer's Association, and we could kickstart this conference. And last but not least, I want to thank all the companies, our platinum, gold, and silver sponsors from the companies for the support to the conference, but also because they are truly now considering the possibility of doing trials. Some of them are ongoing, and for us this is hugely important because for many years we've been bringing bad news to people with Down syndrome and their families, and now we truly can talk about hope. I think that with the new treatments there is a true hope that comes from these families, and I think that we're going to see it in the talks these 2 days that a completely new world is about to start, and I think that we truly can bring this hope to families. And with that, I think that I give the word to Raquel, the co-chair of the organizers, is representing the ADAD, and thank you all for being here. Thank you. I'm sorry. We haven't given this book, but the Fundación Iberoamericana Down 21, there is this book, it's in Spanish, it's about AD in DS, so people that are interested, we have a limited number of copies, but at the registration desk, those of you that are interested, you can ask for a copy until they run out, so do get it.
So, good morning, welcome to Barcelona to everyone. My name is Raquel Sánchez-Valle. I'm a behavioral neurologist. I'm the group leader of the Alzheimer Disease and other cognitive disorders groups at the Hospital Clinic of Barcelona, a hospital clinic that's about 3 stops at the metro, by metro from this building. So I've been working in autosomal dominant Alzheimer disease since 2004. Juan Fortea joined our group for his PhD in 2008 to work with autosomal dominant Alzheimer disease and sporadic Alzheimer disease. And already at that time, he tried to convince us that Down syndrome was another type of genetically determined Alzheimer disease. So after his PhD, he came to this center, to the Hospital São Paulo, and started his cohort in Down syndrome. We have worked together for a while in several works with autosomal dominant families from the hospital clinic and Down syndrome individuals from the Hospital São Paulo. And this conference is his idea, a great Juan idea again. So we think that it could be very fruitful and very interesting for having researchers from the AD field and Down syndrome field in the same room for 2 days. So I think that could be a great meeting. I hope so. And I hope you will enjoy it. So thank you for coming. Welcome to this meeting. I will give the to Kathy. So.
Thank you, Doctor, panel members, ladies and gentlemen. It's a great honor to be sitting at the opening panel of this important conference. As the CEO of the Catalan Down Syndrome Foundation and sister to a person with Down syndrome, I am deeply invested in the topics we'll address. For 40 years, our foundation has been at the forefront of addressing the unique needs of individuals with Down syndrome. pioneering inclusive services across all life stages. Our independent living service stands as a significant milestone. In 1987, we established the Barcelona Down Medical Center, dedicated to providing comprehensive medical care for individuals with Down syndrome. Recognizing the emerging link between Down syndrome and Alzheimer's disease, our collaboration with Dr. Juan Fortea and Hospital de Sant Pau in 2012 led to the establishment of the Down syndrome and Alzheimer's disease unit. Now a focus of excellence in research, diagnosis, and care for individuals with Down syndrome and Alzheimer's disease. As we gather to explore the latest advancements in Alzheimer's research, I urge us to consider the vulnerability of a population often overlooked in these discussions. For decades, most people with Down syndrome were relegated to institutions, deemed as having little value to society. However, with the recent discovery of the link between Down syndrome and Alzheimer's disease, there is a newfound interest in understanding and supporting this community. As we move deeper into research, we must remain grounded in their reality. Many now work and enjoy opportunities for independent living. Therefore, the research conducted must be respectful of their daily lives. We must prioritize interventions that have immediate and tangible impact on their lives. These interventions should not be overly invasive, considering the cognitive challenges they may face. Behind every data point and research objective lies a person with unique experiences and needs. Let us not lose sight of the humanity at the core of our research, ensuring our efforts uphold dignity and well-being of those we seek to help. Oops. Let us approach our research with empathy, understanding, and a commitment to improving the lives of individuals with Down syndrome now and in the future. Thank you.
Good morning. So, as a director of the Department of Neurology, I want to welcome you all to Sant Pau, and I want to thank you for being here, and especially to Juan Fortea and Raquel Sanchez and all the organizers for putting together this great initiative in such a special venue. I want to share with you that this impressive facility where we are now, which is a UNESCO site, has witnessed the first step in the history of neurology in Spain. In 1882, a physician named Dr. Barraquer Roviralta founded the clinical neurology in Spain with the first specialized clinic in the old hospital of Santa Creu, not here, but in the old part. The clinic was named Electrotherapy Clinic, that later would become the first department of neurology of Spain. And since then, neurology has been very strong in Barcelona, and today it's great that we can join forces to recognize this work around this a common topic. The theme of this meeting, I think, is especially relevant and timely for us and for Barcelona, because the two organizing hospitals have pioneered the care and research in Down syndrome and autosomal dominant AD. So I wish you a very nice meeting and stay in Barcelona. Thank you. So, with Juan and Raquel, we decided that that would be a very, very good moment to take an opportunity to recognize the lifetime, the work of a special person, and to give a Lifetime Achievement Award to Dr. and Professor Rafael Blesa. So, Dr. Blesa graduated in medicine in the University of Barcelona and completed his residency in neurology at Hospital de Santa Creu in São Paulo, just here, this facility. I have to say it wasn't that nice as that you see today. He did his PhD thesis on the characterization of a very popular mouse model of Parkinsonism, and he worked at Hospital Clinic until 2003. During these years, he created one of the most competitive Alzheimer and memory units among Europe. Also, during that time, he founded PicoGen, the first and novel program in Spain for genetic counseling for dementias. And this program was later directed by Dr. Sánchez Valle. Later, Dr. Blesa, together with his wife, Professor Isabel Illa, Dr. Blesa performed an international stage at NIH, Bethesda, where he led key studies with FDG PET. In 2003, he was appointed as chair of neurology department at the new hospital of São Paulo, the one you'll see close by, nearby. And during these years, he transformed the department in a modern and competitive service. He was instrumental in the creation, together with Dr. Juan Fortea, of the DABNI cohort, a unique longitudinal cohort of more than 1,000 individuals with Down syndrome, and the Alzheimer Down program. This award is in recognition, and among many other achievements, of his key role in the research and advancement of the care and quality of life of individuals with Down syndrome and autosomal dominant AD. It is an honor for me to give this award to my mentor and friend, Rafael.
I want to thank the organizers of this conference on autosomal dominant Alzheimer disease and Down syndrome associated Alzheimer disease, the sponsors, the Alzheimer Association, and especially the co-chairs, Dr. Raquel Sánchez del Valle and Juan Fortea and Alberto Lleó, for thinking of me. When I look back, I realize that my life fits into a really small space. I was born in Hospital Aliança. Hospital Aliança is 1 block from the entrance of this building. The entrance of São Paulo Hospital, exactly where we are now. I was a patient of São Paulo in my childhood for allergic asthma. And I was a medical student, a resident at São Paulo, and finally, I was director of neurology until 2021. I will not bore you by explaining that my house also was within walking distance from my office here. Hospital Clinic. Hospital Clinic, as Raquel said, is a 4 metro stations from São Paulo. As an infant, I was treated at clinic for polio, which was a fashionable disease in the middle of 20th century, so even at that young age, I was already trendy. In 1982, Eduardo Tolosa, Professor Eduardo Tolosa, hired me to be a staff neurologist at clinic, where I worked until 2003, except for a, let's say, short 3-year stay at the National Institute of Health, NINDS, in the experimental therapeutic branch, and I work with Dr. Tom Chase. And now, here we are today. Rainer Maria Rilke said, "Gratitude is more a state of being than an expression in words." I'm having a hard time to put in my gratitude in words. But hope you know how much I appreciate the generosity, the support, and the kindness you have shown me throughout my career. If my life fits into a small space, my memories need Michelangelo and the Sistine Chapel to represent all the pieces of my professional life with you. And I will need Antonio Gaudí to fit inside of Sagrada Familia Cathedral all my love for patients and their families, the administrators, even the administrators, secretaries, nurses, technicians, colleagues, and my friends and my family. Juan, Alberto, Raquel, thank you again, and thank you for following the Vietnamese proverb. When eating fruit, remember to one who planted the tree. Thank you.
So we will start with the scientific sessions. Good morning again. So I will ask the speakers of this session to come to the table and sit with us. So this Lisi Flores, Agnès Pérez-Millan, Aina Comas, and Marie-Claude Potier, please come to the table and take a seat. So, estamos. No, we'll have one more. Okay. So again, my name is Raquel Sánchez-Valle. I will be co-chairing this session with Professor Bo Anses from the Washington University in St. Louis. I will start with some housekeeping notes. We have 3 types of sessions in this symposium. We have 8 scientific sessions, with 5 persons talking with 10 minutes talks, and with 40 minutes for discussion. At the end of the talks, the questions will be answered at the end in the general discussion time. We have also 1 flag talk session with 9 5-minute talks and a final panel discussion. We will also have finger food lunches outside in the patio, and coffee breaks to meet people, and in summary, plenty of time for discussion. So please join us discussing any type of issues you want to discuss with the speakers or with anyone in the room. So I will start with the first speaker. So Dr. Lisi Flores Aguilar will present adults with Down syndrome display blood-brain barrier damage at advanced stages of Alzheimer disease neuropathology. Please, Lisi.
Yeah. Can you put my... So I'm very happy to be here. I think this is going to be an amazing meeting, and I'm honored also to open the scientific sessions. But before doing that, I also want to tell you that I'm super happy of being in beautiful Barcelona, visiting family and friends, and that I hope that you have a great time. So I'll be telling you about a story that we have been writing in the HEAD lab, and it relates to the study to understanding whether people with Down syndrome have changes in their blood-brain barrier. So as we know, young people with Down syndrome have incipient Alzheimer's disease neuropathology, which is characterized by diffuse amyloid plaques and the presence of intraneuronal A-beta. And this develops to a full-blown AD pathology by age 40. And by their early 50s, they already present clinical symptoms associated to AD dementia. So people with Down syndrome are very special, And one of the factors that make them special is that they have a low frequency of common systemic vascular risk factors. So as you can see here, people with Down syndrome have a low percentage of atherosclerosis when compared to sporadic AD or neurotypical controls. And they have virtually no arteriosclerosis when compared also to sporadic AD and controls. Despite having this low frequency of some common systemic vascular risk factors, people with Down syndrome display severe cerebral amyloid angiopathy. And as you can see here, this is more severe in Down syndrome than in AD and controls. And Dr. Maria Carmona has also shown that people with Down syndrome and those with autosomal dominant Alzheimer's disease have more severe CAA than those with sporadic early onset Alzheimer's disease and the neurotypical population. Also, neuroimaging studies have shown that people with Down syndrome have increased vascular injury markers, and this has been done with data from ABCDS, but also from DAPNI, in studies led by Patrick Lau and Alexandre Vejonon. So they have shown that there is an increase in white matter hyperintensities, infarcts, enlarged perivascular spaces, and microbleeds. And importantly, the severity of these vascular injury markers increases with aging, but also with AD progression in this population. There's also increased neuroinflammation in people with Down syndrome, and this neuroinflammation varies in their lifespan and could also be contributing to the vascular profile that we observe in this population. So the presence of cerebrovascular pathology in Down syndrome suggests that the blood-brain barrier may be compromised in this population. And just to refresh you, the blood-brain barrier is composed by a monolayer of endothelial cells. And on top of these endothelial cells, we have the basement membrane. And sitting on the basement membrane, we have the pericytes. So these are the three components of the blood-brain barrier. We can have other cells, such as microglia, astroglia, and neurons, and when they are all together, it's commonly known as the neurovascular unit. So in the lab, we are trying to understand whether, we are trying to detect the onset of blood-brain barrier pathology in people with Down syndrome, but also to study its progression across the lifespan and across the AD continuum in this population. And for that, we have access to post-mortem brain tissue from young adults with Down syndrome that are at incipient stages of Alzheimer's disease neuropathology, but also we have post-mortem brain tissue of adults with Down syndrome that are at late stages of AD neuropathology. And as you know, we are a neuropathology lab, and one of my passions is looking at the brains under the microscope. So we are doing a lot of histological analysis, looking at the blood-brain barrier components. And we are also complementing our studies by doing some proteomic analysis using mass spectrometry in post-mortem brain tissue. And we are analyzing different brain regions. So today, I'll be sharing with you what we have seen in the occipital cortex of adults with Down syndrome at advanced stages of Alzheimer's disease neuropathology compared to neurotypical controls. So what we did was to stain blood-brain barrier components. So we are looking at blood vessels, pericytes, basement membrane, but we are also looking at blood proteins that are leaking into the brain as an indicator of blood-brain barrier breakdown. We stain the brain sections, and then we image lamina 3 and lamina 4 of the occipital cortex, and we quantify pericyte number, the coverage of collagen 4, which is a component of the basement membrane. We also looked at fibrin extravasation, which is normally present in the blood, so its presence in the brain indicates blood-brain barrier breakdown. And we also analyzed the blood vessels, and we looked at the area fraction, length, and tortuosity. And the majority of the stainings were done by Annie Du, which is a very talented research assistant in the lab. So we started by looking at the blood vessels. As you can see here, we have a control and a Down syndrome with Alzheimer's disease case. And maybe you are already noticing some differences. And we observed that there is an increase in the vessel area fraction in Down syndrome with Alzheimer's disease as compared to neurotypical controls. And we also observe an increase in the length of the vessels. We were also interested in knowing whether the vessels were showing some morphological alterations, and we looked at tortuosity. So in neurodegenerative diseases and other diseases with a vascular component, the vessels become tortuous, meaning that they become loopy or twisted, as you can see in this image. So we quantified the tortuosity index, and we did not find any differences between controls and Down syndrome. Then we looked at the basement membranes, so we looked at collagen 4 coverage, and we found that there is an increase in Down syndrome at advanced stages of Alzheimer's disease compared to controls. And this is probably related to the fact that we also see an increase in vessel area fraction and also an increase in the length of the vessels. We quantified the number of pericytes, and we found an increase in people with Down syndrome and Alzheimer's disease compared to controls. However, when we normalize the pericyte number to the collagen 4 covered area, we did not find any differences between groups, which suggests that the pericyte to vessel ratio is maintained in Down syndrome. When I was analyzing the collagen immunostainings, I noticed the occurrence of these thin structures, collagen 4 positive, and in the literature they have been regarded as string vessels, collapsed capillaries, or basement membrane structures. And as you can see here, we also found that pericytes are being trapped in these basement membrane structures. And we wanted to know whether there were endothelial cells also present in these string vessels. So we did a triple staining. We stained collagen 4 in red, as you can see here, lectin, which will stain the vessels, and PDGFR-beta, which is a pericyte marker. So the stars are highlighting these basement membrane structures, these thin structures, and as you can see, we do not have any colocalization between collagen 4 and lectin, which means that these basement membrane structures are mainly composed of basement membrane. And we are investigating more about this. However, we did find that there is an increase of these string vessels or collapsed capillaries in people with Down syndrome versus controls. So now I've showed you, all the data that I have shown you has been quantified in lamina 3 and 4 of the occipital cortex. So now we have acquired a software that will allow us to do digital pathology, and we are using artificial intelligence to train the algorithms to recognize the same measures that I already presented, and we will be able to analyze the whole brain sections. So stay tuned. And to finalize, I already presented data on vessels, pericytes, and the basement membrane, and I am missing fibrin. So fibrin is a component of the coagulation cascade, and its presence in the brain indicates blood-brain barrier breakdown. So we stained against fibrin, and here I'm showing you what we observe in the controls. So we do have some signal in some cases. Here's the age, but some of them are pretty clean. However, when we look at the Down syndrome brains, we observe that there is a severe deposition of fibrin. And we quantify this, and we corroborated that indeed there is an increased fibrin deposition, meaning that the blood-brain barrier is broken at these very late stages of Alzheimer's disease neuropathology in Down syndrome. So the message that I want you to take home is that the brains of adults with Down syndrome at advanced stages of Alzheimer's disease are going through a vascular remodeling process that we still are figuring out what does this mean, but also the presence of fibrin deposition in the brain parenchyma of people with Down syndrome indicates that at very late stages of Alzheimer's disease, the blood-brain barrier has been compromised in this population. So future directions include analyzing brains from younger individuals with Down syndrome, analyzing other brain regions, and comparing also our results to what we will get when we analyze brains from sporadic AD, and if possible, we want also to analyze brains from autosomal dominant Alzheimer's disease. And Yeah, so I would like to thank my amazing mentor, Dr. Elizabeth Head. She couldn't be here today, but she sends her regards. All the Head lab, the repository team, our collaborators, our lab assistants too, and the funding agencies, and last but not least, all the tissue donors. Thank you, and I hope that you have a great conference.
So thank you, Lisi. That was a great talk. Our next speaker is Dr. Agnès Pérez-Millan, and she'll be talking about galectin-3 is upregulated and correlated with MRI findings in ADAD and genetic frontotemporal dementia. Thank you.
Thank you so much for the introduction. I think that's like... yeah, sorry. I will thank you for the talk and the introduction. I will talk about galectin-3, that we find that it's upregulated in Alzheimer disease and frontotemporal dementia. Galectin-3 is a molecule involved in microglial activation in neurodegenerative diseases, and it's mainly expressed by microglial cells is associated with neurodegeneration. Reactive microglial cells surrounding A-beta plaques are a pathologic hallmark for Alzheimer disease. And in the figure, you can see that the galectin-3, that maybe it's not well known as A-beta plaques, are shown in green, and the A-beta plaques are in red. And we found that the galectin-3 is close to the A-beta plaques. Galectin-3 plays a role in microglial activation, showing an inflammatory response in Alzheimer disease. And galectin-3 is associated with marks of AD pathology progression and cognitive decline in CSF. In a previous study of Hoyo Soriano et al. 2022, where our group collaborated, they studied galectin-3 in Alzheimer disease. They used the galectin-3 levels in brain tissues to study if they can differentiate between healthy controls. And they found that genetic AD, differentiate their levels of galectin-3 in healthy controls. Then they studied if the galectin-3 levels in CSF could differentiate healthy controls and Alzheimer disease. And again, they found significant differences between the galectin-3 levels in these two groups. After this work, we thought that maybe we can study the galectin-3 levels in genetic frontotemporal dementia, because some of their works find that microglial activation could predict FTD cognitive decline and help the diagnosis of different FTD subtypes or FTD genes. So we developed the work that has been recently published of Borrego, Ecija, Pérez-Millan et al. This year, and we found that the brain tissue galectin-3 levels could not also differentiate the different genetic mutations, that some of them, the granulin and MAPAD carriers, are upregulated against healthy controls and C9 mutation. So then we thought that the previous work also worked with CSF. So we studied the galectin-3 levels in CSF. And we found that MAPAD carriers are upregulated against healthy controls, C9 carriers, granulin carriers, and also in that same cohort we have some asymptomatic MAPAD carriers. So also we included. And we found that galectin-3 levels of MAPAD are upregulated and also differentiate between all the groups, including the asymptomatic carriers. So we have two studies and others multiple studies, but we don't study both Alzheimer disease and frontotemporal dementia together. So we thought that maybe it could be very interesting to study the autosomal dominant Alzheimer disease and genetic frontotemporal dementia together, because some of the difference of galectin level could explain some key answers. So the aims of this work was to compare galectin-3 levels in post-mortem cortical brain tissue and in vivo fluids, serum and CSF, in a cohort of autosomal dominant Alzheimer disease and genetic FTD. So we include, in some cases, asymptomatic mutation carriers and the symptomatic mutation carriers. And then, another key of the multiple studies in the literature is that galectin-3 level is an inflammation marker. But we don't study the correlation between galectin-3 levels and MRI. And maybe we should study, because if it's an inflammatory biomarker, it could be a high association with MRI results. So the second aim of this study was to study the association of galectin-3 level with cortical thickness, as we have found that in the cortical we have a presence of galectin-3 level. So for doing this study, we have 3 subcohorts: a cohort of brain tissue in post-mortem, that is from Neurological Tissue Bank Hospital Clinic IDBABS. So in that cohort, we have, of course, all symptomatic. So we have 9 ED-AD, then we have 8 C9, 5 granulin and 5 MAPAT carriers, and 10 healthy controls. Then, from the Alzheimer disease and other cognitive disorders group, from the Picogen cohort, that in other talks I think that they will explain better, we have a serum and CSF galectin-3 levels. So for the serum cohort, we have only in the ED-AD symptomatic carriers. Then we have genetic FTD, again the same participants of the previous study, C9, granulin, MAPAT, symptomatic and asymptomatic, and healthy control. And for the CSF, in this case, we have, in the case of AD-AD, symptomatic and asymptomatic. So we can explain better the AD-AD association. So the methods for the study was that specific human galectin-3 levels, ELISA, were measured in proteins extracted from post-mortem cortical brain tissue, CSF, and serum. And then in the case of the post-mortem, galectin-3 levels were analyzed with a classical GALIS, then when we had it. And in the case of CSF and serum, we analyzed with permutation test, as in the sample, we present some difference in age. Some of these participants, almost all of them, have MRI scans. So we proceed first with the free surface to obtain the cortical thickness, and then we explore the correlation between galectin-3 levels and cortical thickness. All the analyses were correct for multiple comparisons, groups, or regions. So the first results of the study was the cortical brain tissue galectin-3. Here we found we replicate previous findings, but the new thing is that we study all together. And we find again that MAPAT and granulin mutation carriers were upregulated, and that AD-AD is upregulated also. The interesting point here is that we can differentiate all the groups between the healthy controls and the C9 mutation carriers because it's down upregulated. But the interesting point is that genetic FTD, it's more upregulated than AD-AD, that the other studies could not study this. Then we measure the galectin-3 levels in serum, that we don't find any difference, that it's the same thing that we find in previous studies. But with CSF galectin-3 levels, we found, again, an upregulated increase of symptomatic MAPAT mutation carriers. Also, we find that these galectin-3 levels symptomatic mutation carriers could differentiate between all the groups, including the symptomatic, and we know that the symptomatic AD-AD is a little bit upregulated compared to asymptomatic, although it was not significant. Finally, we studied the correlation as we find that it was an interesting point with MRI. In this case, we study with all the groups, and we find that only the asymptomatic participants of the study found significant correlations with galectin-3 levels in CSF. In the case of the asymptomatic AD, temporal lateral and frontal posterior regions present a high correlation and positive, so more galectin-3 levels in CSF have more cortical thickness. And the parietal region, it was a negative correlation. In the case of the asymptomatic MAPAD carriers, we found also high correlations, and in that case was the frontal areas. And again, more galectin-3 levels, that we have to remember that it's an inflammatory biomarker, present more cortical thickness. So the conclusions of the study is that AD and genetic frontotemporal carriers present upregulated galectin-3 levels in postmortem and cortical brain tissue. Then fluid galectin-3 levels, especially CSF, present some differences in symptomatic MAPAD that it's upregulated. And galectin-3 levels in asymptomatic AD and asymptomatic MAPAD are associated with increase of cortical thickness, that this presumably reflects an inflammatory phenomena of these participants. So the overall of this study, or the take-home message of them, is that this study in AD and genetic FTD underscores the potential relevance of microglial activation via galectin-3 in both AD and FTD, and in this study in the genetic expressions of them. And thank you so much to the audience for listening, and a special thank you to some principal co-authors, my mentor, Raquel Sánchez del Valle, and also our collaborator, Antonio Boza Serrano, that from Sevilla, that helps a lot with the galectin-3 levels, and Dr. Sergio Borrego Ecija.
Yes, another housekeeping note. Both the moderators and the speakers for each session should go to the end of the room to have a microphone to participate in the discussion. So the next speaker is Aina Comas Albertí. She will present the talk entitled Gallblood Differentially Expressed Genes in Mutation Carriers of Autosomal Dominant Alzheimer Disease.
Thank you for the introduction, and good morning, everyone. I'm going to talk about my master's thesis, which I carried out during last year. Taking a look at recent literature, the research of AD regarding the gene expression and mRNA has been mainly focused on tissues different from blood, mainly in brain and immune system cells. Nevertheless, some studies have tried to identify a transcriptomic pattern in the peripheral blood that could be used for the diagnosis of AD. But these expression blood studies are usually focused on sporadic AD and not on AD, which we are going to focus on. It is a growing evidence that blood can mirror the physiopathological mechanisms of AD. Promising tissue for study the disease mechanisms, etiology, biomarkers, and therapeutic targets. And moreover, it presents some advantages respect from other tissues. The brain tissue tends to report the later stages of the disease, while blood allows us to gather information throughout all the disease course. Another reason is that blood sampling is much less invasive than, for example, CSF. As it is more accessible, and repetitive samples can be easily taken if it's necessary. Another factor is that there is a lack of lymphoblastoid cell lines availability, and that's why we will need to find neoprognostic or diagnostic biomarkers in blood. The main objectives of my work have been to discover expression differences of several candidate genes in whole blood of patients with autosomal dominant Alzheimer's disease and presymptomatic AVAVs versus the healthy controls with a method that is the qPCR. Another objective has been to explore the pathophysiological mechanisms and the potential new therapeutic targets which can contribute to better understand the AVAV. To select the genes to study in blood, we based on the results of a microarray expression study published by the group last year. They compared the expression in brain and in lymphoblastoid cell lines from autosomal dominant Alzheimer's disease. And we get 14 genes that are common differentially expressed in both tissues. So we are going to focus on these ones. However, we decided to exclude 5 of these genes, 2 of them because they didn't have a qPCR assay, and 3 of them because we performed a preliminary qPCR test and they revealed no expression in blood. So we kept with 9 genes. Additionally, we decided to include 3 more genes that are important to AD pathophysiology to study them in blood as well. Here there are the main characteristics of the cohort. We had a final cohort of 69 patients, in which 32 were healthy controls, 18 were presymptomatic mutation carriers, and 19 were symptomatic mutation carriers. The experimental protocol followed was to first extract the RNA from whole blood, then perform the reverse transcription, and then the qPCR using the Tuckman array cards. We finally obtained expression data, which was analyzed by the double delta CT method using 3 housekeeping genes. And then we obtained the relative expression data, which we performed a permutation test to see if there were differences between the groups. Then we performed a correlation analysis with years since the symptom onset, or the estimated years to symptom onset, and the relative expression of each gene. And finally, we performed a cluster analysis. So let's move on to the results. Here in these graphs, we can see the group comparisons of the expression between the healthy controls and the mutation carriers, which are the presymptomatic and symptomatic individuals combined. So we can see that the genes TMEM184B, SCARNA2, presenilin-1, and APP were all downregulated in the mutation carriers group when we compared to healthy controls. And on the other hand, the genes MAPT and FXYD5 were upregulated in the mutations carriers group. We performed another type of comparison, this time separating the presymptomatic mutation carrier, the symptomatic mutation carrier, and the healthy control. And the significative genes were almost the same as in the other comparison, except for APP1, which significance disappeared, and the genes FMRA1 and PRR3 appeared significative. Surprisingly, there were 5 genes downregulated only in the presymptomatics group with respect to controls, but not in the symptomatic group. And then the MAPT and FXYD5 were both upregulated in both presymptomatic mutation carrier, symptomatic mutation carrier, respect to controls. We decided to perform a cluster analysis to see if there was a natural group classification just using the expression data without the need to predefine any groups. And the main result was a pretty good classification of the presymptomatic group, as the clustering analysis classified more than the half of the presymptomatics onto the same cluster, which means that they share something in common. The percentages indicate the amount of individuals that fits in every cluster calculated within their own group. Regarding the correlation analysis, we obtained 2 significant genes, the RNA 2.1 and the PRR3, both negatively correlated with the years since onset in the symptomatics group and the relative expression. So, the more the years since the symptom onset, the less the expression of these genes there was. And unfortunately, no significant correlation were found in the presymptomatic group when we, between the years estimated to the symptom onset and the relative expression. So, based on the results of the previous microarray study and comparing it with what we have obtained now in blood, we can see this summary table where I have included most significant genes from both studies. And we can see that the only gene that follows the same direction of the expression is the FXYD5, which is upregulated in all 3 tissues. Unfortunately, no similar literature was found, so our study would be the first one to describe the relative expression of these genes in whole blood of autosomal dominant Alzheimer's disease and presymptomatic AD-AD2. Nonetheless, the controversial discrepancies that we have seen in the expression of these genes in both studies may be due to 3 different factors. First of all, the type of tissue studied, as the genes may not express in the same way in the brain as in whole blood as in LCLs. The second would be the different stages of the disease that have been taken into account, as the microarray study just included the symptomatic AD-AD, and our study included also the presymptomatic AD-AD. And finally, the different methodology can also influence the results, as it is not the same to perform the analysis of microarrays as in qPCR. Interestingly, the new gene with a more significant p-value is the TMEM184B, and is overexpressed in brain and in lymphocytes, but downregulated in blood. Analyzing the biological significance of this gene, unfortunately, it has not been seen that this gene is related to AD, but some studies indicate that this gene may be involved in some interesting biological pathways, such as neuromuscular junction morphology. It also promotes the degeneration of myelinated peripheral axons. It may be involved in the MAP kinase signaling pathway. The disruption of this gene also results into defects in acetylcholine receptor. And another study showed that mutant mice for this gene suggest impairments in autophagy that may lead to a protein accumulation and consequently neurodegenerative diseases. And finally, to conclude and give you a more general summary, we can say that the selected genes from microarrays have been useful to find relative expression differences in whole blood, especially in the presymptomatic mutation carrier of AD. The genes TMEM184B, presenilin-1, PRR3, FMRA1, and SCARNA2 are significantly downregulated in presymptomatic AD group. MAPT and FXYD5 are significantly upregulated in both presymptomatic and symptomatic AD. So, the significant genes should be further studied to improve our knowledge of pathophysiological mechanisms of AD and to be able to propose new therapeutical targets. Thank you for your attention.
Thank you, Aina. That was a great talk. Our next speaker is Marie-Claude Potier. She'll be talking of amyloid-beta peptide signature associated with cerebral amyloid angiopathy and familial Alzheimer's disease in APPdup and Down syndrome.
Well, first, I'd like to thank the organizer for allowing me to present my result here. So I will go. So I'm not going to spend a lot of time because Lisi already showed to you that Alzheimer's disease is mainly two different pathology, the amyloid deposit, which are seen in the parenchyma and in the blood vessels, and the neurofibrillary tangles. So this study started in 2018 when David Mann and André Stridon published this paper where they were looking at the patterns and severity of vascular amyloid in Alzheimer's disease associated with duplication, missense mutation in the APP gene, and Down syndrome compared to sporadic AD. And they found that the cerebral amyloid angiopathy score is the highest in APP duplication. In this study, they analyzed 4 cases with APP duplication coming from 2 families and with 3 cases from the same family. So what we wanted to do is to expand this study, studying larger cohorts and investigate in parallel the neuropathological phenotype, as well as compare brain A-beta peptide signature in the same cases using mass spectrometry. So thanks to a European grant that we got with the Paris Brain Institute in my team with UCL London and University Göteborg, with Henrik Zetterbeck, Frances Weissman and Lizzie Fisher, and André Stridon at KCL London. So first we did the neuropathological analysis of all the cases with APP duplication Down syndrome without and with Alzheimer's disease and compared to sporadic AD control and APP mutation. And this work was done in the neuropathological department of the Salpêtrière with Charles Duquertz, Susanna Boluda, Lev Stimmer, and Amel Kasri. So this is the demographic details of the sample that we analyzed thanks to 7 different European brain banks. So we had access to 17 control, 12 sporadic AD, APP mutation. We had cases, mainly we analyzed cases with mutation at the valin 717, and then 7 cases with APPdup and 13 with Down syndrome without or with Alzheimer's disease. So we first analyzed A-beta in the parenchyma, in the blood vessel, using C6-3D antibodies. And what we found is that A-beta deposits are numerous in the parenchyma, in sporadic AD, Down syndrome with AD, less in APP duplication. In APP with mutation, it's high also, and less in Down syndrome without AD. In the arteries and in the blood vessels and in the capillaries, we had mainly deposit in Down syndrome with AD and in APPdup, but much less in sporadic AD and APP mutation and in Down syndrome. And for the capillaries, we could see here the quantification, mainly in APP duplication and Down syndrome with AD. For the tau pathology, we used the 88 antibody, and we found that tau accumulates in all cases with dementia. And Down syndrome with AD saw the highest score for p-tau, neuritic plaques, and neurofibrillary tangle, as you can see here. Oops. So then we wanted to look whether the size of the duplication in all the families was correlated with the neuropathological feature that we could identify. So you see here the list of the 7 cases of APP duplication coming from 6 different families, and the size of the segment which is duplicated. And if you look here at the neuropathological feature, we could not see much differences, and the biggest duplication, which is case number 4 and 6, did not show major differences in the features, indicating that APP duplication alone is responsible for the neuropathological feature that we could identify. For the DSAD cases, we saw some differences between cases, mainly in the amount of A-beta in the wall of arteries and arteriole, as well as in the capillaries. So although APP duplication and DS have 3 copies of the APP gene, A-beta deposit appear different, suggesting that some other genes from chromosome 21 could be involved. Then we compared the A-beta peptide signature, and this was done in the lab of Henrik Zetterberg and Jörg Honrieder, with Elena Camporesi, Gunnar Brinkmann, and Elenix Nasju. And this is the list. I'm not going to show the MALDI analysis, but just the LC-MS analysis. This is the list of the peptide that we could analyze, A-beta peptides. And we analyzed the soluble fraction and the insoluble fraction in the formic acid extraction. So what we could find is that A-beta profiles are different in the soluble and the insoluble fraction, and mainly the difference is due to this pyroglutaminylated peptide at position 3 and 11 in the insoluble fraction, which are absent in the soluble fraction. This is the heat map of all the peptides in the insoluble fraction, starting at position 1 and going up to position 14. And I'm not going into details, of course, but what you can see by eye is that in the soluble fraction, the amount of A-beta peptide is higher in APPdup and Down syndrome with AD. And the other interesting result is that if you compare in the insoluble fraction the APPdup and the DSAD, we see differences that we quantified, and you see here this quantification that indicate mainly 2 results. In the APPdup and DSAD, we have the highest level of A-beta 134, 138, 140, and this is quite similar between APPdup and Down syndrome with dementia, while APPdup have specific differences compared to DSAD, which are the level of the A-beta peptide, which are truncated at position 2, like 234, 238. The other interesting result is that the APPdup are enriched in these 2N peptide, and they have also very low A-beta X42 peptide and low pyroglu peptides compared to DSAD. We then tried to correlate the CAA histological scores with A-beta peptides, and you see here that the list of peptides that are positively correlated to CAA and negatively correlated to CAA. And this is here shown, where in the soluble fraction, these are the peptide 434, 418, 419, and 418 that are positively correlated with CA, while 142, 442, 130, and the paraglue are negatively correlated with CA. In the insoluble fraction, the figures are a bit different. We see a positive correlation with X 37, 38, 39, and 40, while X 42 and 43 and paraglue are negatively correlated with CA scores. And finally, what we did on homogenates could not differentiate between the parenchyma deposit and the blood vessel deposit. So we used the MALDI TOF MS imaging, thanks to the collaboration with Jörg Handrieder in Göteborg. And we analyzed one case with APP duplication, a cortical section, where we could see arterial arteries and also leptomeningeal vessel. And what these studies show that is that there are peptides like 140, 137, 139, 240 and 140 is here again, that are specific of leptomeningeal vessel and arteries and arterioles, while some other peptides are specific of parenchymal deposit, as you can see here. For example, of course, 1A-beta, beta 142 and 442. So there were differences, and we could identify those peptides that are really localizing on the blood vessels and not in the parenchyma. So the conclusions are the following. The ratio of A-beta deposit in parenchyma to blood vessel is about 2 in sporadic AD and APP mutation at the valine 717, while this ratio is inverted in DSAD and in APPdup. And in Down syndrome without AD, A-beta deposits are found only in the parenchyma. So this indicates that APP overexpression is a very strong genetic determinant of CAA, particularly in APP duplication compared to DS. And the second conclusion is that there should be protective mechanism in individuals with DS against A-beta deposition in blood vessel as compared to APPdup. The second result is that DSAD showed the highest score for p-tau, neuritic plaque, and neurofibrillary tangle, while scores are lower in APPdup, suggesting that there could be the involvement of additional mechanism beyond APP overexpression on tau pathology in DS. And one gene which is a candidate is the DIRC1A gene. And finally, the A-beta peptide in the soluble fraction are higher in DSAD and APPdup due to APP overexpression. And we found a specific signature of A-beta deposit in the blood vessel, which is the level of 137, 38, 39, 140, and their end-truncated forms. So the question now are the following. Are those specific peptides generated or degraded within the vascular unit? And could there be new biomarkers for CA in the CSF or plasma for inclusion in A-beta immunotherapy and follow-up of patients with Down syndrome and AD? And I will finish thanking the team members at the Paris-Brain Institute, at the University of Göteborg, KCL, UCL, Escurol Laboratory, the neuropathology department of the Salpêtrière, and of course, all the brain banks in Europe that have provided all the cases that we could analyze, and the funders that allowed this work. And I thank you for your attention.
So thank you very much, Marie-Claude, for the great talk. Now we have a pre-recorded talk. So Dr. Claudio Cuello from McGill University will present cool the status of the NGF metabolism predicts preclinical Alzheimer's pathology in Down syndrome. Yes, it should be.
Down syndrome and in consequence in Alzheimer as well. And this work has been possible through the collaboration with Dr. Carmo, Jorge Busilio, Juan Fortea, and Thomas Wisniewski. Nothing to disclose, and we'd like to start by stating some of the basic tenets of this discussion. One is that the basal forebrain cholinergic system plays, no doubt, a key role in cognition, and it is these neurons, which are the basal forebrain cholinergic neurons, are totally dependent on NGF for their trophism and the day-to-day maintenance of synapses in cortex and hippocampus. And number 4 here, should be that cholinergic losses is an early feature of the AD pathology. Now, it had been thought initially that there was a problem with NGF in Alzheimer disease planning that atrophy of cholinergic neurons. However, the biochemistry has shown that the synthesis of NGF in Alzheimer is normal, so the normal transcription of NGF, and the pro-NGF, the precursor of NGF, is elevated rather than the protein, the precursor protein, rather than being below normal conditions. And this and the fact that ELISAs at the time couldn't differentiate very well pro-NGF or NGF confused the issue, but we thought that the atrophy was dependent from other factors rather than the NGF support. So in short, the established decades-long dogma that NGF support is normal in the AD pathology is wrong. Secondly, while it's correct that synthesis is normal, there is a failure in the generation of the mature NGF. And thirdly, the high level of NGF precursor in AD pathology is not a good news. It is bad news. It reflects the failure of the conversion of pro-NGF into mature NGF. They could be clearly explained by the discovery of NGF metabolic pathway. This pathway is explained better
basal forebrain cholinergic neurons originating in the medial septum and nucleus spicialis are the only source of cholinergic input to the hippocampus and cerebral cortex. These inputs are critical for attention, learning, and memory, and are most vulnerable to the Alzheimer's pathology. In the cerebral cortex and hippocampus, cortical cholinergic terminations receive nerve growth factor, or NGF, from postsynaptic pyramidal neurons. This retrograde supply of NGF is essential for the maintenance of basal forebrain cholinergic neurons. Studies from our lab have shown that NGF is not directly secreted into the synaptic cleft. Rather, it is its precursor, pro-NGF, which is released from postsynaptic neurons. Pro-NGF is released alongside pro-proteins and convertases responsible for its maturation and degradation. These include plasminogen, tissue plasminogen activator, or TPA, neuroserpin, pro-MMP9, and TIMP1. Within the synaptic cleft, TPA converts plasminogen to the active enzyme plasmin. In turn, plasmin cleaves the NGF prodomain, generating mature NGF. This cascade is regulated by neuroserpin, which binds and inhibits TPA activity. Following cleavage, mature NGF dimerizes and binds presynaptic receptor complexes comprising TrkA and P75 neurotrophin receptors. The activated receptors are internalized and retrogradely transported to cholinergic cell bodies, where the NGF receptor complex ultimately exerts its trophic effects. Back in the synaptic cleft, matrix metalloproteinase 9, or MMP9, is derived from pro-MMP9, which is co-released with pro-NGF. MMP9 rapidly degrades the leftover mature NGF in the extracellular space a function tightly regulated by the metalloproteinase inhibitor TIMP1. In Alzheimer's disease, the NGF metabolic pathway is disrupted, resulting in increased levels of neuroserpin and the downregulation of TPA activity, thus blocking the conversion of plasminogen into plasmin. A reduction in plasmin levels impairs the conversion of pro-NGF to mature NGF, leading to the accumulation of pro-NGF and a reduction in available mature NGF. CNS inflammation also stimulates MMP9 activity, leading to enhanced degradation and depletion of mature NGF. Dysfunction of the NGF metabolic pathway disrupts the trophic support of basal forebrain cholinergic neurons, resulting in progressive atrophy of cholinergic synapses within the hippocampus and cortex. The resulting loss of critical cholinergic modulatory activity ultimately contributes to the cognitive impairments of Alzheimer's disease.
So this deregulation of the NGF metabolic pathway is also found in Down syndrome with individuals with dementia, and in a situation very similar to Alzheimer's pathology with clinical presentation, in that the synthesis of NGF remains normal. However, there is an impediment on the conversion of pro-NGF to mature NGF, and seen in number 2, there is an elevation of pro-NGF in cerebral cortex. And there is a correlation between the amyloid burden and the levels of accumulation of pro-NGF, which signifies impairment in the conversion to mature NGF trophic compound. Now, the deregulation of NGF metabolic pathway have been well documented by now by us and others, and explaining the atrophy of the NGF-dependent basal forebrain cholinergic neurons. The point is that thus the NGF metabolic deregulation precedes clinical Alzheimer, clinical presentation of Alzheimer. And it saw good is levels of pro-NGF and other components of the pathway be predictors of the AD pathology at preclinical stages, and therefore a compromise of the cholinergic system. And this is a very likely situation as Down syndrome. In particular, if we observe the growth, the delta, the change of pro-NGF levels from the year 0 to year 1 in one-to-one analysis, and compare with the delta of the cognition at the second year or the following year, and there is a beautiful correlation on these parameters. In short, the compromise of the pathway that will signal an evolving loss of cognitive capabilities. We have extended this type of studies in the religious order study of brain, postmortem brain, extraordinary brain, thanks to the support of David Bennett, and we split the component of the non-cognitive impaired brains from no amyloid or not sufficient amyloid pathology, and those circled here in red with brains displaying amyloid pathology between 2 standard deviations of the average of the Alzheimer's brain. And if you do that and investigate the pathway, there is a non-cognitive impaired, a normal level of pro-NGF, but an elevation, considerable elevation of pro-NGF in individuals who are within the normal range of cognition, and however, differentially, even cognitively, let's play here, and likewise a loss of significant depletion of mature NGF, the neurotrophic active material. And this relates to the level of cognition as well. And furthermore, this is accompanied also with progressive loss of vesicular acetylcholine transporter in the brain, which will be an indication of lack of trophic support of cholinergic neuron. And there is a correlation between the levels of PROGF and the depletion of vesicular acetylcholine transporter. And could this give grounds to study the NGF PROGF levels in blood and CSF to investigate preclinical stages of Alzheimer? And the answer is that it's possible, even with very primitive methods present with Western blot. We are presently working on ELISAs, but to be able to be investigated anywhere. And that we see in Down syndrome, both in plasma and CSF, obviously more clearly in CSF, a good correlation between the clinical state, that is control, Down syndrome's preclinical AD elevation, and clinical AD further elevation of PROGF. The behavior under the curve is quite similar to that of the beta markers and tau levels in blood and CSF. To close, these studies will indicate there is already at a depletion of the NGF pathway, the preclinical stages, and before mild cognitive impairment. And this beautifully corresponds to have been in the sporadic analysis of the structural MRI for the areas where are lodged the four brain cholinergic neurons, and more recently a beautiful collaboration of Rosalena Laja and the Barcelona group showing the same in Down syndrome. And in short, thank you for listening this aspect of this contribution, this question. In yellow, all the people who play a fundamental role on this investigation. Thank you very much.
So thank you to Professor Claudio Cuello. I think that due to the time difference, he could not join us for the discussion. But now the session is open for discussion. Should be a micro somewhere in this level and also in the upper level. So we need 2 mics. So please ask the questions or comments you want to any of the speakers. Here.
Thank you. Lisi, this is a question for you. You described the blood vessels as being broken in Down syndrome, particularly in the later stages of AD. How would you compare and contrast that to sporadic AD and autosomal dominant AD?
So, can you hear me? Well, yeah. So, to sporadic AD, there are some studies showing that there is a decrease in blood vessels, but there's also other studies showing an increase. So, I think the field is divided, and it's mainly because of the methods they have used. More recent studies have shown that there is aberrant angiogenesis. So, and our findings, what we have observed, it's the same as a recent published study in a sporadic AD. In autosomal dominant Alzheimer's disease, I'm not sure what's going on, and I don't think someone has really looked at this. But if someone knows, please let me know. I don't want to lie here.
So to summarize, you would say that there are similarities.
Yeah, they are.
When you describe them as being broken, it's what you observe in other forms of AD.
Yes.
Thank you.
Yeah.
And Lucy, I have a similar question. We have this challenge of what's the appropriate control group in Down syndrome. So I'm So similar to what Mike is saying is the best group 45 to 65-year-olds, or is the better group, more older? I won't say elderly because that would be me. So older people. How do you think about that when you choose your control group?
Yeah. So we do have a 45 to 65-year-old control group, but we also have older adults. So we will be comparing them to both. And it's always not a problem, but something that we need to consider when we are studying Down syndrome, because they do age faster. So it's always good to have these two different ages to compare with.
In ABCDS, we also have a group of sibling controls.
Yeah.
So at least you have some common genetic connections here. So that might be an interesting group to look at, too.
Yeah.
So my question was about galectin, and I was wondering if you could maybe comment a little bit about why the granulin differences are so stark between brain and CSF, in the granulin carriers, compared to the MAP-tau carriers for that particular protein. What do you think's going on there with discrepancy?
Very good question. I think that we need to explore better in that case. I think that we don't have a final conclusion about what happens, but I think that we are starting a new study with these two mutations in longitudinally to try to find what happens and why these differences are about. So I'm so sorry. Now I think that we don't have a clear hypothesis, and we continue studying this to try to explain it.
Another question for Lisi. I'm just interested in how the impact of the leaky blood-brain barrier may have. It's a question about drug delivery, whether it would increase the amount of drug going across the blood-brain barrier. And I wonder if you could speculate.
That's a very good question. I don't have a very good answer to that. But I don't know if you want to deliver a drug into a system that has already been compromised. I don't know if this has been shown in mouse models, but you also have a lot of CAA, so I don't know if the drug will go through that. But I also think that at these very late stages of Alzheimer's disease in people with Down syndrome, it's not a good idea to deliver a drug, because the system is already very impaired.
I have a question for Marie-Claude. Great presentation. Many of us have been thinking about these questions of amyloid angiopathy, and you had two groups, DS and DSAD, and I think the average age for DSAD was 56, and you showed that there was no parenchymal A-beta, or there was only parenchymal A-beta in the 50-year-olds, and mostly parenchymal and vascular in the 56-year-olds. And the question is, does that seem consistent with what Lisi's presentation was in comparing to autosomal dominant forms of AD, such as APP duplication? Do you think that there's a more focality to blood vessel-based amyloid in that population as they get older?
Yes, thanks for the question, Mike. So you could also see that the age of the APP duplication cases and the DSAD were about the same. So what is striking is that this was a question I was going to ask to Lisi, because in DSAD, the vascular system is remodeled in a way. So could this amyloid angiopathy, which we see higher in DSAD as compared to DS, could be due to the fact that there are more vessels around and then more deposits? That would be simple. But then we have not looked, and this is something we have been discussing, looking at the APP duplication labeling of the blood vessel, because maybe it's the same. And then it would mean that APP overexpression, in a way, could be angiogenic factor, or whatever we could call it. But this is something we should really look, because it's quite important to know whether the vascular system is really affected and that influence the angiopathy, or whether it's the other way around, maybe. Yeah.
So is it an overproduction of APP that leads first to plaque formation and then the blood vessel deposition, or is there actually this speciation where A-beta 1 to 40 predominantly goes into the blood vessels, and that's not as often seen?
Yes, that's a very good question again. So I have some hypotheses, but we have not fully demonstrated. So it comes from the fact that in Down syndrome, we don't really see a vascular deposit, but we have not looked in some specific region of the brain where CA is most prominent and appeared first. But definitely, there are regions in Down syndrome without AD that have A-beta deposit in the parenchyma and not in the blood vessel. So it's not like a tight correlation. The fact that you have in the parenchyma, you have in the blood vessels. But usually you don't have in the blood vessel without having in the parenchyma, although in APP duplication cases, it's very low in the parenchyma. So it's still not very clear, but what we can really demonstrate here is that the APP overexpression is a factor that increases CA. So whether it's A-beta in the parenchyma on the way to clearance that deposits there, or is it produced in the vascular unit, we don't know. But because we see different A-beta peptides, it suggests that either these different peptides are produced there, or they are degraded, like the truncated at the N terminus. They could be degraded by other cells from the vascular unit, and the astrocyte could be one candidate because they have the enzyme that cut at position 2, the A-beta peptide. So it's still not complete, of course, but we have some hypotheses, and we need to go further and compare this study of the vascular system. I think it's very important.
Maybe there's some people online that has questions. In case they have questions, please ask the question in the chat, and we'll read it.
While we're waiting, one of the questions to you, Marie-Claude, but also to all of our speakers, you were talking about this parenchymal changes, but some of the earliest changes we see are in these subcortical structures. And questions to you, to Lisi, to others are, is there a breakdown in the blood-brain barrier? Are there changes within these subcortical areas? Because this is something that's very different that we see in autosomal dominant as well as in Down syndrome compared to late-onset Alzheimer's disease. Mm-hmm. So I don't know if people have...
Yeah. So, in fact, we had a question from one of the reviewers of the paper that we submitted, and we are trying to look at the possible microbleeds that we could see on the brain slices. So these experiments are ongoing, okay. But nothing was really obvious. But we are doing some specific labeling now. Yeah. For the APPdup cases, there were a very nice paper from the group from Rouen who has described first this APP duplication. And they have done MRI in a cohort of this APP, living people with APP duplication. And they showed that not all of them, but most have microbleeds and leakage of the blood-brain barrier. And this is mostly correlated to CAA. So it's probably correlated, but what comes first is not completely clear. Yeah.
So just to follow up on that point, I wasn't sure, was the APP mutation you were studying the Dutch mutation?
No, it's mainly the London mutation. It's at the Valin 717.
I see.
So it's London and another, it's another two type of mutation at the same position. But we did not study, you are right, we could have included the Dutch mutation, but here we really wanted to compare the APP duplication, which are known to give massive hemorrhagia and problem in the people with this type of mutation. So the comparison with the APP mutation at the Valin 717 is probably more because we went through the UK brain bank, and that was the cases that we studied the most. But they are not the cases with severe cerebral amyloid-angiopathy. Yeah.
Right. In those cases, there is not overexpression of APP.
No,
right?
no, not that we know. Yeah. Mm-hmm. But there is a difference in the ratio of A-beta 42 and 40. Yeah. I have a question for Lisi, if I may. Ah, sorry.
Yeah, please. Yes, please.
Okay. So, Lisi, I was looking at your images with the fibrinogen labeling. Do you think there is a co-localization of fibrinogen with the A-beta deposits?
Yeah, we have seen that.
Okay.
Yeah,
mainly or all?
Yeah, mostly all the plaques are co-localizing with fibrin, and we have also seen fibrin byproducts inside neurons and astroglia, but not in microglia.
Yeah. And I had a question on galectin-3. Is it produced by the neuronal cells or by the macroglia, or by which type of cells?
For the macroglial cells. Okay. Yeah.
Yes. So it's the activation of the macroglia that changed the production of galectin, or the other way around?
In the first way, correct, I think.
Thanks.
Yeah. Thank you. Very nice presentations. This is a question for Lisi and Marie-Claude. You both talked about vascular pathology, and I was wondering, beyond neuroimaging, could you comment on any advances at the fluid biomarker level to track these pathologies?
So we are collaborating with Dr. Donna Wilcock, and we are going to start looking at biomarkers. We are starting like in the next month, so I can update you later. But yeah, we are interested in looking in some biomarkers.
Yes, and on our side, of course, and because it's kind of an issue at the moment with the clinical trial, so what we are trying to do is to produce antibodies against some of the specific species that we see in the blood vessels. So it's a project that is ongoing, that has been financed by the CURE-ND, which is a collaboration with the Paris Brain Institute, UCL in London, and KCL, and so on. So we are trying to produce these specific antibodies. There were in the past antibodies against the 2N peptides that was made by Thomas Bayer, but it was a polyclonal, so probably not very specific. It tends to be quite challenging, but we are trying. Yeah. The other option would be to do some targeted mass spectrometry in the plasma. Yeah.
I have also a question for Lisi and Marie-Claude. So based on your findings, do you predict a different percentage of area in patients, in subjects with Down syndrome treated with anti-amyloid, the different type or different percentage or whatever?
Yeah, I mean, they have severe CAA, so I would predict that they will have more area.
Most of the area E, area H, both of them. What do you?
I don't know.
You don't know. Marie-Claude?
I mean, I would give the same answer as Lisi, but I mean, again, they have, as we were showing, they have more CA. We also showed that they have less than in APP duplication. So there is something we should look also in the Down syndrome individual, because they must have protective factor against CA. although they must have protective factors. So it's something that is counterintuitive in a way. So I would expect, because they have more CA, they are more prone to have problem with hemorrhagia, but I think they will need to be followed. And I know that from Natalie Ryan, who is in the room, that they are trying to set up new imaging techniques to look quickly in those people. Yeah.
I know we will discuss this issue in another session, but I don't know if someone in the room have some opinion about that, about the potential percentage of ARIA in Down syndrome compared to sporadic AD.
Maybe André or
Juan.
Ron.
No, I think that the jury is still out. We don't know. Certainly there is more CAA, that's for sure. But as Marie-Claude was saying, there are data to suggest that maybe they are more protected against hemorrhages. So that we don't know. And I think that the data that we have from the autosomal dominant AD is kind of encouraging. So the trial, although it was negative, the gantenerumab trial, did not substantiate the concerns about the safety data that could be a problem in autosomal dominant AD. Of course, we are lacking that data in DS, and we certainly need to monitor it closely. But we're here in a very difficult situation because, and this will be the topic of a debate or one of the tables, no? The situation we are in, because we desperately need data. Of course, we want it, and we have an ideal situation of the data we would like to, but the attitudes or even the regulatory, not the regulatory agencies, but the recommended use recommendations for the treatments in autosomal dominant AD and DSAD diverge completely, and the theoretical risk is similar. So I think this is food for thought, and I think one of the things that we will discuss in depth. So yeah, we need data, and we really need research to be done here.
But I think what is quite remarkable, although our study is still limited, but in the cases with Down syndrome without AD, as we showed, we could see A-beta deposits in the parenchyma, but not in the blood vessel. So again, it suggests that if we can start treatment before the appearance of the CAA, then you know,
would be
it
more
would be less risky. Of course,
yes,
we
more safe.
Always have to see like 10, 15 years ahead, which in a way is difficult to set up because they are younger, but it would probably kind of improve this risk of CAA and ARIA in those people. Yeah.
Okay.
Yeah, to follow up on what Juan said, so for the autosomal dominant trial, the rate of ARIA was the same as we see in sporadic. It was driven by the same factors. That it was primarily driven by people having E4 rather than just kind of the overall risk for ADAD. And then also, although the overall rates of ARIA were the same, the actual extent of the ARIA was reduced relative to what we see in sporadic, suggesting partially because I think being at the younger age, although things like CAA are up, their overall vascular health was actually better, so that the extent of the ARIA was smaller.
More questions?
I have one for Aina. So I saw that you have down regulation of genes in pre-symptomatic AD, but then some of these genes go up. Do you know why?
Yeah, that's the key point of our study. We are trying to get with a biological coherent explanation. We think that maybe there are some genes that are dysregulated in the earliest phases of the disease, and then these genes go to normal expression levels. That's why the symptomatic group and the control group would be so similar between them. But as there are no literature about these new genes, we have discovered this expression. It's so difficult to try to get to a biological explanation without knowing anything about these genes. But this is the key point that we are going to investigate further.
Have you, in your plans, are you considering looking at protein levels?
Yeah, we were thinking about looking at protein levels of these new genes, but first of all, what we want to do is to try to validate the results of the qPCR with tag records with manual single assays of the principal genes that were the TMEM, presenilin-1, and FXYD5. To really see if if they are only overexpressed or underexpressed in the presymptomatic group. And then, if the results validate, yes, we would consider to maybe perform Western blot or some ELISA protein expression analysis, because these genes are could be so interesting to discover the expression of the autosomal dominant Alzheimer's disease. Yeah.
Thank you.
Thanks.
I have a question for Agnès. So the galectin-3, did you measure in Down syndrome and Down syndrome?
No, we don't measure in Down syndrome, but it could be very interesting because it could explain another things. For the moment, we only measure in Alzheimer disease, the sporadic and the genetic, and FTD genetic, and in some studies, it begins, all the galectin-3 begins in mouses, and they move to Parkinson, and then Alzheimer's disease, and then frontotemporal genetics. So the next step, it could be in Down.
So do you think it could be a differential biomarkers for FTD with a tau mutation?
In the previous study of FTD, we also divide in different tau or not tau, and we find also differences and in the different subtypes of FTD also. So I think that, yes, it could be there a difference.
But to differentiate between Alzheimer and FTD with tau mutation?
No, here we don't look at that. I think that it could be next step, but in the previous study of only FTD, we checked that point.
Yes. And then I had a question for Aina. Did I get it right when you showed that the difference in APP levels were not significant when you differentiated the asymptomatic and the symptomatic?
Yes,
okay.
You get
so,
it right.
But there was no difference anymore? Or?
No, the APP significance of the relative expression, it was only when we compared the mutation carrier and the healthy controls. But we don't know why it disappeared when we spared the groups.
Yeah, variability.
Yeah, maybe, or the statistical analysis, maybe.
Okay, thank you.
Thank you for your wonderful talks. I have a question regarding galectin-3 to Agnès too. Did you have the opportunity to compare it to other markers of inflammation? I'm thinking of soluble TEM2, for instance, or YKL40.
If I'm not wrong at all, in the first paper I mentioned in the introduction, both Serrano et al. In 2022, they check against other inflammation biomarkers and then find high correlation. So I think that it's interesting, and it could be a new one or not, or it can be the first, and then it comes after, because first the anti-inflammatory and then the inflammatory phase.
Hi, no, this is just a reminder for those following the conference online that you can post the questions online and we will read them out loud. So far we haven't had any questions online, but please, for those that want to ask, do write them and we'll ask them to the speakers in this session and in all the sessions to come. Thank you.
I've got a just general comment for the group to discuss. Is it time we start thinking of these diseases as primary blood-brain barrier diseases driven by APP?
Yes, I mean we are doing some work right now on this topic, and we are analyzing iPSs and endothelial cells derived from iPSs as well as cerebral organoids in cases with APP duplication, and we compare to APP knockout. And we do see differences, and it's still too early to say anything, but there are differences induced by APP overexpression, at least in the endothelial cells that form the first layer, as Lisi was showing. So, so probably APP has a role in the structure of this vascular unit and the blood-brain barrier. Yeah.
I think that the question will be that the blood-brain barrier is rupture is a consequence of a cause of the disease. I don't know if there's. I don't have an opinion on that, but I don't know if you.
I mean, obviously, when you see cerebral angiopathy in the blood vessels, and you do see that the blood vessel is surrounded by this deposit, you think that at some point there should be a problem, which is the case, in fact. So we know that cerebral angiopathy is altering the blood-brain barrier. Whether the blood-brain barrier is altered before is still, to me, remains to be demonstrated. But
I think we will be able to partly answer that question when we look at younger brains. Yeah. So we'll be able to see if it's related to Alzheimer's disease neuropathology, CAA, or if it's also a consequence of the overexpression of genes in chromosome 21.
Yeah. But I don't know if there was work done in the APOE4 carrier. Whether I think there is the work of well-known work on the blood-brain barrier and APOE4.
Yeah, they are more susceptible.
Yes, exactly. Yeah. So we have to look at confounders when we analyze cases. Yeah. Mm-hmm.
Alberto.
Yeah, so thank you. I have a question for Marie-Claude Potier, but all the panel about autosomal dominant AD. So we have done many characterization of autosomal, like neuropathology of autosomal dominant cases here, and we described when we studied one of the E-variant mutation on APP. But we had the challenge that each mutation had different phenotypes depending on the residue, or even the same residue with different mutations in the same, had different mechanisms. So it's just a general comment how to deal with this, because the ratio 42 to 40 in each mutation may affect type of plaques, and even we had more diffuse or more compact. So it's just general thought when we study the phenotype as a group, combining sometimes APP or presenilins, how to deal. We had the challenge how to deal, what's the common theme across all these. It's just one thought.
Yeah. So I would think that for the APP mutation, of course, there are the mutation in the base one site and in the presilinin, the one which are in the transmembrane domain. But I guess the one that give the more vascular deposits are the one in the juxtamembrane domain of APP. And this is striking because they all are localized in the same domain. And you will hear a talk from a postdoc from my team tomorrow that suggests a couple of things with the interaction with cholesterol and so on. For the presenilin, I know less, but I would think for the APP mutation that the localization of the mutation should, in a way, indicate of course, the ratio, but also the amyloid angiopathy. Should predict in a way, and for the presenilin, I don't know if you have. Yeah.
No, but I'm wondering, does it really have an effect on the clinical phenotype, like these mutations?
In the age
all the mutations do not give the same phenotype, and I think there are people in the room, Lucia Chavez, who has been showing that. Of course, the type of mutation gives you a different set of peptides also. So it's, looking at something else than A-beta 38, 40, and 42, I think is very important, because we will learn every time we do mass spec on these different cases. We learn a lot of things. So I think we should continue. It's not very easy, but it's doable. And there are more and more studies that show that in these different mutations, the set of peptides is different, and that could probably, at some point, drive, and show some correlation between some specific phenotype and some peptides. Yeah.
But that will have an implication in the treatment,
yes.
Right? So how do you separate all of this? Yeah. How do you decide which one takes which treatment?
No, I don't have any answer, but what I was saying is that in our case, for example, the APP mutation, all the production of A-beta was shifted towards A-beta 42. So it was one of the highest ratios reported, 42 to 40, and that really had an impact on the pathology that we see, so the phenotype. Probably that it was a very early age of onset in the 30s, in the early 30s in that case. So it was really a match between the phenotype that we saw in the neuropathology, the mechanism, postulated mechanism of extreme 42 to 40 ratio, and the age of onset. Whether this has implication for the clinic, I guess in the future, once we have treatments, we probably will have implications. But my general thought it was difficult to really combine such a different mechanism across different mutations, and it just was my comment.
Yes, but we all know that the 42, 43 and paraglu are probably the peptide that are the big seeders in a way. Yeah.
Yes, for Lisi and Marie-Claude, when you conduct your neuropathological studies, do you also get access to clinical information from the donors? For example, I'm thinking of comorbidities, diabetes, obesity, cardiac disease that you could relate if that has an impact on the results that you see.
So we do have at UCI clinical data from the adults with Down syndrome and Alzheimer's disease. We do not have for the younger cases because those cases are coming from the NIH Neurobiobank and the data is not available. And we are collecting data from the ABCDS study, so we will have that available.
And in our case, we did not have access to many clinical data, but we had the neuropathological report with the macroscopic examination and the neuropathological examination in several regions. Yeah.
Marie-Claude, here, Lucia Chavez. So, yes, follow on your comments. So, we have characterized the amyloid-β profiles generated by mutations in APP as well as in presenilins. So, for presenilins, we see a nice correlation with a ratio between the short and longer peptides and clinical onset. For APP, we see a similar correlation with mutations in the transmembrane domain. So they change ratios. So, and there is one mutation that is strongly associated with CAA. That one has a different profile, has very strong levels in A-beta 40. It's actually the main peptide. So for those that are in the extracellular domain that are more associated with CAA, we do not see any changes. It's probably more connected with the aggregation propensity of the peptides rather than the ratios.
Thank you for giving more precise information.
Yeah, well, and I have a question for you. So the levels of 40 in APP duplication versus Down syndrome, are there any indications of, do they differ? A-beta 40,
They are quite similar, between Down syndrome with AD and APP duplication. And they are higher than in the other cases.
Okay, yes. Thank you.
So I think it's time for coffee. Thank you all the speakers for the presentations. And I will ask the speakers and the moderators of the next section to get a micro before the session. I think it will be easier for the speakers to have the micro at the beginning. So thank you.
Vale. Okay, so in today's session, we will talk about clinical and neuropsychological presentation and non-genetic modifiers of the phenotype. Speakers will be Ben Handen, Laura Videla-Tolo, Jason Hasentab, Lídia Vaqué-Alcázar, and Sigan Hartley, who has a pre-recorded talk, but she's online, so she will be there for the questions. So our first speaker will be Benjamin Handen, and he comes from the University of Pittsburgh, and he will talk about ATN status and longitudinal change in cognition in adults with Down syndrome.
Well, good morning, everybody. I'll kick things off. I'm Ben Handen from the University of Pittsburgh, and I was going to share some data on ATN status and longitudinal change in cognition in adults with Down syndrome. I have a few disclaimers and a picture of what I'm missing today in Pittsburgh. So I expect most folks know the ATN model, but for those who don't, let me just briefly review. So this is a staging model that was proposed by Cliff Jack probably 10 years ago, based on the amyloid cascade hypothesis, where we traditionally expect that someone's going to become amyloid positive or be above cutoff for significant amyloid first, then proceeding to being above cutoff for tau, and then finally for neurodegeneration. So that's the ATN model. And essentially, amyloid is traditionally measured by amyloid PET scans or CSF AB42, tau, similarly by a tau PET scan or phospho-tau on cerebrospinal fluid. Neurodegeneration could be FDG PET, looking at glucose metabolism, structural MRIs such as hippocampal volume, or CSF total tau. The field's also looking at plasma biomarkers as part of this, though I think there's still some discussion about what the cutoffs might be for various plasma biomarkers, but I expect we'll see that soon enough. And there's also some discussion about adding neuroinflammation to this model as well as cardiovascular factors. So it's going to end up being a kind of complex model by the time we're all through. So we already have some information in Down syndrome, some research done by some of my colleagues here in this room. We have some cross-sectional longitudinal research showing the association of PET amyloid levels and their impact on early cognitive decline. We also have some data looking at amyloid and tau levels and their association with cognitive decline in a 2022 paper that came out. I think that we know a little bit less about neurodegeneration. The N part of the model is a little less understood in Down syndrome, which is one reason we were interested in looking at this today. So the aim of this first look is my colleague Sigan Hartley. I just started looking at this data in preparation for today. We wanted to characterize change in ATN status across a relatively short period, 32 months, but you have to start somewhere. And then we wanted to see if baseline ATN status would predict subsequent declines at 32 months in cognition. So we had 5 measures that we were looking at. Amyloid PET scan using Pittsburgh compound B was our PET measure for amyloid. Tau PET scans using AV1451. T1 structural MRI allowed us to look at hippocampal volume. Cognitively, we used the modified cued recall test, which I'll talk about in the next slide. And then the DLD scale is a caregiver questionnaire. That's the dementia questionnaire for persons with learning disabilities. So those are the measures of interest. Let me briefly tell you a little bit about cued recall. This is a measure of episodic memory. For us, it seems to be our best shot at looking at the first changes in cognition that we see certainly well prior to a diagnosis of MCI or dementia. Individuals are taught to learn 12 different pictures. We present them 4 at a time, and then we have 3 trials. We start with what's called free recall, just saying, tell us all the pictures you can remember. If they can't remember a picture, we give them a cue. So if someone doesn't remember grapes, for example, we might say, or would say actually, it's a fruit. And oftentimes they'll say, ah, right, it was grapes. So we get a total score of 0 to 36, where we add both free and cued recall responses together. And we also can look at intrusions, which is essentially mistakes. Someone saying apple when we say it's a fruit instead of grapes. So how do we determine ATN status? Well, for amyloid PET, we used a centiloid value of 18 or greater. For tau, we use the Mayo composite value, which is a total across multiple brain regions, and we use an SUVR of greater or equal to 1.21. We're interested in structural MRI with hippocampal volume for our N value. That was a little tougher to come up with a cutoff because you can't use the cutoff for the general population for hippocampal volume and Down syndrome, so we had to come up with one. So this is what we proposed. You may disagree with it, but we can discuss it later. But essentially we took our cognitively stable group mean for hippocampal volume and adjusted it for intracranial volume. And then anyone who was more than 1.5 standard deviations off from that, meaning their volume was lower, we decided they were N positive or above cutoff. So we had a longitudinal cutoff, and we just recently published cross-sectional data looking at this same question. Our longitudinal group was from 4 sites from the Alzheimer's Biomarker Consortium, ABCDS. None of the individuals had dementia at baseline, and we focused at our baseline at 0 months, and then when they returned at 32 months. And we were able to find 76 folks who we had a complete data set for. So this is kind of our first pass at looking at longitudinal data. Here's our demographics of the group. As you can see, most folks had full trisomy. We had a few folks with mosaicism, and about 8% with a translocation. About 20% were APO4. The majority had mild intellectual disability, but we also had 30% with moderate, and a few folks with severe profound levels of functioning. About half our folks were females and half were males. As we said, everybody was cognitively stable. We had a few folks who we determined had MCI using a group consensus process, and a couple of folks we really couldn't determine. And the mean age was just under 38 years, ranging from 26 to 55 years of age. So once we looked at the ATN staging, we were really pleased to see, if you look at the baseline numbers, that almost everybody, with maybe 3 or 4 exceptions, fell into what we anticipated. Folks met cutoff for amyloid before they met cutoff for T or N, and then they proceeded to cut off for both amyloid and tau before proceeding to the N, and finally we had those who met cutoff for A, T, and N. We only had, as I said, just a few folks who didn't fit that proposed model. So just to share a little bit of data, this is our change, our decline essentially in cued recall. So let's see if I can figure this out. Oh, how perfect. So here's our 0. So essentially this would be at 32 months folks who showed no change, and then this would show a decrement, at least in cued recall. And again, you can see that most of our folks were not at cutoff for any of the 3 biomarkers. We had a small group of 8 who were cut off just for amyloid. This is all at baseline. And just a couple who were A and T positive, and a few who were for all 3. And then an interesting group we'll talk about in a second who didn't meet what we were expecting, which was they were A positive and N positive, but had not yet become tau positive. So you can see that based on cued recall, at 32 months, those who had, were not at cutoff for anything, and those who just were amyloid positive really didn't show any decrements, which is probably not a surprise. But once you're amyloid and tau positive, when we see you back at 32 months, we see quite a drop. And those who are positive on all three, there's also a drop. There's a slight difference here, but it has to do mostly with those who were positive on all three started out with a fairly low baseline, so they didn't have as far to drop. But if you look at them, they both dropped about 30 to 35% from baseline. So this is the group that's interesting. This is the group that is not tau positive, but it still meets cutoff for amyloid and neurodegeneration, and they show no difference, which confirms some other data that a lot of folks in this room have shown already in Down syndrome and in other forms of Alzheimer's, which is until you show tau positivity, you're not going to expect to see much in the way of changes in cognitive functioning. Here is our DLD. Again, this is a caregiver questionnaire on symptoms concerning changes in cognition. This is slightly the opposite, so a higher score means more concerns with one's behavior. So in this case, just same pattern. Those who are not positive in any areas show no change, and being amyloid positive at baseline is not predictive of any change at 32 months. But once you're amyloid and tau positive, we start to see some changes, and if you're positive for all three, we see even more changes. And then, of course, back to our group that is not tau positive, but is above cutoff for amyloid and neurodegeneration, still are not really showing any changes. Again, reinforcing the fact that until you see tau positivity, we're not going to expect to see much in the way of changes in cognition. Finally, we had about, let's see, 4, 8, 12, 18 folks who actually changed status from baseline until we saw them at 32 months. So it's a pretty small sample. 4 folks went from meeting no cutoff to being positive for amyloid. 8 folks became positive for tau, and 6 folks became positive for all three. If you look at those who remained below cutoff for everything, as you would expect, again, this is cued recall, there's no change at 32 months. And similarly, if at 32 months you became positive for amyloid, we're not going to expect to see much in the way of change either. That's really not enough time to show much. And in fact, even the folks who became positive above cutoff for tau didn't show much change either, because 32 months, somewhere in that 32-month period, someone became tau positive is not enough time to start to see impact on cognition. But where we do see the change is the few folks who became positive in the neurodegeneration cutoff. Those are folks who had been tau positive at baseline, now became N positive as well, and that was enough time to start to impact episodic memory. So that's our first pass at this. I'm going to thank, obviously, our families and our many participants at ABCDS and my colleagues in the consortium. Thanks.
Thank you very much, Ben. We will have time at the end of the session for questions. Now, our next speaker will be Laura Videla-Toro. She's a neuropsychologist at the Hospital de Sant Pau here in Barcelona, and she will talk about the clinical and cognitive expression of Alzheimer's disease in Down syndrome.
Good morning to everybody, and thank you for the presentation, Laura. And thank you to the organization for providing me the opportunity of presenting my work to this audience. As she mentioned, I'm going to talk about the cognitive expression of Alzheimer's disease in Down syndrome based on what we have learned at the Alzheimer Down unit during the past 10 years. Very briefly, Down syndrome is caused by the triplication of chromosome 21, and due to this triplication, this population is now considered, they have an almost fully penetrance of Alzheimer's disease with a lifetime risk for dementia of more than 95%. And as you can see in the bottom of the slide, they have as well an increased risk of, an increased prevalence of dementia, as you can see with this red color, from the age of 40. So, however, despite this ultra-high risk of developing dementia due to Alzheimer's disease, we don't have clinical diagnostic criteria suitable for diagnosing this disease in this population, and it is mainly due to the premorbid intellectual disability this syndrome has from their neurodevelopmental. So the diagnostic criteria usually used in the general population are not suitable for diagnosing this disease in these individuals. And another problem that we are facing in our clinical practice is that we don't have many adapted suitable neuropsychological tools to capture this cognitive decline related to Alzheimer's disease. So in 2013, a group of experts in intellectual disabilities, they published these guidelines here for detecting dementia in different intellectual disabilities. And what they recommended that is important for today's talk, it was to include a neuropsychological assessment in the exam of these patients, but in different ways. But as different at what we do in the general population, this cognitive assessment should be longitudinal in order to compare the individual's own cognitive performance with its own baseline. And another important thing they said in this article was that cognitive tests, that for individuals with intellectual disability, we couldn't use normative data or cutoff points for the cognitive test because there is a high inter-individual variability in their cognitive performance, so these measures wouldn't be useful for that. However, I haven't found in the literature any study comparing objectively this cross-sectional versus longitudinal performance of this test. So what I tried to do was, studying this issue a little bit more. So all the results I will present you are based on the DAPNI cohort. This cohort is centralized at the Alzheimer Down unit, and this unit was born by the alliance of Fundació Catalana Síndrome de Down and the memory unit at Hospital Sant Pau. And there we perform this health plan where we recommend every adult with Down syndrome in Catalonia to perform a neurological and neuropsychological assessment once a year. So with these clinical visits, we obtain our clinical cohort. And obviously, we have the consent of the participants for using this data. And in this clinical visit, we use as well, we offer them to voluntarily participate in the DAPNI cohort, which is this biomarker cohort that probably you all know, that includes different kind of biomarkers, but I'm not going through this because it's not relevant for today's talks. So another important thing regarding to methodology is the test that we use in the neuropsychological assessment. We use the modified acute recall test. I'm not going to go through it because it has just been presented, this test. And just saying for those who are not familiar with intellectual disabilities, that this test is some kind like a Busky test used in the general population, but adapted to people with intellectual disabilities. And the other test we use is the CAMCOG-DS, which is as well a cognitive battery that includes 7 cognitive domains, and it is adapted and validated for a Spanish population with intellectual disability. Again, for those who are not used with these tools, it could be something like the ADAS-COG widely used in clinical trials in the general population. So all the studies I'm going to present are based on these two tools. So, moving to the results, what we first did was studying the cross-sectional performance of these two tests I have just presented. And what we saw was that these two tests were useful to assess individuals with mild and moderate levels of ID, but it was not useful for those with severe and profound ID. Another important thing of this graph is that we could use this test in the whole continuum of the Alzheimer's disease. This is in the asymptomatic stage, in the prodromal stage, and as well in the dementia stage. So this seems to be useful to monitor this disease. And in that same work, we proposed some orientative cutoff points for these two tests with a good sensibility and specificity to detect prodromal Alzheimer's disease. However, it is really important to notice that we had to stratify this sample by the intellectual disability in order to this cutoff work properly. So then, after studying this cross-sectional performance, we wanted to go to study a little bit more the cognitive decline longitudinally, and as well the clinical progression of our samples. So we did a longitudinal study, including more than 600 individuals with Down syndrome, and our first result is showing how individuals with, who at baseline are asymptomatic, after 5 years of follow-up, there's a 70% of progression to these symptomatic stages. It is prodromal or dementia stage. And then here what we saw was that when we stratified the sample by age, there was a high age dependency on this progression. And as you can see, those individuals who were more than 50 years at baseline, there was a 60% of progression to symptomatic stage within the first 5 years of follow-up. And then we replied this analysis with the prodromal group. And as expected, progression was much higher. Almost all of the sample had progressed to a dementia stage after 5 years of follow-up, and approximately the half of the sample progressed between the first and the second year of follow-up. And in contrast of what we found in the asymptomatic group, here this progression was not age-dependent. That means that when the disease onset, it doesn't matter the age you have, that you will progress at the same rhythm than the older individuals. After that, we looked at the cognitive longitudinal decline. Here I'm plotting the row scores for the CAMCOG-DS, and here is age. Here I'm plotting the spaghetti plots of all our participants. The blue line represents the mild ID group, and the orange one represents the moderate one. And as expected, those individuals with a mild intellectual disability had higher scores in the cognitive test than the moderate one. And this is not new, but we also see it is already reported in the literature that somewhere between the 35 and 40 years old, it starts a cognitive decline despite these individuals doesn't have an AD dementia diagnosis. But the novel thing here is that we also plotted the spaghetti plots of the annualized cognitive change. This is the cognitive, the scores that they lose in a year between follow-ups. And what we see here is that there is an overlap between these two lines, meaning that it doesn't matter if you are a mild or moderate, if you have a mild or a moderate intellectual disability, that you will lose the same amount of scores in the cognitive test a long time. Another thing that we could conclude from this visual inspection of this graph is that in the younger individuals, it seems to be some learning or practice effects in the cognitive test. So we decided to study this a little bit more further. And we saw that between the first 2 years of follow-up, in those who were asymptomatic at baseline, it seems to be some learning effects, especially in the memory test, in the acute recall test, and especially at younger ages. And these practice effects are maintained until the age of 40, more or less, despite the decrease in the offset in the test. And finally, we wanted to compare the cross-sectional diagnostic performance of the test versus the longitudinal ones, and we did, well, to detect Alzheimer's disease, obviously, symptomatic stages. And what we did was a ROC curve analysis. We plotted in the y-axis the area under the curve, and in the x-axis the follow-up and the 1 year annual change, the second year annual change, third and fourth. And the red line represents the areas under the curve of those individuals with AD dementia, and the blue line represents the prodromal ones, and these dotted lines represents the area under the curve of baseline visit. And as you can see, the baseline row data, the baseline row scores, these areas under the curve goes from good to excellent to detect, to distinguish between asymptomatic, prodromal, and dementia, and they are higher of those of the annual change at 1 and 2 years. This result was very surprising for us because we weren't expecting that. It went against our own working hypothesis and against the actual recommendations. And we were thinking what could be happening here. And we studied the intra-individual variability in cognitive performance from one year to another. And I'm not showing the result because of time limitation, but we did find that there was a high intra-individual variability in the whole continuum, in the asymptomatic individuals, in the prodromal individuals, and in the dementia ones. So that may be justifying this better performance of the diagnostic performance of baseline visits. So to summarize, I think our results support the idea that Down syndrome has almost a near complete penetrance of Alzheimer's disease. And I think these results also reinforce the idea that this population is ready to, well, could benefit from disease-modifying clinical trials, and that they could withstand with the clinical and all the cognitive procedures for the duration of these trials. And I think that is important for us to develop health plans, appropriate tools, and as well to adapt the actual clinical diagnostic criteria. And that's all. Thank you so much, and thank you to the memory unit in the Hospital Sant Pau, and thank you to all participants and their families.
I'll introduce you. Okay, our next speaker is Jason Hassenstab from Washington University. He's going to talk about developing a digital cognitive platform for Down syndrome-associated Alzheimer's disease research, the ARC-DS study.
Hi, thanks so much for inviting me. Barcelona is just an amazing city. It's almost as nice as St. Louis. That's a joke. I like St. Louis very much, but this is a beautiful place, and I love coming here. I'm really excited to talk about a new study that we just started. I don't have a lot of data to show you, but I'm at least going to give you an overview of it. Several collaborators are here in the audience. These are my disclosures. My university makes me put these up here, and I do consult for some companies, but I just tell them, use this cognitive test, not that. That's the extent of it. I made way too many slides. I wasn't sure how much time I would have, so I'm going to buzz through some of these things really quickly. But I do want to tell you about our experience developing a digital cognitive assessment for the dominantly inherited Alzheimer network, which I've been a part of. I've led the cognition cores for that study for about 10 years. And that was really the basis of the smartphone application that we've developed to measure cognition. And now we're pushing it into Down syndrome AD research, which I am brand new to. So one thing we wanted to do was to build this for an international secondary prevention trial where there's a primary cognitive endpoint, and our population was people with autosomal dominant AD, especially the mutation carriers. And the requirements at the time when we built this, which was going back to 2017, was that we wanted to have a native smartphone application, so that would be an app that you would touch on your phone. And we wanted this to be able to be used fully offline. And in retrospect, that was kind of a mistake, because then once you start doing this type of work, that locks you into developing for iOS and developing for Android separately. So it's twice as much work. And the reason why we were very concerned about this is because several of our participants, especially in some parts of South America, we didn't think that they would have access to mobile data. In reality, that's actually not the case at all. Whereas some of our participants in those remote locations may not have power in their homes, they all have smartphones and they all have access to smartphone data networks. We built this ground up to be adapted for different cultures, which I think is something that's really, really overlooked. Oftentimes, a measure is developed in a culture and then adapted for different countries. In this case, we wanted to start with something that we would think would work in all sorts of different cultures around the world and languages. So as I said, Diane is a very, very global study. You can see our map of sites and potential sites around the world, and we're very, very proud of the network that Randy Bateman and Eric McDade, who you'll hear from later, have built. So this is our platform. This is one of our measures that we use. This is a spatial working memory test. And the idea here is we pick common items that are available in every culture, and then we change these letters in the stimuli. We distract people with this, and then they have to find the location of those items. This is probably the test I'm going to talk about the most today, which is our processing speed test. And you'll see why this doesn't work for Down syndrome so well in just a minute. But I just want to tell you some results that we found with this test. So basically, you would pick one of these. There are 12 trials. You have to go as quickly as you can on your smartphone. And then this is a memory test that we've developed. And this is the Dutch version, if anyone can read this. I think this is like some snacks and maybe a toothbrush if you read Dutch. And we have participants memorize these. We ask them if it's a good price. And that's essentially the platform that we use. This is what a typical week's worth of testing looks like for our participants. So, for example, they may be available from 7 a.m. to 10 p.m. We send a notification like you would get on any device. And this looks like a lot of testing, and it kind of is. But if you add up the total interaction time, it's only about an hour and 15 minutes across 1 week of a person's life. And the philosophy behind this is that we sample people repeatedly in different contexts and environments and situations, and then we can either combine those results into one point estimate, or we can actually examine the variability, which is, I think, something is very, very important. And I'll show you some results about variability that I think are really, really intriguing, and I was really happy to hear that variability in the previous speaker, I already forgot your name, was very interesting in Down syndrome. So these are some results from studies that we published in our sporadic AD cohort. This is just the correlation with our platform with standard in clinic cognitive measures. I'm not going to go into this because of time, but these are all in the expected direction, although the correlations look a little bit low. But we do find that when we give tests to people in their homes or in their natural environments, that we get lower correlations with our in-clinic measures for reasons I can talk about. These are some biomarker data results. They're all in the expected directions, and generally we see exactly what you would think. There are correlations mostly with neurodegeneration biomarkers, less so with amyloid biomarkers. This is work from my former postdoctoral fellow. Our measures that we give in this fashion are extraordinarily reliable. This is probably the key advantage to giving cognitive tests within people's natural environments, is that you get low performance, you get high performance, you measure them when they're tired, you measure them when they're awake, and when you combine across all these occasions, you get extraordinarily high reliability. If you look, this is probably the thing that I think is the most convincing aspect of this approach, is the test-retest correlations. This is like what you would see for a biomarker, not for a cognitive test or a behavioral measurement. So we're exceeding 0.9 and even upper 0.9s at retest intervals, which I think is really intriguing. But one thing that I wanted to talk to you guys a lot about today, because I think it's so fascinating, is that we can learn a lot just from getting a simple response time measure from people. Within that response time, meaning the time at which you see a stimulus and you respond to it, there's a wealth of information that can be drawn from people. And I know that doesn't seem like the most clinically meaningful thing at first, but I hope I can convince you that there is something here. So if you take two individuals, for example, one person may have a very steady performance across occasions, and another person may have extraordinarily variable performance across occasions. So these two scores from these hypothetical individuals have the exact same mean, but their standard deviation is vastly different. And you can see, if you were to pick any one of those two occasions across time, you could make a very, very different conclusion about those two individuals if you didn't have the repeated measure. This is data collected at 6-month intervals. So each cluster of data on a response time test represents 6 months. So this is about 2.5 years worth of data. And you can see over time that there's a general improvement. Remember, a faster response time is a better performance. So over 2.5 years, our participants are getting better by almost a second on these response time tasks on average. But you can see there's a lot more within this signal that you could break down and analyze that may be of interest. So for example, in a paper that we did with some colleagues from Penn State, we actually characterized the different forms of cognition and behavior that you can measure just from response time. And you can see there's a learning phase. So I was very happy to hear you talk about practice effects, and I have some comments for you later on that. That there's a really steep learning effect that we see initially, and we see the same thing in Down syndrome, the same thing in autosomal dominant AD. People get used to taking the test, but the rate at which they learn, and then when you expose that test to them again, say a year later, the rate at which they learn and remember from taking the test on a previous occasion is actually of interest. And then there's what we call asymptotic performance and peak performance. And all of these things can be used as potential outcomes, which I think is very, very exciting. So we took a look at some of these things in our sporadic AD cohort as potential areas of research. So within 1 week, we can analyze variability at the day level, we can analyze variability across the entire week, and then we can actually analyze variability within each session from trial to trial. And one of the first things that I'd like to show you is a paper that was just featured in the American Psychological Association Spotlight. I'm super proud of my former postdoc Andy's work on this. And we found that variability within a day among people who are cognitively normal but had a APOE4 allele, the APOE4 carriers showed more variability even at the daily level than non-carriers. And so we took this to another extreme and said, well, how much can we learn if we looked within each trial? So I'm talking about the individual responses to that processing speed task at like the trial by trial level. So we're talking 30 seconds of performance from one individual. And my postdoc, Matt Wilhalf, said, I think there's a signal there, and I told him he's wrong. And I want to tell all of you that I was wrong and he was right. So when we compared symptomatic and asymptomatic individuals, of course we found a signal just at the trial by trial level with 30 seconds of data. This is just a remarkable result to me. But this wasn't so surprising. But when we limited this to all cognitively normal people and we stratified by genetic risk, we actually found a pretty compelling signal, not a very, very large effect size, but just from 30 seconds of data. It's absolutely remarkable that we would even see such a signal. And another thing that we can do with repeated testing, which I think is really interesting, is we can look at time of day effects. And so in our older adults, we found that when they take tests at night, they perform about 10% worse. And then if you have biomarkers for AD, the difference between morning and evening performance was even more exaggerated. And in some ways, I think this suggests that perhaps we should be testing our people not when they're at peak performance, but perhaps when they're a little bit stressed or tired. And I think we may be uncovering a little bit of latent behavioral deficits that might come out. And I can tell you, after flying overseas yesterday, staying up till midnight, having a nice Spanish dinner, that I'm not my sharpest right now. And so this, I think, is reflective of what we can see in individuals with preclinical AD. This is our new study that we've just started. We just got funded in August, and I'm really, really excited about this. It's called the Ambulatory Research and Cognition Down Syndrome Study, and we're trying to adapt our smartphone platform to suit this population, which, as I said, I don't have a lot of experience in, so I'm learning a ton from everyone at this meeting today. I'm not going to belabor this because you all know this, but we do know that people with Down syndrome are routinely excluded from AD studies and clinical trials, and I think we really have to figure out why. And I think from a cognitive perspective, some important things to consider is that the FDA and the European Medicines Agency require evidence of a cognitive benefit to approve AD treatments. This is like written out in all sorts of documentation from both of these regulatory agencies. But in Down syndrome, it's really, really difficult to show cognitive benefit when it's confounded by intellectual disability. And I realize I'm speaking to, you all know this. But our existing cognitive measures that we use, I think, are a pretty fair, loose collection. And we wrote a review paper with Andre Stridham, who I think I saw here somewhere, and Juan and Johannes and others. And we found some signal there when we combined them across cohorts. But we're really trying to focus in on developing a digital platform to do this. And I also think that none of these measures were developed specifically for global studies. So they're typically adapted, which is fine. That's what we all do. But we wanted to start from the beginning with something that would be work for a global study. So can we adapt our tool for Down syndrome studies? Well, the overall aim of this is to do just that, and I underline global because we really want to emphasize that we think we're going to have to do this in multiple different languages and countries and cultures if we really want to have a digital platform that will work for phase 2 and 3 clinical trials. These are our sites. You'll recognize many of these names. Several people are in the room or online. And in the bottom, we're very excited to potentially add 2 additional sites to our study, including in Buenos Aires and Trinity College Dublin, pending some, well, let's just say the United States government right now is not having the best time with budgets. And once the budget is approved, we're hoping to add a couple of sites to our study as well. The study works in 2 different phases. Right now, we're just starting our first phase, which is our test development and software development stage. And in this stage, we promote new measures and we put them through a iterative testing pipeline, which carefully considers a lot of things, primarily psychometrics, user experience, and then also engagement. And we run these through these populations as quick as we can, and each site is participating in these studies, hopefully, within the next few months. And then if we don't like the data, we basically can quickly revamp them with technology, push out new versions of our measures until we get them where we want them to be in terms of engagement and psychometrics. And then in the phase 2, I'm really happy that we'll be able to begin. We're hopefully going to have our kickoff meeting here in this very room in about a year for the validation and plasma biomarker collection phase. We're hoping to enroll about 320 participants with DSAD, probably about age 40 and in the mild to moderate intellectual disability range. And we have annual assessments with our digital platform, our standard cognitive measures, including the modified cued recall test, a bunch of other things that you'll probably hear about today. And we also have blood collection. That serum collection right now, this is just a schematic I borrowed from Carlos Cruchaga. Will be about 5 to 6 tubes. We're going to collect heparin, EDTA, serum, Paxgene, and we're going to process all of these bloods at the Sahlgrenska lab up in Gothenburg with Henrik Zetterberg, who we all know and love. But the considerations that we have to deal with for developing this digital platform are really important, right? We have to deal with the fact that our participants generally don't have excellent literacy. So you can see when I've showed you my examples of tests, there's a lot of text. There's a lot of writing, and we want our participants to be able to do these independently without us. And we also have speech impairments, there's visual impairments, and then some participants may require assistance from study partners. So this is a huge challenge to develop a digital measure. You can see from our original version that we have, there's very, very small text, there's very, very complicated instructions and symbols, and so we've simplified this, and we're now relying on an audio presentation instead of having text to read, which also brings about different challenges when you want to make a smartphone app or a tablet-based instrument. Do you have headphones? Is there background noise? Is this something that people can carry around with them? These are all considerations for us. And then we've also taken our GRIDS memory measure and we've simplified this and added different game-like features. Anyway, this is just a preview of what we're working on. We don't have a lot of data, as I said right now, but from our preliminary data, we collected about 23 participants just for engagement and psychometric validity. And indeed, participants can totally do this test with Down syndrome. There's no issue with them understanding or completing the tests. And we were able to get pretty good data from our participants thus far. And I'm sorry I don't have a lot more data to show you just yet, but if you invite me back in a year, we should have a good chunk. And in 5 years, we're going to change the game. We'll see. All right, I think that's all I'm going to talk about today, so thanks very much. But I do want to just acknowledge Andy, Jessica, Hannah, my grad student, Matt Wilhaff, and of course all of my other investigators and funders, and of course the participants and families who are going to help us in this. Thanks very much.
Okay, thank you, Jason, for the wonderful presentation. Our next speaker will be Lídia Vaqué-Alcázar, and she works here in the Hospital de São Paulo, and she will talk about the generational changes in Down syndrome and the impact of intellectual disability, Alzheimer's disease progression, and cognitive trajectories.
Good morning. Thank you for the introduction. Today I'm going to talk about the concepts of resilience and cognitive reserve that has been extensively investigated in aging and Alzheimer's disease. And I'm trying to show you that these concepts could be also of interest in the study of Down syndrome population. The current reserve and resilience framework define resilience as the capacity of the brain to maintain cognition and function in aging and disease, and also define cognitive reserve as a mechanism underlying resilience that could be broadly defined as a property of the brain that allows for cognitive performance that is better than expected given a degree of disease or brain injury. So cognitive reserve refers to to a capacity of the brain such as adaptability, efficiency, capacity, or flexibility that are usually measured using MRI studies, neuroimaging studies, and also can be influenced by the interaction of our genome and the lifetime exposure and the complex interaction between them. So we can understand cognitive reserve as a dynamic property of the brain that can be enhanced along the lifespan. Also, this cognitive reserve can be measured via a set of proxies. For example, years of education is the most common proxy of cognitive reserve, but we also can assess cognitive reserve using questionnaires or with other approaches such as the residual approach or with the neural implementation or the biological approach. So it's well established in the general population that cognitive reserve is related to better cognition, and specifically in Alzheimer's disease field, we know that cognitive reserve is associated with a reduced age-specific risk for developing AD. And it seems that those individuals with high cognitive reserve can tolerate or better cope with greater severity of Alzheimer's disease before becoming demented. As you can see in this classic model proposed by Stern, those subjects with higher cognitive reserve, with higher estimates of cognitive reserve, perform better than those with lower cognitive reserve, and they show a delayed clinical onset in Alzheimer's disease. Also, cognitive reserve has been explored in autosomal dominant AD. Here you can see an example published by Franz Meyer and colleagues, where they identify the left frontal cortex as a neurobiological mechanism of cognitive reserve. So this is an example of the biological implementation of cognitive reserve. Specifically, the authors identify that those subjects with higher functional connectivity between this half of the brain and the rest of the cortex evidence and a slow or a less impact of the estimated years of clinical or symptom onset on the memory decline. So the trajectory is more flat than for those with lower functional connectivity. Moving now to the Down syndrome, as all of you know, Down syndrome is caused by the triplication of the chromosome 21, and this triplication leads to an extra copy of the APP gene, being this both sufficient and necessary to cause AD pathology. We also know that Down syndrome-related Alzheimer's disease is as predictable as autosomal dominant AD, but there is a variability in the age of clinical symptom onset that we think that at least could be explained by modifiable factors or the environment, the lifestyles. Few studies have tried to characterize cognitive reserve in Down syndrome population, but most of them using leisure activities as a proxy of cognitive reserve. And the main message is that cognitive reserve may be measured in ways similar to a general population, and that this cognitive reserve may be modifiable too in this population. So in this context, and based on the well-established idea that during the last decades, the Down syndrome population has experienced an increase in the number and the quality of stimulating activities, we wanted to test whether this enriched environment would result in a generational effect showing a lower ID level and a higher functionality and intellectual profile as function of the birth year in Down syndrome. And then we proposed to study how this intellectual disability as a putative cognitive reserve proxy could influence the AD clinical onset, taking account the prodromal or the dementia diagnosis and the cognitive trajectories among asymptomatic Down syndromes. For these proposals, we analyzed data from the Down Alzheimer Barcelona Neuroimaging Initiative cohort, explained previously by Dr. Laura Videla, and we include a subset of subjects composed by 778 Down syndrome participants that were classified as asymptomatic, prodromal, or demented along the AD continuum. We use longitudinal data for the second aim, but for the first one, we focus on those asymptomatic and using cross-sectional data. Specifically for the intellectual disability classification, we stratify our sample into mild, moderate, severe, and profound based on the DSM-5 and the caregiver report of the individual's best level of functioning and the scores from the Spanish version of the Kaufman Brief Intelligence Test. Of note, we exclude those participants with profound intellectual disability for the cognitive analysis and also for the analysis related to the second aim. The first result that you can see in this density plot is that we identified that there was a generational increase in the proportion of individuals with mild and moderate intellectual disability and a decrease in those with, profound or severe intellectual disability as a function of the birth year. Similarly, a higher proportion of individuals develop day-to-day functions, as you can see in these density plots, where we display if the individuals had been partially able or not to develop these activities, such as cooking, housework, take the public transport. There is a tendency for the increased level of autonomy. However, it seems that this peak reached its maximum among those subjects born in the 19s. And I'm going to further explain this point in the following slides. In addition, a higher proportion of individuals acquire intellectual milestones such as calculation or language, and we have more or less the same results that in the previous slide. And we identify again this maximum reach among those subjects born in 1990. Then we identify also a positive association between both the verbal and non-verbal CAVIT scores and the birth year. But we further characterize this association between the vocabulary, in particular scores, and the birth year, and we identify a nonlinear association that can explain in part the results that I have shown in the previous slides. With this lowest model, when we replace birth year by age, we can see that the CAVIT score reached its maximum around 27 years. And this suggests that the best level of functioning could be underestimated among the younger subjects, and this can explain why we identify our maximum among those born in 1990, in the 90s, and not for the youngest subjects from our cohort. On the other hand, moving to the second aim, we wanted to test the progression from the asymptomatic Down syndrome to clinical Down syndrome, so combining both the prodromal and the dementia diagnosis. And the Kaplan-Meier curves that we carried out evidence that the asymptomatic Down syndrome with severe intellectual disability progressed faster. However, no differences were found when we select the subset of prodromal Down syndrome and we test the progression to demented Alzheimer's disease. We also identified that there were no differences in the age of onset for the prodromal diagnosis when we analyzed those asymptomatic subjects. However, for the severe intellectual disability group, there is a slightly later age of onset for demented Down syndrome when we analyze the groups, and this could be due to the complexity on the diagnosis due to the intellectual disability itself. And in this last result that has been partially presented by Dr. Laura Videla, but here we have included more subjects and a larger cohort and more time points, I think. We analyzed the cognitive trajectories and the age-related changes in these groups, and we identified that there were no group differences among trajectories when we compare mild and moderate intellectual disability groups. However, as expected also in general population and in cognitive reserve field, we always identify differences in the intercept. Always the mild intellectual disability group perform higher than the moderate. And neither we identify differences when we estimated these trajectories by age ranges, as you can see in the other plot. So in conclusion, there have been major changes in intellectual profile in adults with Down syndrome in terms of intellectual disability level and functionality or intellectual profile, but there is a lack of results to evidentiate that this advantage could suppose an effect on the AD presentation. However, there is an increased interest in understanding how cognitive reserve proxies or modifiable factors contribute to resilience in Down syndrome. And an example of this is the creation of a cross-PIA as a result of the interaction of the Down syndrome PIA and the reserve and cognitive and protective factors PIA that try to study this topic. Thank you for your attention and to my team.
Thank you. Our last presenter is a pre-recorded talk by my colleague Segan Hartley from the University of Wisconsin-Madison, who unfortunately cannot be with us today. She's going to be talking about timing of cognitive decline in Down syndrome Alzheimer's disease. And I hear a rumor that she actually might be awake and joining us for questions. So anything I can't answer, I'm just going to punt over to her. Maybe she's not awake.
Hello, I'm here, although I think they're going to do the video. I'm Segan Hartley, and I'm a professor at the University of Wisconsin-Madison and the current vice chair of the iStart Down Syndrome PIA. My presentation is the timing of cognitive decline in Down syndrome Alzheimer's disease. Now, recently, several studies have examined the average age of AD symptomology in people with Down syndrome. And a recent systematic review estimated that the onset of dementia occurs at about 53.8 years on average. And some large natural history studies have shown that cognitive declines begin in the 40s and that there tends to be a similar rate of decline across individuals with various premorbid ID levels. Now, prior work also suggested that Alzheimer's disease biomarkers, such as PET biomarkers, align with the ATN model and do map onto cognitive decline in people with Down syndrome. So you can see in the middle top figure that performance on a modified cued recall task, which measures memory, remains stable across time for individuals who started the study with low amyloid. You see a mixed pattern for individuals who became amyloid positive during the course of the study, and marked declines for those who started the study with amyloid positivity. Taking this further, you can see in the bottom middle figure there that it's really individuals with Down syndrome who are both amyloid positive and who had elevated tau who are showing memory declines across time. Taking this even further, you can see the figure on the right, and there is the individuals who are elevated in amyloid, tau, and also who evidence hippocampal atrophy, who are indicated by the red cross sign, who are performing lowest on this memory measure. Now, what's really missing in the field, though, is how we can pull this information together to develop a timeline that could be used to estimate when an individual with Down syndrome might develop Alzheimer's symptomology. Now, outside of Down syndrome and in Down syndrome, often people will use the EYO approach, or estimated years to onset. And this approach takes an individual's chronological age and subtracts it from the population-based mean for AD symptomology onset. So in Down syndrome, about age 53 or 52. But one limitation to this approach is that it really can't handle within population variability. So you can see on the left that across people with Down syndrome, we do see about a 22-year spread in the age at which dementia has an onset across studies. And you can see in the figure on the right that we also see variability in the age at which individuals with Down syndrome will begin to accumulate amyloid-β. Some individuals accumulate in their 30s, others not until their 50s. So an alternative approach to the EYO is to anchor a timeline based on Alzheimer's disease biomarkers, such as amyloid-β. So Matt Zammit and Brad Christian have done this for the Down syndrome population. So you can see there at the left, this is their estimated amyloid chronicity scale, where 0 would be an amyloid positivity value of 18 centiloids. Then scores to the left would be how many years an individual would have until they would be estimated to reach that centiloid value of 18. And scores on the right would be how many years following an individual having reached amyloid positivity or the centiloid value of 18. Here you can see a much tighter trajectory when we anchor it to amyloid chronicity. And Matt, using this approach, has found a sort of a robust association between amyloid chronicity value and tau deposition. Now, taking this a step farther, a very talented postdoc in my lab, Emily Schwer, teamed up with Matt Zammit to lead an effort to try to establish the timeline to symptomatic Alzheimer's disease based on these amyloid chronicity values. So they're the two first authors of what I'm going to present now. And they looked at data from a sample of 167 adults with Down syndrome from ABCDS. And these individuals all had at least 2 time points of data collection, spaced 32 months. They focused on 3 measures: the modified Q recall, the DSMSE, and the NTG, which is an informant report of dementia symptoms. So here, what you can see, these are Lowe's models to show their mixed linear regressions. And they use this broken stick approach to find the amyloid chronicity value at which there was a change or a decline in performance. So here you can see on the Q recall that they found a significant change at 2.73 years following amyloid positivity, or again, that 0 value or 18 centiloids. Thereafter, you can see that beta estimated that individuals would decline on that scale by 1.35 points per year. You can also see that they similarly found a change point of 2.75 years when we look at intrusions on the Q recall, and an estimate of 3.58 years on the NTG, which is about a year later, which makes sense because this is an informant-based report of dementia symptoms interfering with everyday life. Now, they repeated this model, but they looked at change across the 32 months in our cognitive outcomes. Here you can see on the Q recall total score that change point moves to 3.41 years post-amyloid positivity. And there was a trend in the NTG for that change point to be 5.52 years post-amyloid chronicity. Now, we don't know if these slightly later estimates are because the within-person change provides a more robust sort of timeline for us, or if this is because these within-person change models are based on a lower sample size, only 97 participants. So this is something we'll be watching as we go into the future. When we look at clinical status, here you can see that group in the green, cognitively stable individuals had a mean chronicity value of -3. People with MCI had a mean chronicity value of 7.4. People with dementia had a mean chronicity value of 12.7. And that group in pink are people who we could not do their clinical status because of life changes or medical conditions. To put tau in the same timeline, you can see that there was a change point in terms of tau deposition at 2.71 years for the Braak stages 1 and 2, 3.38 years for stages 3 and 4, and 6.11 years for stages 5 and 6. So to put this all together, we have this wonderful timeline that Matt and Emily created. So here you can see that we would expect on average memory declines to begin at about 3 years following amyloid positivity. This really aligns with deposition of tau at stage 1 and 2, followed by tau and deposition in stage 3 and 4 at near that 4-year mark. Again, at near that 4-year mark, we're going to have declines in or increases in dementia symptoms based on informant reports begin. MCI really occurring at 7 years and dementia at 12 years. So in summary, we do think the AD symptoms in Down syndrome Alzheimer's disease follow a predictable trajectory that we can map on to amyloid chronicity. We think these findings suggest that there's an accelerated timeline to AD symptoms relative to late onset Alzheimer's disease. So in LOAD, progression to MCI was estimated at 15.5 years post-amyloid positivity, whereas we're finding MCI at 7.4 years and dementia at 12.3 years. There is some caveats to this work. First, we looked at the average age of participants who had MCI and dementia, not the age at which they initially transitioned to these clinical states, so it could be a conservative estimate. We also had relatively few participants with MCI and dementia and looked over a short course in a relatively small sample. So these are all things we're very excited to continue to follow in ABCDS. So I want to thank Emily and Matt. Again, they're the lead authors of this work, and Brad and I have had the privilege to get to work with this wonderful team. Ben Hand has been very involved, as has Toby Bedhauser and JBO Wang. And I want to thank all of the ABCDS investigators, the families we partner with, and of course, our important funders. Thank you very much.
So thank you, Sigan. So now we have time for questions, and Sigan is awake at 3 a.m. in the morning. So she's there in case you have any question for her. And yes, feel free.
I think we should ask Sigan at least one question to make it worth her while for getting up.
Okay, now we're good. Thank you all the speakers for your talks. I have 2 questions. I'm upstairs, right? I have 2 questions if I can. One for Laura and one for Jason. For Laura, you showed that in your ROC analysis that the cross-sectional, the baseline, it seems to be better to classify individuals, no, that in prodromal or dementia stage. It was quite unexpected, but you also showed that there were practice effects, in the follow-ups, as expected also. To what extent do you think that the practice effects are affecting this, the ability to predict a symptomatic stage in the follow-ups? And even, have you used, for example, parallel versions to mitigate practice effects, or can you elaborate a bit, please?
Yeah, thank you for the question. Sorry, thank you for the question. Yeah, indeed, the practice effects were shown in those asymptomatic individuals. So this was more surprising because it should go against this, this better performance of the cross-sectional performance, because in the longitudinal ones, the ones with dementia or in a prodromal stage, they didn't show this practice effect. So it's like contradictory for us. This was very surprising. So yeah, it's a strange, well, as I said, it was very surprising, and we really think it's because of the intra-individual variability, as well, Dr. Hasenstab also saw in his works. And regarding the other question, it does exist a second version of the modified Q recall test. We don't have a second version of the CAMCOG-DS, but the second version of the B version of this test, of this memory test, we are not using it. We are thinking about adapting it to our population because the images are quite are not so usual in the Spanish vocabulary. So this second version is really difficult for them to learn these new words. It's like, I think they have to be updated, but we are thinking of doing it. Yeah, because I think it's mandatory to do it, because we need a second version of all those tests as it happens in the general population.
Thank you. And my other question for Jason is regarding variability. What do you think what is the underpinnings of this variability? I mean, it's like an unstable attention, or do you have any hypothesis behind this?
Sure. Your first question was really intriguing too, practice effects. That's kind of a passion project of mine too. But regarding variability, the vast majority that we saw were in APOE4 carriers. And I think E4, I don't have any hard evidence of this, but I've always considered it to be like a resilience gene. And it's something that I think just is a developmental issue from people who are born different that have, copies of E4. And I think it has something to do probably with their ability to stay focused in the attentional demand that's required of certain tests. So it just tends to not be the ability to sustain attention for as long as people who are not E4 carriers. I mean, that's my theory, that's my hypothesis. I have no hard data to support that particular thing.
Thank you very much.
Great. My question over here is about cognitive reserve. So in the model that was shown about cognitive reserve, the high performers are throughout life high performing until they get to a certain point and then they have a decline. And the low performers are also stable across life and they decline. And the slope of decline for the high performers is faster than the slope of decline for the low performers. So I was wondering if the panel could comment a little bit on this idea of cognitive reserve being protective for Alzheimer's disease, and in Down syndrome, you didn't show difference, between the intellectual disability levels, right? So that doesn't seem to really play into this concept. But any comments about that?
Yeah. Thank you for your comment. Yes, what we know in general population is that always a higher estimate of cognitive reserve was associated with higher performance. But then when we try to identify the cognitive trajectories, if there are differences between these groups, it's not so clear if cognitive reserve supposes an advantage. So in the context of Alzheimer's disease and Down syndrome, it will be also more difficult to identify these differences. But the idea is that if you have higher rates of cognitive reserve measured as, for example, years of education, you will be able to maintain your cognitive performance. That is the way that we use to assess or to identify the clinical onset the most of the times. And well, the idea is that then when you start to decline, this decline is faster because your brain has accumulated such amount of damage and your neural resources are not able to compensate this damage anymore.
So you end up at the same point?
Yeah, but...
You end up at the same point
but later. But later, we can delay this decline.
So really nice talks, and also thanks, Segan, for 3:30 or 4 o'clock in the morning being up. It's really amazing. So we have a lot of people who have a strong neuropsychology background, and one of the things in Segan, what you were presenting, we're seeing in the ABCDS, is that there's a much more compressed time frame, and so that can have benefits, but it could also have deleterious effects. What I mean by that is that the benefits is that typically we don't see an association between amyloid and, say, cognitive changes in late onset Alzheimer's disease. But if it's a more compressed time frame, we do potentially see that, and that could help in, as Jason or others have been mentioning, with FDA or measuring these kinds of measures. So how do you put that into the time frame? And then the second is that with cognitive reserve, it may be that because there's such a compressed time frame, you can't really see that kind of changes or that protection because it's so compressed with the disease time course. So how do we take this kind of compressed time course, how do we use it to our benefits with cognitive testing? That's for anybody.
I think it should be for Siegen.
Yeah, definitely.
Worth it. We can't hear you, Siegen, if you're coming up with a brilliant response to Bo's question.
She's unmuted.
She's on. Okay, well. Anybody want to take a stab at I agree, Bo. It's a compressed time point. And until we're looking at tau cutoffs, and we would see when someone became amyloid positive that we could see changes in cognition, I think that the changes were bigger once we could add tau to it. Before, it was kind of diluting it. Yeah, right, exactly. But you think there might be an advantage to that, so.
Well, there's an association. I mean, there's something, you see 2.7 years.
So, Bo, that's a great comment. I just want to follow up on that. It's 3.2 years that you're seeing cognitive decline.
Right.
And interestingly, in sporadic AD, in the 2 secondary prevention trials that we've run, the A4 study and the AHEAD study, we're powering on the PAC, which is similar to the MCRT in preclinical AD. That's a 3.5-year time frame to detect a change on the PAC, 3.5 years. And 3.2 years is not so far off. So there's a question here as to, is it really accelerated? And my question was going to be, on the data that Siegen presented, and Ben, you mentioned it also, when you're saying 3.2 years, how much of a decline are you seeing on the MCRT on average? What's the variability on the MCRT after 3.2 years? Because that's really defining decline, right. And it may be different than the PAC in secondary prevention trials.
Right. Well, Siegen's on muted, but I seem to recall it's about 1 to 1.25 point on acute recall a year. This is my recollection.
So depending on the effect size of the treatment, that's going to be a major issue.
Yeah.
I just wanted to add to the conversation about tau that the way we've been looking at it with the Brock staging, we may want to back up a little bit and look at finer regions of interest, because that 1 to 2 phase groups in a lot of change in tau, and so thinking about that move from entorhinal out into other areas of temporal cortex, that may give us a little more time in there to look at that change than just the 1 and 2.
And, oh, sorry.
Please.
Yeah, and also in line with what you are talking about, the cognitive change, I want to mention what Laura was saying about the learning effects, that she's seen those learning effects until they reach the 40s. We could use that in our benefit as a cognitive measure per se. Mm-hmm. So we could think about the lack of learning effects being a pre-measure, like something that we don't see maybe with the modified curricle, but we are seeing with this construct itself. So the lack of learning effects by repeated exposures could be a cognitive measure that will allow us to detect those cognitive change, like early cognitive change in the mild cognitive impairment stage of the disease. So,
yeah, in the A4 study, we saw an increase in the PAC, actually, in the first year, and then a decline afterwards.
Yeah.
It said 2.7. That's all I thought. 2.7 years. That's like that. All I could read. Yeah. So just to follow up on that, in the Diane study, we published a paper about practice effects, and we saw practice effects even in mutation carriers across the entire study for 4 consecutive years. Even on measures that had alternate forms, on the cog state measures, which are supposed to be randomly generated, we saw a consistent improvement across 4 years. And I think that's related to a couple of things. One, in that study, for example, they were exposed to the materials every 6 months, which is very common in clinical trials. You don't see that in observational studies. And the other thing is we had a 3-to-1 randomization. So they had much more higher chance of being on active drug, which I think set up some expectation effects from participants, maybe like a sort of like a placebo effect. They thought they were getting active drug, so they maybe a little bit convinced they were getting better. It was really fascinating exploration of this. And we published a paper in my lab in 2015 called Absence of Practice Effects, or Attenuation of Practice Effects is a marker of preclinical AD. So this is, not a new concept, but that, I think, modeling that lack of a practice effect as an outcome is an absolutely very, very useful idea, and I think everybody sort of understands what that means. Like, it's a clinically meaningful outcome, just like, you didn't get better on this and everyone else did. You can sort of understand what that means as an outcome. I like that.
It makes so much sense. So rather than us fighting it and trying to come up with alternative versions,
the title of the paper, the title of the paper is Avoid or Embrace. And so embrace, that's what I say.
This is a question for Jason. I was curious if you could comment on your experience administering your digital test in clinic versus remote at home, and how you're planning to do that in your Down syndrome program. And the reason why I ask is because we have seen differences administering a digital test in clinic or at home, and what we see or what we think is happening is that families are helping participants. And how are you planning to control or to check for that?
Yeah, so for right now, we're administering everything in clinic until we can understand what participants can do on their own. So what we're doing in our pilot studies right now is we're actually videotaping the interaction, and we're keeping their collateral source outside of the room, and we're trying to figure out what sort of pain points the individuals have when they interact with our technology, so that when we do go to our actual trial, they'll be able to pick up their tablet or phone and do everything that they need to do without asking a caretaker, or a care partner to unlock it. So that's actually a super, super important part of our development strategy right now. And we have a user experience expert who's helping us with this process. So she looks at the video of the interaction, and the participant's actually wearing a little microphone, and they're talking about the problems they're having interacting with the device. So we're trying to take those steps right now to avoid the problem of the caretaker helping out later on. There's no way you can control for that. And we get asked this all the time from the DIAN study, well, how do you know that their partner isn't completing the test for them? And we tried to come up with all sorts of clever ways to deal with that. The best we've come up with now is just having the participant put their initials that says they completed the tests at the very end of the testing session. And that's all we can come up with. We tried using like the fingerprint ID. We toyed around with using the front-facing camera, flashing a picture at random times. But you can imagine how privacy, experts maybe disagreed with that approach. But even though the picture itself would actually just be a grid of numbers, it just takes facial features, like the Face ID in your phone doesn't actually take a picture of you. It just takes little measurements at points across your face and says, across this matrix of numbers, this is their unique ID. And we tried to pass that by regulatory agencies, and they were absolutely no. But that's one way you can do it. The front-facing camera has a lot of possibilities there, but it's just we've gotten hard-nosed from everyone we've even tried to broach the topic with. So.
Is that quantifiable? Because it almost seems like just like you're fighting practice effects, now embracing them. Maybe the fact that you need a caregiver to provide more assistance is actually a variable to embrace rather than to try to avoid.
We toyed with the idea of having a test where it required, collateral source input, but it's just too hard to standardize, I found. Maybe if you guys, people who have more expertise in Down syndrome chime in, but I think that would be really hard to, in clinical trials, everybody wants same experience for every single participant, and we treat individuals as like discrete units, and we never really consider like their family unit or structure, because those are things that we can't control and compare across groups. So that's like my hesitation with that would be to get that by a regulatory body.
I have a question for Lídia on the cognitive reserve in Down syndrome. Maybe I missed it, but did you see like factors like social factors, the level of education that could be involved, or some other environmental like nutrition or sport? Or?
Yeah, we are working on it, and we need to further characterize this lifestyle or, for example, social leisure activities that can influence or can compute as cognitive reserve to measure the effect on Down syndrome population. But as I said, the most part of the papers published in cognitive reserve field focusing on Down syndrome have tried to characterize the leisure activities, so the level of social activity, the physical activity, for example. And yes, we are trying also to collect this kind of data in our large cohort to better characterize cognitive reserve also at this level.
Well, we are running out of time, so I think we should conclude here. Thank you, everyone, for your wonderful presentations, and thank you. And thank you, Sigan.
Thanks, Sigan.
Ens aplaudim.
Good morning to everyone. I am Albert Lladó from the Hospital Clinic, and my partner is Alexander Bejana from the Hospital Sant Pau of Barcelona. In this session, there will be 5-minute talk, and then, if it's possible, one question for every speaker. So we will appreciate the speakers to respect the established time, so without further ado, let's move the first talk, titled Special and Single Nucleus Transcriptomic Analysis of DSAD and Sporadic AD, presented by Samuel Moravito from University of California.
Thank you. Thank you for the introduction, and I would like to thank the organizers for allowing me this opportunity to speak today. I'm really excited to talk about the focus of my PhD at UC Irvine, which was the spatial and single nucleus transcriptomic analysis of Down syndrome and AD and comparing it to sporadic AD. And I think my perspective is more from a basic science standpoint, and I will say that my background is as a computational biologist, so different than what we're seeing today, but I believe it's very complementary. I will also say that a fun fact is that I just moved to Barcelona 2 weeks ago to start my postdoc at CNAG. Let's see. Okay, there we go. Just to start, I wanted to talk about different genetic subtypes of AD and the difference in lifetime dynamics of disease pathologies. So we can see on the right, or sorry, on the left, that the amyloid and tau deposition in autosomal dominant AD occurs at an earlier time point relative to ApoE4 related and unrelated types of AD. This tells us something that the genetic subtypes of AD confer important differences in disease progression dynamics. And this gives us a hint that underneath that, there are cellular and molecular changes depending on the patient's genetic profile. And this leads me to talk about AD and Down syndrome. We know that Down syndrome is characterized by a triplication of chromosome 21, and that on chromosome 21 is the amyloid precursor protein, which ultimately leads to an extremely high prevalence of AD and Down syndrome individuals. We can see, for example, in a Down syndrome brain, all these amyloid and tau plaques, and that in this similar plot, we can see that over the lifespan, there is amyloid-β accumulation followed by tau, and then followed by onset of clinical symptoms in the age 40 range. So our lab studies transcriptomics and omics of AD. So my PhD revolved around studying transcriptomics in Down syndrome AD patients in order to identify from a more unbiased standpoint the molecular cascade of disease. So first I'll tell you a little bit about spatial transcriptomics. As we know, like current traditional bulk RNA-seq and single-cell RNA-seq approaches lack the spatial information, which is very critical to understand in a disease that is marked by these specific pathologies which may have very localized microenvironments. Over the last 5 or so years, there has kind of been this explosion of spatial transcriptomics technologies, and it is hard to tell which to use for your particular study based on these different trade-offs. On the x-axis, we can see that there's this number of cells versus number of features, so these are genes or proteins profiled. And for our study, since we do like to do things in a more unbiased way, we selected this technology called Visium, which gives us full transcriptome information at around 5,000 spots. So I will explain to you what this technology is. We have basically this grid of spots that are 55 microns in size and spaced apart by 100 microns. And your tissue is basically affixed to a slide with this grid. And every molecule, every cDNA molecule in that spot is going to be given a unique molecular barcode, so we can bioinformatically figure out where all these RNA molecules belong to in 2D space. Okay, for the experimental design of our cohort, we have both human and a mouse model. We take cognitively normal controls, early stage AD, late stage AD, and AD and DS for these different comparisons. And of course, AD and DS is a very important part of our study as a genetic form of the disease. And for additional comparisons, we included sporadic cases that were defined by severity of pathology. And then finally, we do have, for an additional comparison, a time course of 5x FAD mice from 4, 6, 8, and 12 months in order to kind of capture the span of amyloid deposition. I'll just give you a very brief overview of this kind of data set in conclusion. So these are 8 representative samples, 2 from each condition in the human data set. Each of these spots we have a full transcriptomic profile for, and here they're colored by an unbiased clustering analysis where we can basically annotate them by cortical layers and different white matter clusters. Similar analysis in the mouse points us to different brain regions, since obviously the mouse brain is a lot smaller than the human brain. On one of these slices, we can fit an entire hemisphere, whereas this is kind of just a little slice of the prefrontal cortex. So using this data set and in my preprint on bioRxiv, there are tons of different conclusions that we've drawn from this, but in this 5-minute flash talk, I will just show you a little bit of our differential gene expression analysis that we did. So here we systematically compared each of these disease groups, early, late, and AD and DS, with cognitively normal controls. And we did this in each of these different annotations. So in each cortical layer and each of these white matter clusters, we have DEGs that are upregulated in disease and downregulated in disease for these 3 different groups. And we want to point out, very importantly, that many of these changes are in cortical layer 3-4, where we see a lot of amyloid deposition. When we kind of split this apart by chromosome in the DSAD group, we kind of do see that there's this big spike in DEGs on chromosome 21, but it's very important to note that there are transcriptome-wide changes across all chromosomes. And this plot is very colorful and complicated, but I'll try to explain it to you. So within each of these sets of DEGs, we can break it down by what cell type is expressing that gene. And very importantly, we do see a lot of these yellow colors are going to be vascular cell types like endothelial cells, pericytes, smooth muscle cells, fibroblasts. The orange are going to be astrocytes. So most of the signal in the genes that are upregulated in disease are actually coming from these vascular cell types. Maybe very interesting considering previous talks we've heard today about the blood-brain barrier breakdown. And this result is really interesting to me where in the early stage of disease, more specifically, we are seeing a lot of white matter and oligodendrocyte genes downregulated. So if you want to learn more about this, you can check out our preprint, and it should be published in the next couple months this year. And we're working on an interactive data portal, so you can query a gene, you can see which cell type it is active in. But for now, if you are really curious about a gene, like if you're interested in galectin-3, you can email me, and I will give you a plot. So I would like to thank, I would like to acknowledge my lab, especially my lab mate Emily, who is the co-first author on my study, and my advisor Vivek. All of our funding sources, our collaborators at UCI Mind, especially Elizabeth Head, who helped us design this cohort and who got the Swarup lab very interested in the DSAD component, as well as Kim Green's lab at UCI. And thank you for your time.
Thank you. Any question? So we will move to the next speaker.
Thank you.
Thank you. Our next speaker is Charlotte Jacob from the University of Antwerp, and she will be speaking about the correlation between monoaminergic biomarker, classical biomarkers, and the BPSD, DS2 behavioral scale in Down syndrome with and without Alzheimer dementia. Thank you.
Hello everyone, I'm Charlotte Jacob. I'm a PhD student under the supervision of Debbie Van Dam at the Laboratory of Neurochemistry and Behavior, and today I will tell you a bit about our behavioral assessments of the BPSD DS2, the biogenic amines and classical biomarkers, and how they all correlate with each other. So first I'm going to give you a bit an outline of the project. So the BPSD, it stands for Behavioral and Psychological Symptoms of Dementia in Down syndrome, and part 2 because there was first a first test, which we optimized and validated. So why BPSD? People with Down syndrome and Alzheimer's have really characteristic behavior patterns, which we like to categorize, and we question all these different types of behavior with this questionnaire. And as you can see, there are a lot of different things that we score on. But the two main points are the frequency and the severity changes, which means the frequency, so how often does a behavioral pattern occur? And the severity changes means how bad is it for the patient itself, the individual with Down syndrome themselves. So this is the outline based on biomarker profile. So basically we had a population of about 191 patients with Down syndrome, which we categorized into individuals with Alzheimer's, without Alzheimer's, and with questionable Alzheimer's, of which we collected serum. And we put the serum on a Simoa assay to collect data regarding the classic biomarkers, by which I mean amyloid-β 42, amyloid-β 40, p-tau181, GFAP, and NFL. And on the other hand, we used reverse-phased UHPLC with electrochemical detection to analyze different monoamines such as adrenaline, noradrenaline, or epinephrine and norepinephrine, dopamine, serotonin, and all their metabolites. So here I'm going to give you a quick overview, a little highlight of the results where we looked at an association between the diagnosis, which is based on clinical data, so by a clinician, and the indication of dementia, which is based on the results of the BPSD DS2. So as you can see, we saw that there was a difference between the patients without dementia and with questionable dementia and dementia based on NFL levels, GFAP levels, and p-tau181 levels. And then the indication regarding whether they had an indication or no indication of developing Alzheimer's was based on the levels of serotonin and the serotonin degradation, so the 5-HIA serotonin metabolism. Here we also looked at the correlation between the BPSD2 sections frequencies, so all these different sections that I showed you in the first slide, and the different biomarkers. And as you can see, let's see if this works, there was a negative correlation for amyloid-β 42 and amyloid-β 40 regarding aggression. There was also a negative correlation regarding MHPG, which is a precursor of norepinephrine, and disinhibited behavior. And finally, over here, you could see a positive correlation between GFAP and apathetic behavior. So that was it in a really short presentation. I want to thank the people of my lab, especially Professor Debbie van Dam, and the people of the neurochemistry laboratory as well in Amsterdam, as well as the people from the different fundings, and of course everyone who works to collaborated with us to make this test and this analysis even possible. So thank you.
Great. Great talk, thank you. We have time for one question. Maybe I can ask you, among the different biomarkers that you had, which one was the most sensitive to detect the dementia?
The most sensitive one was, you mean regarding the classic biomarkers or in general?
Both, in general.
The one we actually saw the biggest, most meaningful results with was actually serotonin, which is not per se what we expected, because we expected MHPG to be more robust. But yeah, it was serotonin, so.
Okay.
Thank you.
Thanks.
The next speaker is Isabel Barroeta from Hospital of the Sant Pau, and she will present the Down Syndrome Biobank Consortium, an initiative to advance research on Alzheimer disease in Down syndrome.
Hello, everybody. So I think that by now we are all aware that the main medical problem for Down syndrome adults is Alzheimer disease, and it has a almost full penetrance, and by the age of 52.8, they start showing dementia caused by Alzheimer's disease. And this is a challenge for everybody. So now we have to do an early diagnosis, and then we have to be able to include them in preventive clinical trials that now we know that are feasible. As we can see, for example, with experience with the TRACK-DS and the AC24 study and the APPdup study that is now going on. So the thing is that we still have a gap in the some neurobiology mechanism, and that's why we think that maybe that could be because we don't have access to the tissues or to biofluids, and that's why we started this consortium called the Down Syndrome Biobank Consortium to create a repository with tissues and biofluids. And it's an international consortium that is now confirmed at 11 sites, including sites from Europe, India, and the States, and with a highly productive and well-known research groups in DSAD-ADAD. There are 8 dedicated neuropathologists that are supervising and orchestrating the dissections and the staining of the brains, and there are 8 clinicians with highly experienced in the management and assessment of adults with Down syndrome. So what we have achieved until now is that we conducted training sessions to harmonize the tissue collection protocols. We had distributed to the sites a brain carrying apparatus, a brain jig, and we've developed a standard operating procedures for tissue collection. Then for the dissemination of the tissue and biofluid, we have received over 30 brain donations by now, and we can offer access to more than 300 DS or DSAD donated brains, as well as AD, familial AD, and very important age-matched non-DS controls and associated biofluids. And what I want to highlight that we have active clinical cohorts, so we are collecting long-term medical information, clinical assessments, and neuroimaging. So all of members of this consortium as well, we have experience and we are able to talk with families about brain donation. Until now, in terms of the access of the information, we've developed REDCap data and a website where we can see which is the information that is available, and we provide access to this valuable information for all research. So we had 30 tissue requests until now and more than 35 publications providing unprecedented access to high-quality tissue for scientists in both the DS and the AD field. We want to enhance research with the idea to develop novel treatments in that way. And in summary, this consortia, the input is to collect brain tissue from clinical, well-characterized DS cases with appropriate controls and associated biofluids, and the output is to distribute these samples via a centralized website and a REDCap database. In the future direction, of course, we would like to continue doing that, and we are welcoming other sites to join us. All researchers from across the world are welcome to do the requesting for tissue. And as a final thought, I wanted to share with you that the way to get the most out of biological specimens is not only prospectively banking samples, but finding ways to coordinate researchers that have already collected them for their own questions. And I think this audience could be better to do that. Thank you for your attention. And of course, thank you for the families that are allow the brain donation, and for the unit, I don't know. Okay, and it's the same slide. I'm here in the memory unit, so thank you very much.
Thank you, and congratulations for this initiative. Any questions in the audience?
Yes, hello, Isabel. I would like to know what is your experience when asking to the families to donate the brain. I think it must be difficult, no, to ask such questions, and what is the reaction of the families? Thank you.
Okay, so we've been doing this question now for almost 4 years, and we have registered about 30 families for the donation. We've had 9 donations. I think that most part of families, you would be surprised, but they really want to help. So it depends on how you bring the question, and the timing is very important. The way we are doing that is to link that to the research, and we don't wait until the patient has developed dementia or is in a very late stage of the disease. We bring that conversation during the follow-up, and we're explaining them that this is one key piece in the research program we have. Is not different from the other studies we are doing. And it depends. For example, there are families that they would like to participate in research, but they cannot because, for example, the person is not able to underwent an MRI, for example, so they think they can help in another way. So it's a conversation that you can have, no different from other programs, and of course you have to be sensitive and do it in a way that they don't feel that you are asking them or like putting them in a situation where they don't want to talk about it. But it's been very helpful as well to have the coordination with the hospital clinic with Ivan and Laura Molina, and they have as well experience. They have material that we share with patients with all the information, and sometimes they just ask for time to think about it, and then you ask the question 1 year after, and then they talk with families. Yeah.
Thank you, Isabel.
Thank you.
It is now my pleasure to present Inigo Rodriguez-Bas from the São Paulo Memory Unit, who will be presenting his work about predominant visual perceptual dysfunction in a patient with Down syndrome-associated Alzheimer disease.
Okay, good morning to everyone, and thank you very much for letting me this minute for sharing this case with you. As you maybe know, posterior cortical atrophy syndrome is an atypical variant of Alzheimer disease, primarily involving visual perceptual symptoms and typically manifested at earlier stages than the amnesic variant of Alzheimer disease. So Down syndrome is a genetically determinant form of Alzheimer disease. To date, well characterizes PCA cases in this population remain absent. So today we will discuss a case of PCA in a patient with Down syndrome. The case involved us, it was a 39-year-old male, right-handed with Down syndrome who presented cognitive decline over 18 months. Between their medical history, he had dyslipidemia, hypothyroidism, and cataracts that were surgically treated at the age of 29 years old. And in his occupational and social background, he attended to the ordinary school until the age of 16. After that, he had vocational training, and he also were doing professional activities, and he didn't have any legal incapacitation. as primary symptoms, his family reported the difficulties in navigation and also in object perception deficit. He has also difficulties for recognition of faces, and during the evolution of the problem, he developed a problem also in episodic memory, language, and even due to the visuoperceptual disturbances, he has some problems in motor skills. All this led to an impossibility to work and also to an inability to perform some self-care activities like, for example, dressing. In neurological examination, it was evident an space perception deficit, also oculomotor apraxia and optic ataxia was evident. He needed assistance during the gait evaluation, and no other relevant symptoms were observed during the neurological examination. The previous intellectual disability was considered mild based on caregiver report. Here, it was also observed object identification deficit, and here we can see a task where the patient is asked to encircle each house, and we see how the patient was not even able to complete the task. We could recognize visual agnosia and visual neglect, also visoconstructive apraxia. We can see here he is not even to draw a circle or a clock. Also ideomotor apraxia, severe difficulties in writing and reading, and at the point of the assessment, he had also some problems with episodic memory, also impaired frontal executive function, and some language disturbance. Laboratory tests ruled out secondary causes of dementia. APOE33 was determined, and cerebrospinal fluid core biomarkers were consistent with Alzheimer disease physiopathology. In neuroimaging, global cortical thickness reduction was observed, but predominantly in parietal and occipital lobes. In sagittal slides, we can appreciate severe atrophy in cuneus and precuneus, and also we can see a relative spare middle temporal lobe. Here in the FDG PET, we also can see hypometabolism in parietal and occipital region, and the tau PET uptake was predominantly also in these posterior areas, as well as the lateral temporal lobes. So, in conclusion, we have documented a case of cognitive decline at dementia stage due to Alzheimer disease. This is atypical because of the visuoperceptive symptoms and the early onset of them. This is the first case of PCA syndrome due to Alzheimer disease in Down syndrome population individual. So thank you very much for your attention.
Great presentation, thank you. Great presentation. Is there any question? So I think it's very nice to address the heterogeneity of the clinical expression of Alzheimer's disease in Down syndrome. Are you aware if there is other atypical form that has been described across the world?
In Down syndrome population?
Yes.
No, it isn't. There is just one case, a reported case from France. I'm related to PCA also, but there are not so many data as we have. And there is not other unusual variants, focal forms of Alzheimer's disease are reported, or at least I didn't have any knowledge about that, and I have researched a lot on the literature. So.
Okay, thank you.
The next talk is cerebral vascular disease and neuroinflammation, enhance the classification accuracy of Alzheimer's disease-related clinical diagnostic conversion in adults with Down syndrome. It will be presented by Natalie Edwards from Columbia University.
Hi, everyone. It's wonderful to be here with you today to discuss the vascular inflammatory interface and its associations with Alzheimer's disease pathology and diagnostic conversion in adults with Down syndrome. First, I want to acknowledge that I get to present this work on behalf of my incredible co-authors and collaborators, mainly my mentor, Dr. Adam Brickman, and Dr. Patrick Lau. We know that Alzheimer's disease presents with a tremendous amount of heterogeneity at autopsy, the most common co-pathology being vascular pathology. However, vascular disease is most often considered simply a comorbidity that contributes additively to the symptoms of dementia. Well, we can look at these relationships in genetic forms of Alzheimer's disease, which are often considered pure AD, because individuals with autosomal dominant AD are, of course, younger and don't have the same vascular risk confounds. And as was discussed earlier, individuals with Down syndrome have extremely healthy vessels and seem to be protected against developing something like hypertension. Despite this, though, we still see evidence of cerebrovascular pathology in genetic forms of AD. This work done in the DIAN study found that individuals with autosomal dominant AD had elevated white matter hyperintensity burden, which is an MRI marker of small vessel disease, in comparison with non-carrier controls. And when we look at this in Down syndrome, this work done by Dr. Patrick Lau found that there is, copious amounts of evidence of vascular disease on MRI that progress along with the AD continuum. Not only is this, suggesting some sort of endogenous or innate vascular component to the disease, but again, this work by Dr. Lisi Flores Aguilar has shown that individuals with trisomy 21 have a uniquely elevated inflammatory profile across the lifespan. So what we wanted to do in our cross-sectional work last year was to see if these two factors, if vascular pathology is indexed by white matter hyperintensities and neuroinflammation as indexed by plasma GFAP, which is a marker of astrocytosis, were related to each other and were related to Alzheimer's disease pathology. We use plasma biomarkers to do this. And we found that white matter hyperintensity burden was in fact associated with p-tau217, and this statistical relationship was mediated by neuroinflammatory factors. And this pointed to some sort of pathophysiological cascade that we started to kind of hypothesize in adults with Down syndrome. So this leads us to my new work, which is looking at if baseline measures of vascular burden and neuroinflammation are associated with the conversion from a more mild to a more severe, longitudinal diagnosis, that being from cognitively stable to MCI, MCI to AD versus remaining stable, and if these two factors are able to actually classify individuals as converters or non-converters. And we looked at this in 149 participants from the Alzheimer's Biomarker Consortium Down syndrome. These individuals, again, were cognitively stable or MCI at baseline and had at least 2 time points of clinical consensus data and a baseline T2-weighted FLAIR MRI and plasma AD biomarkers. And we can see here in that first kind of aim I highlighted that, in fact, white matter hyperintensity volume and plasma GFAP are independently associated, higher levels of these are independently associated with a greater odds of conversion to a more severe clinical diagnosis. And this was accompanied by p-tau217, which wasn't very surprising, but again, higher levels of vascular burden and neuroinflammation are associated with incident MCI and dementia. And when we look at if we can build models to actually classify these individuals as a converter or a non-converter, we see here again that both GFAP and white matter hyperintensity volume are able to do so with an accuracy that is akin to that of amyloid and neurodegenerative pathology. Unsurprisingly, again, p-tau217 was our most accurate independent classifier, but its accuracy was enhanced when we added in, our vascular and inflammatory confounds. And one of my favorite results is actually when we just look at predicting conversion status based on the interaction between vascular and inflammatory pathology. it does so with an accuracy that is modestly akin to that of tau pathology. But the key here really is that when we add in, both this interaction and, of course, our classic, tau pathology predictor, we are able to classify individuals with incident MCI or AD more strongly with vascular and inflammatory pathology than traditional AD biomarkers alone. So with that, our conclusions from this are that this interaction between vascular and inflammatory pathology is really emerging to be critically important, and that markers of vascular disease and neuroinflammation can independently, are associated with this greater odds of conversion to a more severe clinical diagnosis. And so our future work now is trying to see what upstream factors are contributing to the presence of cerebrovascular disease in the absence of vascular risk factors, and what other mechanisms might be involved here. Thank you all for your attention.
Nice talk, thank you. Is there any question?
Hello, thank you so much for this wonderful talk. I wanted to ask if you're aware of any neuroinflammation PET imaging data in terms of Down syndrome associated AD, and if so, if there are any differences compared to sporadic AD in terms of diagnosis?
Mm-hmm. So not to my understanding, there hasn't been any inflammatory PET done in the Down syndrome cohort, but it is being done in other cohorts.
Okay, thank you.
Yeah.
We will now move to our next speaker, Sara Gutiérrez Fernández from the VIB Center for Brain and Disease Research in Leuven, who will be speaking about molecular basis of clinical onset in familial AD.
Hello. So my laboratory is interested in the underlying mechanisms of familial Alzheimer disease, the autosomal dominant form of the disease, to gain insights into new therapeutic avenues. FAD is caused by mutations in three functionally related genes, presenilin-1 and presenilin-2, the catalytic subunit of the enzyme gamma secretase, and APP, the substrate responsible for the generation of A-beta peptides. Gamma secretase cuts APP in a rather unique sequential proteolytic manner that leads to the generation of A-beta peptides of different lengths. FAD mutations consistently impair this processive cleavage of APP. The FAD mutations share a common mechanism, and previous studies from my lab already show that what they do is they destabilize the enzyme-substrate interaction and thereby lead to the premature release of longer and more toxic amyloid-beta peptides. And this degree of destabilization correlates with the age of onset. But now we wanted to further know if this molecular composition of the A-beta profiles arising from this destabilizing nature of the mutations is at the core of FAD pathogenesis and defines the age of onset. What we know is that the age of onset is consistent between families and carriers of the same mutation, but remarkably differs between carriers of different mutations. So why some mutations manifest symptoms that get earlier than others is still not well understood. And up to now, there is no consensus of which A-beta species best reflects AD pathogenicity and severity. To investigate that, we select several presenilin-1 mutations with different age of onset, and we analyze these A-beta profiles in as comprehensive manner as possible, analyzing the vast majority of generated A-betas. So compared to the wild type and the controls, as you can see here, all the FAD mutations, they shift these A-beta profiles towards the generation of longer and more toxic A-beta species, A-beta 42 and A-beta 43. Then we wanted to study the processivity of the enzyme using this ratio that is a measurement of the processivity along both product lines. And as you can see, all the FAD mutants show an impairment in the processivity of the enzyme, and this nicely correlates with the age of onset. So with this strong linear correlation, we are able to define the age of onset experimentally, what we call the biochemical onset, and we are able to also set the pathogenicity of the mutations in vitro. But we wanted to know if we could predict the onset, since many of the mutations occur de novo, or there is no information about the family history, or there are really few cases. The only mutation that has enough carriers to do epidemiological studies is this FISA mutation. So we wanted to determine the onset of this mutation experimentally, and we observed that the biochemical onset matches the reported one. So we gain confidence, and we analyze other mutations with few carriers or mutations with unclear pathogenesis. As you can see, for some mutations, the clinical and the biochemical onset matches, but for other mutations, there are some mismatches in the biochemical and the clinical onset, and we can see that there can be genetic modifiers of the onset, such as APOE2 or APOE4, as is also reported in the literature with opposite effects. And we also have this special mutation that we call inactivating mutation. This mutation has really low total A-beta levels, so really low global gamma secretase activity, but it has a really pathogenic-like A-beta profile. Even though it has really pathogenic A-beta profile, there is a delay in the onset. So we hypothesize that this inactivation, so this impairment in the global activity, is somehow silencing the disease allele and is counteracting its pathogenic effect. Then we move forward to presenting two variants that are much less known. As you can see, only 6 of them are categorized as pathogenic or likely pathogenic, and for the rest there is no information. Also, the age of onset is much more broad within the same mutation. So here it's much more important to set or to define an onset experimentally. We did the same analysis, and as you can see in this lower graph, some mutations already show significance, suggesting the pathogenic nature of these mutations. So for those mutations, we correlate with the onset, and we still find a linear but weaker correlation for presenilin 2 cases. And the main difference with presenilin 1 is this delay in the onset of approximately 30 years. We also observe that presenilin 2 mutations have lower total A-beta levels, so mimicking this inactivating effect I previously mentioned. So this is likely explained by a lower contribution of presenilin 2 complexes to APP metabolism in the brain, related to presenilin 1. As a conclusion, this study is important in clinical setting to assess these ambiguous FAD mutations. It's also important for genetic studies in the identification of genetic modifiers of the age of onset once there is a mismatch between the biochemical and the clinical onset, and for transnational studies, therapies aiming at shifting these A-beta profiles towards the generation of shorter species or towards the silencing the mutant allele, which both of these approaches can delay the age of onset. So I want to thank all my lab and all of you for your attention.
Thank you, Sara, for this presentation. Is there any comment?
So thank you for this massive amount of work.
Yes,
so did you get all the results from brains of patients with this mutation, or is it cellular model?
So this is a cellular model of mouse embryonic fibroblasts, just on a double knockout background that we rescue with all the different presenilin mutations. But there are also, not from me, but there are also some data from patients that also, for some of the mutations, they also see the same. But for me, it's always in vitro with this cellular model. Yeah.
Thank you. The next speaker is Fernando Gonzalez-Ortiz from Gothenburg University, and he will present plasma p-tau 217 in a severity and progression biomarker in Niemann-Pick disease type C.
Thank you so much. I would like to thank the organizing committee for allowing me to present this topic that I know it's not obviously related to Alzheimer's disease or Down syndrome, but I think it's really interesting, and I will connect it with this. And also I would like to quote Kevin Talbot from Oxford University, which pondered the question like rare diseases, butterfly collecting, or an entry to common, understanding the common. So I think that Niemann-Pick type C is a very interesting condition. It will allow us to understand a bit more about tau pathology and the meaning of blood-based biomarkers. So first of all, Niemann-Pick type C and Alzheimer's disease are distinct neurodegenerative disorders with different neuropathological backgrounds, but they share interesting similarities. And maybe the main similarity is the presence of neurofibrillary tangles in the brain, composed of hyperphosphorylated tau. And one of the unresolved questions is what exactly phospho-tau in blood actually means. So This is just a representation of Niemann-Pick disease type C. It is a very special variety, even among the Niemann-Pick diseases, because it's not associated to the sphingomyelinase mutations, but it's more a disease of the transport in the intracellular compartments. It's something like Wilson's disease, but with lysosomes in the brain, and it also has some visceral affection. So as I said, there's this question of like, what exactly does phospho-tau mean in blood? And multiple studies have shown that strong correlations exist between amyloid pathology assessed by amyloid PET and levels of phospho-tau in blood and in CSF. And these associations have led to the conclusion that actually phospho-tau is an amyloid marker. But what happens with conditions that are amyloid negative but still have increases in phospho-tau in blood? So in this study, the authors showed that tau tangles and tau accumulation can actually be measured using tau PET in patients that are amyloid negative and that have Niemann-Pick disease type C. And another very interesting question is that if we analyze the composition of the neurofibrillary tangles in AD brain and Niemann-Pick C brains, they actually have a similar pattern of phosphorylation. This is a very old article in which they compare the brains in AD and Niemann-Pick disease type C, and they use different phospho-tau antibodies, and as you can see, the pattern of phosphorylation is very similar in these two. So for this study, what we did is that we took a cohort consisting of 71 patients with Niemann-Pick disease type C. So we have 71 patients at baseline, and we also have follow-up for most of the patients in this cohort. And then we measure plasma p-tau217, p-tau231, and neurofilament light. And also we compare our results against sporadic AD using another cohort, dementia disease initiation, a cohort from Norway consisting mostly on Alzheimer's disease patients. And then we use the annual severity increment score and the LISO tracker method to assess severity and progression in the patients with Niemann-Pick disease type C. So these are the results. First of all, we compare the concentrations of plasma p-tau217 in Niemann-Pick C against controls. And as you can see, the levels are significantly higher in the NPC group when compared to controls. And also, they have a good accuracy discriminating between these two groups. Obviously, we are not going to use p-tau217 as a diagnostic marker in Niemann-Pick disease type C, especially when there are other methods available, but I just wanted to show the accuracy to differentiate between these two groups. And also we observe a negative correlation with age of disease onset. And this was very interesting because usually the more aggressive forms of the disease start in early ages of life. So we observed that among those patients with more aggressive forms of the disease, the levels of p-tau217 were higher than in other forms. Longitudinal measurements, we check the associations of plasma p-tau217 with LISO tracker measurements, which assess the lysosomal impairment or the level of lysosomal dysfunction. And we also observe positive associations with the annual severity increment score, which is a score that basically talks about disease progression. When we divided the patients according to age groups, we observed different trajectories according to different ages. And if you see the green line, those are the younger patients, and they start with higher concentrations of p-tau217, and they maintain these concentrations high during the whole time that we follow up these patients. We also measured p-tau231 and NFL. I won't talk too much about them, but I have to say that they were both higher than controls, similar to p-tau217. What makes p-tau217 special in Niemann-Pick type C is that the associations with age and with LISO tracker, with lysosomal dysfunction, were weaker for p-tau231 and for NFL. Finally, how does it look when you compare Niemann-Pick type C against AD? The first thing is that we observe that AD has significantly higher levels of p-tau217. But also something that I want to remark is that the AD group has like a mean age of 60, and this group of Niemann-Pick type C has a mean age of 17. And then what we did is that we divided the AD group according to CSF biomarker positivity in amyloid positive, tau negative, and amyloid positive, tau positive, just as a way to assess. And we observed no significant differences between Niemann-Pick type C and amyloid positive patients with tau negative in CSF. It's only when there is amyloid and tau pathology that the levels are significantly higher. as conclusions, high levels of p-tau217 were associated with disease severity and progression in patients with Niemann-Pick disease type C. Beyond the potential applications of Niemann-Pick type C, our findings suggest that p-tau217 and phospho-tau markers are not amyloid-dependent markers. They are amyloid-associated markers. And other conditions can also increase levels of these markers, and they need to be taken in consideration. And beyond this, understanding this tau pathology and Niemann-Pick type C can help us to develop new therapeutic targets or new therapies that target tau instead of amyloid. Thank you so much for your attention, and thank you so much to all these people.
Thank you, Fernando, for this very interesting talk, but we have time for questions. Thank you very much.
So we will move directly to our next speaker, Charlotte Johansson from the Karolinska Institute, that will speak to us about electrophysiological biomarkers in AD-AD.
All right, so my name is Charlotte Johansson. I'm an MD and a PhD student at the Department of NVS at Karolinska Institutet in Stockholm. My supervisors are Caroline Graff, Vesna Jelic, and Kai Blennow. And importantly, this work has been performed in collaboration with Professor Thomas Koenig at the University of Bern. So electroencephalography, or EEG, is a known biomarker of synaptic dysfunction in Alzheimer's disease. And basically, it measures synchronized post-synaptic potentials from pyramidal cells in the cerebral cortex using electrodes at the scalp. And also, EEG signals form transient global topographies of scalp potentials, so-called EEG microstates. And EEG microstates reflect short-lasting, spontaneously forming large-scale neurocognitive networks. And by measuring in time how much time is spent in the different microstate classes, we can quantify what different cognitive networks were activated during EEG recording in an individual. It's been suggested that EEG microstates might be better than conventional spectral or connectivity analysis to detect transition to mild cognitive impairment. In this work, we hypothesized that the EEG microstates are candidate markers of disturbed temporal dynamics of EEG during the Alzheimer's disease continuum. The aim was to explore EEG microstates in pre-symptomatic and symptomatic mutation carriers, PMC and SMC, compared to healthy non-carrier controls, NC, in families with autosomal dominant AD. Participants were included from the longitudinal Swedish familial Alzheimer's disease study at Karolinska Institutet, here represented by families with the APP Swedish double mutation, the APP Arctic mutation, and one presenilin 1 mutation. In all, 94 recordings from 49 participants were selected, and PMC and SMC were again compared to NC. In short, the EEG recordings were pre-processed and cleaned and then assessed to determine the optimal number of microstate maps to explain the variability in the data. Next, parameters of coverage, mean duration, and mean occurrence were calculated and introduced into a linear mixed model. The main findings were these. You see below the different topographies or microstate classes that we identified, 7 of them to best explain the variability in these EEG recordings. In the plot, you have on the y-axis the predicted mean of coverage, and this variable means basically the percent time spent in each microstate class. Then in the x-axis, you have the different microstate classes A to G. In black, you have non-carriers. In yellow, pre-symptomatic mutation carriers, and in red, symptomatic mutation carriers. And what we found was that the coverage was decreased in class C in symptomatic mutation carriers compared to non-carriers, and this was also a trend in comparison to pre-symptomatic individuals. The opposite was true in class E. Here we had an increase of coverage of class E in both pre-symptomatic and symptomatic individuals compared to non-carriers. Yes, so what conclusions could we make? Well, first, by going back to the literature, we found that the topography of our microstate classes did harmonize with previously published maps, so this was comforting. And for the decrease of coverage in class C in symptomatic mutation carriers, this aligns with data from sporadic Alzheimer's disease, and we suggest that it's a disease effect. Interestingly, class C has been linked to the default mode network. Next, class E. This increase of coverage in class E in symptomatic and pre-symptomatic individuals is shown for the first time, and we speculate that it might be a mutation effect. The functional correlates of class E, however, remain largely unknown. It has been suggested to be linked to processing of emotional information on the salience network, but there are more work to be done here. So that was all for me. I want to thank our participants and our families, and of course our collaborators. Thank you.
Great presentation. Please keep your question for Charlotte for the lunch break. And we will move to the next speaker.
The last talk is improving IQ measurement in Down syndrome by using true deviation from population norms with the Kaufman Brief Intelligence Test, and is presented by Laura de Hoyo Soriano from the Hospital de San Pau.
Hi everyone, I will try to be very brief as we are already out of time. So the title of my presentation is actually Eye Care Measurements Among Adults with Down Syndrome and Addressing Challenge and Exploring Solutions. So the most used cognitive assessments that we use nowadays to measure general cognitive status in Down syndrome is the CABIT, the version 1 and the version 2. We also use the Stanford Binet, but it doesn't have a validated Spanish version. And we also use the later, which is like a pantomime version, which is just nonverbal cognition. So the age range usually goes from 3 to 99 for the CABIT and the Stanford Binet, while for the later is from 2 to 22 years of age. Usually the IQ type score range that we get from those assessments goes from 40 to 160. So which type of scores do we usually get from those tests? First, we have the raw score, which is the direct score, and then we have the standardized scores. On one side, we have the zeta scores. Zeta value is actually the raw score of the participant minus the mean score of the distribution divided by the standard deviation of the distribution. And then using zeta scores, we can get IQ scores, which is the typical score where we multiply the zeta score per 50. And then we sum 100. And then we have the t-scores, which is basically the same, but usually using a different standard deviation and mean value. So the thing here is that the mean values and the standard deviation values that we use to get the zeta scores are based on typical developing participants or age-matched peers. So for this reason, what we get worldwide when we have IQ scores in Down syndrome is a horrible floor effect, where more than half of the population usually get a score below 40. This is not informative for people below mild intellectual disability because we have moderates, we have severes, and we have profounds, but these three levels of intellectual disability always come in the same bag. So our study is also based on the Dabney cohort. We have an initial sample, and then from that sample we have excluded participants based on being nonverbal or because they were cognitively impaired to a point where the cognitive assessment was not possible. So I'm gonna present here our results where we try to recalibrate those IQ scores using our population norms. So these are the characteristics of our sample. And this is the IQ or the t-scores distribution that we get in our sample using the manual tables. So again, as you can see, the first graph is the general IQ score for the CABIT. The second one is the t-score for the vocabulary part. Then the third one is the total t-score, and the last one is the matrix of the nonverbal. So the distribution is quite bad. So what we are proposing here is to recalibrate the standardized scores, and instead of using the mean of the distribution for the general population and the standard deviation, we are proposing to use the means in our large cohort. So we are dividing the age ranges as in the manual. The first proposal is to do it by age ranges. So we are using the same age ranges of the manual. Here you have the mean values and the standard deviation values for each range. And then we are proposing to use T-scores rather than EQ scores, because a mean score of 100 for a participant with Down syndrome wouldn't be realistic, while 50 is more representative in terms of its clinical use. And because of this, which I'm not going to explain because it's been showed in previous presentations, we are also proposing to recalibrate those scores by using AD progression. So those different mean and standard deviation values in relation to the ranges could also be depending on if the participant is asymptomatic, if it's in a prodromal stage of the disease, or it's with Alzheimer's disease. Also, we use a regression model and to see which independent variable is better explaining variability in raw scores in our IQ. We can see that the variables are in Spanish, but we can see that the age of the visit is better explaining the model than the diagnosis, although the diagnosis is also explaining quite well the model. Here you can see the distribution of the sample. One, we use our mean and standard deviation values rather than the general population deviation values. So the distribution is way better. And here you can see it by diagnosis. The distribution is good too, but it looks better in the previous slide. So because age and AD stage is very well correlated in Down syndrome, we are also doing this parallel analysis where we are seeing the link between our T-scores by age and age by diagnosis. So in the first graph we are seeing how the T-score based on age ranges is related to the age in the visit for the full sample. As expected, there's no relation because we are controlling for age. When we separate the graphics between those that have AD, even if it's prodromal stage or in a dementia stage, we see that there isn't a relationship between age and the T-score. But when we sit in the full sample, we also don't see a relation. However, and as expected, when we use the raw values of the general score, we see that it's only related with age for those who are asymptomatic. Could be that there's more age variability in this group than in the prodromal and demented group, but that's what we see. Here are the values. Also, here we see the link between the T-scores by age ranges and the AD diagnosis. We see that, yes, there is, there are differences between groups, but not like huge differences between groups. That's what we see in the first graph when using our recalibrated scores. While in the second graph, which is the IQ scores using the data in the manual, we see that this graph is not informative at all because, again, no, we have like half of our sample scoring below 40. So here are also like the mean values in case you are interested to see more in detail the differences between the diagnosis groups by using our recalibrated score. And another important thing when you want to validate a new IQ model, you want to see its external validation, and we want to see how it is related to the level of intellectual disability categorized using the DSM, and we see a really nice correlation in the first graph when we use our method, where you can see No. But when using the typical IQ method, using the manual, we again see differences between mild and the rest of the group. But there's a lot of sound in moderate, severe, and profound that we are not capturing using the typical IQ model. Here we can see also, we are also, again, for the external validation of our recalibrator method, we are looking for the link between the recalibrated scores by age range in the first graph and by AD continuum in the second graph, which is pretty similar. And one autonomy scale developed by one of our neuropsychologists, Bessy Benejam, which is looking to different outcomes in terms of autonomy in the day-to-day of individuals with Down syndrome. And again, when using the typical developing CETA scores, it's useless. This is the method developed by Bessy. In case you're interested, it's in bias of being. Yes, and then the take-home message that we take and the future steps. First, conversion tables and CETA scores based in general population are useless in Down syndrome, and this is not something that I'm saying. It's something that we can see it everywhere. They are just doing the separation between mild and the rest. And in the rest group, there's a lot of sound that we are not capturing with this method. Maybe with mild participants is still useful, but not in the rest of the group. So our goals are to publish our means and standard deviations values in our large cohort, so it can be used as a reference from other researchers or clinicians to better determine the standardized values of overall cognition in adults with Down syndrome. Also, we promote the use of T-scores rather than EQ scores in individuals with Down syndrome because it's more representative, a mean of 50 than a mean of 100. And then we also want to validate our autonomy scale, which Bessy has developed, because that will be helpful for us in terms of the external validation of our calibrated scores. And this method should be implemented in all other IQ tests. This is now implemented with the CABIT because it's the one that we are using, but it could be also implemented in the Stanford VNet or in the later, as long as we have large cohorts.
Thank you, Laura, for this important data. And I would like to thank all the speakers and my co-chair for this excellent session. It is now time for lunch, and I invite you to come back at 2 p.m. So the lunch will happen in the outside where we made the coffee break.
Hola. Hi. Hello. Good afternoon, everyone. Thank you very much for coming to this wonderful meeting. And I have the pleasure to co-chair this session, which is Biomarkers 1, together with Dr. Lisi Flores Aguilar. And now I will present the first speaker of the afternoon, Dr. Sandra Jimenez. She's a clinical neurophysiologist and a sleep medicine specialist with a doctorate in sleep neuropharmacology, and she combines her clinical and research activities in the memory and sleep unit and the Alzheimer Down unit in Hospital de São Paulo, with a main focus of research on the relationship between sleep disturbances and cognitive decline, both in the general population and in Down syndrome. Thank you.
Okay. Thank you very much for the presentation, and thanks for the organizer to allow me to present our work. So I will talk about the impact of Alzheimer's disease in adults with Down syndrome. And as you know, there's growing evidence that underline the bidirectional relationship between sleep and Alzheimer's disease in general population, and with sleep disturbances that appear early before the onset of cognitive symptoms could be an early markers of neurodegeneration, and also it has been proposed that could be a modifier risk factors for Alzheimer's disease. In turn, we know that Alzheimer's disease increased the prevalence of sleep disorders, and in these patients with more sleep disorders, these worse and accelerate the progression of the disease, being sleep disturbances one of the main causes of institutionalization of these subjects. As you all know, here Down syndrome is a genetic form of Alzheimer's disease which presents a very high prevalence of sleep disturbances. Some years ago, we published a paper with a community study in adults with Down syndrome, asymptomatic, and we reported a very high disruption of sleep and with a very high prevalence of obstructive sleep apnea, that, however, these sleep disturbances were not captured by the subjective sleep reports and neither reported by the caregivers. So these sleep disturbances are really very often, not saying almost always, unnoticed. So the triplication of chromosome 21 confers some craniofacial abnormalities and functional as hypotonia, which confer and predispose subjects with Down syndrome or population across the whole lifespans to present obstructive sleep apnea, which this risk increase in adults due to the development of other comorbidities as hypothyroidism or obesity. So OSA is a sleep breathing disorder that results from stop breathing, repetitive stop breathing during the night, which produce a sleep fragmentation, and this intermittent hypoxia and sleep fragmentation with reducing in REM sleep and slow sleep has been proposed as a mechanism that will accelerate the neuropathology of Alzheimer's disease. However, there's still very scarce data that have investigated the relationship between sleep and Alzheimer's disease in Down syndrome population. But fortunately, there are some groups that we are already starting to assess this relationship. And here, what we are doing in Barcelona group, as already explained before, in this multimodal assessment in this preclinical phase of Alzheimer's disease. So we include the sleep study to investigate if these sleep disturbances could accelerate this progression from preclinical to symptomatic AD. However, we still do not have data that investigate the relationship of Alzheimer of sleep in patients with already dementia. So That's what the main focus of this study was a multicentric European study with the consortium Horizon 21 network, where we wanted, and funded by the Jérôme Foundation, that we wanted to assess the prevalence of sleep disturbances in subjects with Down syndrome and dementia. For this study, I won't go into the neuropsychological part, but the sleep study, we were conducting subjective sleep questionnaires with 1 week of actigraphy to record the sleep and wake pattern, so the circadian parameters, and a full, complete hospital polysomnographic study. So I will go briefly into some results, preliminary results concerning just the polysomnographic part. So first of all, I want to remark that right now we have included 73 subjects with symptomatic dementia, which includes prodromal stage and dementia. And we compare those 73 with 155 asymptomatic patients from our Downing cohort, which means that we have, or I will be talking about 231 subjects with Down syndrome that have completed the sleep study with full polysomnographic, and we will compare data also with 78 control subjects. So as expected, the Down syndrome group present worse sleep quality, with reduced sleep time that decrease accordingly to the to the progression of Alzheimer disease, and also they present a higher sleep fragmentation with an increased number of nocturnal arousals as well as the Alzheimer disease worsens. As a result, Down syndrome patients, and especially those symptomatic, present a lower sleep efficiency compared to healthy or asymptomatic subjects. Concerning the sleep macroarchitecture, as we already published, so Down syndrome compared to healthy controls present an increase in slow wave sleep, so it means that the deep part of sleep, and reduced REM sleep compared to healthy controls. And these two phases are decreased according to the progression of Alzheimer's disease. Here you have the same representation with slow wave sleep, or we call as well N3 of sleep, and you have the spectrum how this sleep is reduced in those symptomatic patients, and also REM sleep decrease according to the whole progression of Alzheimer's disease. And I just wanted to mention this slide because these two phases of sleep are vital for some processes that are related especially to sleep, which are metabolic waste clearance and process of memory consolidation, which explain how some sleep disturbances in slow sleep or in REM sleep could contribute to this cognitive decline or process of neurodegeneration. So concerning the prevalence of obstructive sleep apnea, so our group with Down syndrome, as reported before for us and other groups, so they had a very high increase in prevalence of obstructive sleep apnea. And I want to mark also that more than half of our sample presented a moderate to severe obstructive sleep apnea, which is already a clinical indication for OSA treatment. This OSA severity was also increased across the AD spectrum, and with symptomatic patients presented the higher apnea-hypopnea index that was also related with the worst items in oxygen saturation and hypoxia. And we observe also an interaction with both groups with Down syndrome and healthy controls with the apnea-hypopnea index, the severity, and age, which, as well mentioned right now, so Down syndrome presented at the same age higher apnea-hypopnea index. Age was also related to the presence of slow wave sleep, in terms that young subjects presented and asymptomatic presented higher presence of slow wave sleep, but the progressive decrease according to age. And REM sleep so presented a decrease as well as in healthy subjects, but remain always in lower rates compared to healthy controls. Just to finalize, and concerning the subjective sleep reports, despite the scores in symptomatic Down syndrome were worse than the scores presented in asymptomatic, the results of these sleep questionnaires were not significant to define bad sleep quality. Neither they show that there was an excessive daytime sleepiness, neither the branches of obstructive sleep apnea. Therefore, just as we show in these preliminary results, AD exacerbates sleep disturbances, also in adults with Down syndrome, as has been observed in general population. But these sleep disturbances remain unnoticed, and so we strongly recommend to try to routinely screening with objective measures, because we believe the treatment of these sleep disorders will help not only to slow maybe this progression, but also to improve this symptomatic progression to dementia. And I know maybe what you are thinking, but yes, it's possible to treat subjects with Down syndrome with and without dementia with CPAP. It's the most common treatment with OSA. And in this paper, we observed a compliance after 3 years that there was the same use of CPAP and good tolerance that in general population. And just to conclude, I would like to thank the organization to let me put the sleep data into this team working, let's say, to different approach to get, I will say, the goal to try to reduce or improve this dementia in this genetical and vulnerable population. Thank you very much for your attention, always the support of the memory unit, and Hoyo, and all the participants and caregivers. Thank you.
So our next speaker is Jana Dijkstra from Amsterdam University Medical Center. Jana is a medical researcher at the Alzheimer Center in Amsterdam. She obtained a Master of Science at the Free University and a medical degree at Amsterdam UMC. And her PhD research focuses on hereditary factors of dementia. She is currently focused on identifying hereditary factors of neurodegenerative diseases.
Thank you for the presentation, as well as I'm very happy to be here, and also very happy to show for the first time our Dutch case series of 50 AD patients in a Dutch memory clinic. So these are my disclosures. So ADAD, autosomal dominant Alzheimer's disease, has shaped our understanding of the disease mechanism, biomarker profiles, and clinical trial designs of Alzheimer's disease. So studies on ADAD carriers are a valuable model to look at the molecular drivers of disease, as these patients have an early onset and have a pure form of disease. So in this research, there's an emerging field of fluid biomarkers, being cerebrospinal fluid, as well as more recently the blood-based biomarkers. And the latter are an interesting method due to the fast, cheap, and non-invasive character. Fluid biomarkers can help in diagnosis, establishing the disease time course, as well as to better understand the biological mechanisms. So in the field, there are 4 well-established biomarkers that probably you all know. So first, the amyloid-β 40/40 ratio. This is a marker for amyloid plaques. And in ADAD carriers, symptomatic, we see that in CSF this ratio is less compared to sporadic AD, and in plasma this ratio is elevated. The second, phosphorylated tau 181, this is a hallmark for, a biomarker for neuritic plaques. And we see that in ADAD symptomatic carriers, that these levels are elevated in both CSF and plasma. Neurofilament light, a marker of neuronal damage as well as degeneration. This is also both elevated in ADAD carriers. And last, the gliofibrillary acidic protein, GFAP. This is a marker for astrocytic activation and neuroinflammation, so it shows the glial response. And this is also, in CSF, there is not an ADAD difference, but for plasma, this is elevated. However, there are many different ADAD mutations, and we observe that there's variability in the biomarker levels between individuals. So building on literature, we were wondering perhaps the location of these mutations has an influence on this variability. So, for instance, here you see the PSEN1 protein, and building on Schultz and Chadwell, we divided the mutations based on the domain. So, for instance, in Schultz et al., they divided into transmembrane ADAD mutations versus cytoplasmic ADAD mutations, and there they found that p-tau, for instance, is elevated in the transmembrane group. So this in context, we aimed to describe for the first time our ADAD carriers in the Dutch Memory Clinic, and then look at the genetic mutations that occur, the clinical presentations, as well as the fluid biomarker levels. And then as an additional analysis, look at does the mutation type has an influence on these levels. The data were collected from the Alzheimer Center Amsterdam, which is a specialized memory clinic in the Netherlands and nationally known for focusing on early onset dementia. And we included, ADAD carriers. Concerning the genetic characteristics, we found 12 PSEN1 variants in our cohort. 3 of them were also included in the Schultz and Chadwell paper. And we categorized 2 of them as transmembrane and 1 cytoplasmic. 2 were also in the Schultz paper that were ungrouped, and we categorized as the cytoplasmic/extracellular, and we found 7 extra variants. We included 2 APP variants, 1 in the transmembrane and 1 extracellular. This is not the Dutch ADAD mutation that is known. And we also included APP duplications, 7 carriers, which had 3 different duplications. So 3 carriers only had the APP double. 3 carriers had an additional 19 genes duplicated, and 1 carrier had 21 genes duplicated. So to sum these variants up, we found 15 different variants, and most of them were in the PSEN1 gene, and they had a range in mutation age at onset between 34 and 64. So we categorized these variants in transmembrane proteins or variants and cytoplasmic/extracellular variants. And we both included the symptomatic and asymptomatic groups. For the other domain group of PSEN1, the most frequent mutation was the A79V. For the transmembrane group, the most frequent mutation was L262F. And for the APP group, the duplication was the most frequent variant. Concerning the clinical presentations, we included 6 asymptomatic patients. For the PSEN1 transmembrane, we had 16 patients, the PSEN other domain 18, and for APP 8 patients. The symptomatic group showed similar clinical presentation, so they had an age at diagnosis around 52, and an age at symptom onset around 50, 51. And they had a similar time between diagnosis and death of 5 years, and almost all had an affected first-degree relative. Then the clinical characteristics, they showed a typical AD profile with memory complaints as the first symptoms, mediotemporal atrophy, a low Vasicus score, and all symptomatic carriers were amyloid confirmed in CSF. Then, concerning the fluid biomarkers, we saw a pattern that these markers were specifically elevated in the PSEN1 transmembrane group. So the first carrier is the AB42. Unfortunately, we did not have a ratio. But we compared the three symptomatic groups, being the PSEN1 transmembrane, PSEN1 other domain, and APP. And for the AB42, these are similar levels. However, they are almost all below the amyloid positivity threshold. But for the other three variants, there seems to be a pattern of elevated levels in the PSEN1 transmembrane group. And then specifically for NFL, this was significantly higher compared to the APP group, and there was a significant trend for GFAP. For the plasma markers, we found a different pattern, that the levels were more elevated in the PSEN1 other group. So for NFL, we did not see a difference between the groups, and there were two outliers that we will remeasure. But for the other three, there seemed to be a slight higher level for the PSEN1 other group. For the AB42 40 ratio, almost all points were above the amyloid positivity threshold. And for the p-tau, there was a significant, a positive trend for the PSEN1 other group. So as an additional analysis, we were wondering, does perhaps the mutation age at onset has an effect on the biomarker levels, as they are a marker for pathogenicity? So the earlier the mutation age at onset, perhaps that is a more aggressive form and does show more abnormal levels of biomarkers. However, we did not see an association. So to conclude, our 50 AD cases that we show for the first time, they show mostly a typical AD presentation. In CSF, we replicated the levels were elevated in the PSEN1 other group, so we replicated the variant-dependent heterogeneity. However, in plasma, we saw a different pattern, and this could perhaps be a role of the blood-based biomarkers, perhaps comorbidities of the patients, and maybe age. But we are very open to discuss maybe an improved categorization of these variants. But all in all, we do support this variant-dependent heterogeneity, and we suggest further research into these major genes. So with that, I would like to thank my colleagues, my supervisors, and also you for your attention.
Thank you, Shanna. And now our next speaker is Dr. Michael Okafor from the Institut du Cerveau in Paris, France, and he is studying the protective effect of a mutation on APP gene in the development and progression of Alzheimer's disease.
Hello, everyone. I would like to start by thanking the organizing committee for allowing me to present this work. So as said, we are interested in particularly a certain mutation that we found that has shown to reduce the amount of A-beta, the longer peptides produced in the brain, and I'll be presenting new work that have been done over the years on this. Some years ago, the work of Charles de Geertz in the lab showed that you have way more cholesterol in the brain of Alzheimer's patients, and this was mainly seen in the second and the third, as well as the fourth cortical layers. Also, previous work has shown by Dr. Panchal in the lab as well that specifically in the plaques, you have at least around twice the amount of cholesterol than you have in the surrounding neuropale. The work of Catherine Marker previously showed that when you artificially increase the cholesterol in the membrane of neuronal cells, you have a relocalization of base 1 as well as APP to the lipid rafts that leads to the internalization and further processing of APP protein to give you the A-beta peptides. So we were interested in the effect of the cholesterol-binding domain in the production of APP. So for this work, Linda had made some mutations in different regions of the APP protein. So some were transmembranous and some were juxtamembrane. So what she saw was that specifically the K28A mutation here, that there was a significant reduction in the amount of secreted A-beta-40 and as well as A-beta-42. And this was done by ELISA. And when you look at the amount of total A-beta produced with the length greater than 16, you see that there is also there's an increase in the A-beta in the K28 mutation. And so this led us to propose the idea that maybe there are other species, so that's because we have a reduction here that leads to this increase. So using mass spectroscopy in collaboration with the team in Gothenburg of Henrik, what we see is that with APP wild type, you have, as in the absence and presence of cholesterol, you have the same species of A-beta that are secreted. But when you have the A-beta, APP K28A mutation, you have a difference already compared to the wild type in terms of there's an increase in the amount of A-beta 1 to 33 that is produced. And with the cholesterol, it's more or less the same. But when you quantify this, what we see is that cholesterol, as expected, increased the amount of A-beta produced in wild types. But with the K28A mutation, we don't see this effect. So it would seem that this mutation leads to the APP protein being insensitive to the effect of cholesterol. And that with the mutation as well, we mostly produce the A-beta 33 peptide and not the longer ones. So this work, part of this work was done in collaboration with Dr. Denis Bia at the CEA. And so for this, he knocked out APP protein in SH cells as well as BE2C cells. These are neuroblastoma cell models. And then we re-expressed wild-type APP or the K28A mutation in these cells. So this is just some immunohistochemistry showing you that it did in the knockout, you don't have anything. So we wait 6 days after transfection to take the supernatant and do an MSD reading. And what we see is that in both SH and BE2C cells, you have a substantial reduction in the amount of A-beta 38 and 40 and an abolishment of the secretion of A-beta 42, which goes in line with what we saw previously in the HEK cells. And we did some mass spectroscopy on this, and what we see is that with the wild type, you have the production of the longer forms of the secretion of the longer forms of A-beta, and you have a shift with the K28A mutation to shorter forms such as A-beta 1 to 33, both in both cell models. And so this mutation is quite robust, at least in these models, in terms of reduction in the size of the A-beta that is secreted. So we also looked at the production of A-beta in iPSC cells. So these cells were gotten from the lab of Dr. Selena Ray, and with the help of Stephanie Bigot and Laurie Dansett at the ICV IPS platform, we made some mutations using CRISPR to give us a wild-type isogenic as well as the London mutation with the K28 mutation, or without. And what we do is that we do the same, we take the supernatant and we look after 3 days, and we see that the K28A mutation alone removes completely or reduces completely the secretion of A-beta peptides. But when you have the London mutation, which is supposed to increase the amount of A-beta 40 especially, that is secreted, we also have nothing. So it's quite robust as well on human iPS cells. So what we think is happening here is, sorry, before I go on that, is that in the amylogenic pathway of the APP metabolism, normally we target, we use antibodies to target the A-beta peptides, or there have been some trials that have shown that have tried to work on the inhibition of beta secretase as well as gamma secretase that have been stopped. And recently, more and more, there are works with modulators of gamma secretase, which basically leads to the formation of shorter A-beta peptides, which are believed to be less toxic in the brain. So we think that the K28A mutation is a supermodulator because we get way more shorter peptides, which we believe to be less toxic. So we think what happens here is that since the K28A mutation takes place in the juxta membrane, which is around the region that binds cholesterol, we think that when we have the K28A mutation, you have kind of this anchoring of the APP, which leads to, let's say, the processivity of gamma secretase increases to forming shorter peptides. So what I'm going to do next is to work on cortical neurons. So we've generated some NPC cells from iPS to see if we have the same results here. And we're also in the midst of making mice models with humanized APP mice that were crossed with the APP and LGF from Saido's group to give us mice with the K28A mutation with the human APP or the NLGF that also has the K28A mutations, as well as the controls. And this is done by Jan Hero and Marie-Christine at ICS in Strasbourg. And I would like to thank everyone that worked on this project, especially my supervisor, Dr. Marie-Claude Potier, Laurie Danset, and as well as the past members of the lab that has worked on it, as well as our collaborators in Gothenburg, Jan Hero at IGBMC, Denibia, CEA, and the platforms, as well as my funding, and you for your attention. Thank you.
Thank you, Michael. So next we have Dr. Lajos Shinchik from Queen's University, the UK. He's a postdoctoral research fellow, and his main interest is to develop retinal imaging markers for different neurodegenerative conditions, such as Alzheimer's disease, utilizing novel retinal imaging and image analysis techniques.
Thank you very much for the introduction, and hello everyone. I'm excited to be here. I'm learning so much. My research is focusing on retinal changes in different neurodegenerative diseases like Alzheimer disease, prodigal Alzheimer disease, and DSAD. So you might have heard, but probably I'm the only one who looking at retinal changes in Down syndrome today. But you might have heard the eye to be referred to as a window to the brain. Why is that? Well, the retina in the eye is part of the central nervous system. It develops from the same embryological tissue. So retinal changes may mirror changes in the brain. And what makes really attractive retinal changes in Alzheimer research is, as opposed to brain imaging, retinal imaging is much quicker, and the resolution is much higher. And when I say much higher, it's about 1,000 times higher. So I would like to introduce you to results from our pilot study. First, some of them published, some of them unpublished. This was originally set up by Prof. Tony Holland in Cambridge, and Dr. Madeleine Wolpert, who was a PhD student at the time. These are the cohort characteristics. Some of them had amyloid PET, 17 of them, and 12 of them had negative amyloid PET and 5 positive. So this is just a conventional fundus image, and you can see the surface of the retina. What we used in this study is optical coherence tomography. This technique can generate an optical cross-section of the retina. It basically goes through the whole retina. And what you can do now is measure the thickness of the different layers of the retina. And thinner retina layers would correspond to neurodegeneration, and thicker retinal layers might be a sign of inflammation. And in Alzheimer's disease, we measured thinner retina, thinner inner layers of the retina in sporadic Alzheimer. Now, what Maddie did, this is an optical cross-section of the eye. This is the retina here, and you can see the retinal nerve fiber layer entering the brain. And so what she did, she measured the retina here and here, and what she found is thicker inner layers of the retina in Down syndrome compared to controls. And in fact, this was positively correlated with the thickness of temporal cortex in the PET negative group. So that we find it really interesting. Is this a sign of inflammation? And we wanted to further explore this and look at retinal vascular changes. There's nothing really known about retinal vascular changes in Down syndrome. It's really under research apart from knowing the supernumerary vessels around the disc. And we know from Alzheimer's research, sporadic Alzheimer's research, there are vascular changes associated to Alzheimer. And so what we did here is we used a novel technology called ultraviolet imaging that allows us to image the 82% of the retinal surface as opposed to only the central retina, 15%. So we did this technology. Our PhD student, Jamie, looked at peripheral central retinal changes, vascular changes, and peripheral retinal vascular changes. And he used artificial intelligence to extract vascular trees for the central zone. And what he found is there was an increased complexity of retinal vasculature in DS compared to control, which wasn't surprising considering the supernumerary vessels around the optic disc. And then when he looked at this peripheral retinal vasculature, he found a lower complexity of retinal vasculature, and that's for venules, arteries, there were no difference. And so we wanted to see what might cause this decreased complexity. We know from Alzheimer research that a decreased complexity of retinal vasculature associated to Alzheimer's disease. And what we first did is looked at how the vessel thins along the vessel path. So from the central retina towards the peripheral retina. Previously in Alzheimer's disease, we saw that there is a faster thinning vessels in Alzheimer, and might be corresponds to a degeneration of the vasculature. So these dots just show how the vessel thins, and the steeper the slope is, the faster the thinning. And what Jamie found is that there was a faster thinning vessels in Down syndrome compared to controls. Now we didn't know at this stage whether that is because of the degeneration of the peripheral part, or actually the wider vessels in Down syndrome around the optic disc. So what we did then, what Jamie did, is measure the width of the vessels around the optic disc. And what he found is there were wider vessels around the optic disc in Down syndrome. So this is really interesting, and we then wanted to further follow up and look at another vascular layer of the eye, and that's the choroidal vasculature. Now the choroidal vasculature is here, and that is basically one of the most perfused tissue in the human body. It's full of vessels, and it feeds the inner retina, the outer retinal layers. And so Rachel, a medical student, she measured the thickness of the choroid in control and in Down syndrome. And we used this grid called ETRS grid, and we looked at the thickness in each sector of this grid. And what she found is almost each sector of this grid showed a thickened choroid. So that was really interesting, and thought, would this be a sign of inflammation? But we were thinking, okay, if we have supernumerary vessels in the retina around the optic disc, that might actually be the case in the choroid as well. There are supernumerary vessels, and that would explain the thickening. So what then what other interesting thing is that this thickening is not present in children with Down syndrome. So would this be a property or feature of a older Down syndrome population? Would that indicate a onset of Alzheimer disease in this population? So what we did then, we looked at Jamie thresholded the OCT scans, and with this technique, he could separate blood vessels from the stromal area from everything else, and we could measure the blood vessel area compared to the entire choroidal area. And what he found is that there was a decrease in vascularity, choroidal vascularity, which again was really interesting. So I guess we need further research, and we need to look at this in longitudinal setting to understand more. And then just quickly want to introduce you our current study. We just set this up, and it's just started running the eye in Down syndrome as a window to Alzheimer disease. And with the PIs of Dr. Imre Lengyel and Prof. Julian Little, and Jamie, a PhD student, and Aoife is a postdoc involved in the study. In the study, we have people with Down syndrome age 60 to 50, without Down syndrome age 50 to 80, and we have people with mild cognitive impairment without Down syndrome between 50 and 80. We have vision tests, memory tests, blood, spit, and tear samples we are collecting, and we do high-resolution multimodal imaging, retinal imaging. Some of them never been done in Down syndrome before. And we have the Northern Irish Research Facility, where we conduct this study. So one of these techniques never been done in Alzheimer disease, the optical coherence tomography angiography. This is a non-invasive technique. It's quite quick, and it visualizes the finest blood vessels in the retina. So these are microcapillaries in the retina, and this would be a healthy. And you can see some dropouts of these fine blood vessels where there's no perfusion. So what we can do with this, calculate the density of these fine vessels in the retina. Then the other thing is we use this is a very high resolution technology. This was adopted from space research, where they developed to remove atmospheric turbulence to improve the image quality. And what we can do in retinal imaging, we can resolve single cells with this technology. That never been possible before. So what you see here, these are cells, and this is just a high magnification. These are the photoreceptor cells here that are sitting in the back of the retina. But what's more interesting, that changes on the surface of the retina, as on the OCT here. So these are signs of inflammation called reactive gliosis, and with this technique we can assess this. And what we believe this is due to is reactive astrocytes, mulla glia, and microglia contributing to form this lesion. And this has been shown in MCI, in the typically developing population associated to MCI. So it's going to be really interesting to look at these changes. And another imaging technology we use is the looking at oxygen saturation in retinal blood vessels, which again, never, to my understanding, never been done before in Down syndrome. And this is just the team that involved in this work. Thank you very much for your attention.
Thank you, Lajos. The last speaker of this session is Professor Johannes Levin from the University of Munich and German Center for Neurodegenerative Diseases in Munich, Germany. He leads the Neurodegenerative Diseases Group of the Department of Neurology at the Ludwig Maximilian University of Munich and also the German Center of Neurodegenerative Diseases. And his principal research focus is the molecular pathogenesis of neurodegenerative diseases, especially on protein aggregation and therapy development targeting protein aggregation. In this context, he has a track record for coordinating academic research studies, including investigator-initiated trials, and long-standing experience in conducting industry-sponsored trials. Moreover, he's a principal investigator in several international studies and in international cohort studies such as the DIAN and GEMFI. Thank you.
Maria, thank you very much for this very long introduction. Thank you very much for the invitation, Juan and Raquel. This is a wonderful meeting. You know how much I like to come to Spain every time I get the opportunity, so I was very appreciative for this invitation. And then Juan called me and told me, do you want to give a talk? What do you want to talk about? And I said, well, it would be a very good day to talk about Parkinson's disease today because it's World Parkinson's Day, or at least to talk about the pathology. So obviously this is something that doesn't originate from the last few days, but that's something that fascinates me for almost 10 years already. When I was attending my first DIAN steering committee meeting, Nigel Cairns gave a talk that I thought was really, really interesting about the synuclein or Lewy body co-pathology of individuals with autosomal dominant Alzheimer's disease. And I thought, this is really interesting. We have a very young onset population there with a very clear-cut molecular trigger in the A-beta protein, and half of them end up having not only tau, which we assume is kind of normal. I don't know if we should assume that all the time, but we assume it as a given in the Alzheimer's pathology. And half of them have, in addition to that, Lewy bodies. And not only this is also a very, and I didn't know that at the time, a very common topic also in sporadic Alzheimer's disease. So I thought that was really interesting and worth looking further into it. And actually, it's not that easy to do that because we didn't have lots of data around it that accumulated in the past years only. So these are or it's a number of the questions you might ask yourselves if you think about these problems. How can we detect them? When would such a pathology start to appear in the disease process? How could it be distributed in the brain? What could it do to the brain in terms of clinical consequences? Why would someone develop Lewy bodies and others wouldn't? And what is this story, how is that story being investigated in other Alzheimer's populations, such as Down, for example, here, very important. So we recently got things over from the prion field, and I'm a big advocate of the prion field. Look what has been done in the prion field and try to copy it. Most things will be very irrelevant. And there are many analogies. And some of the things that made it from the prion field to the autosomal dominant and then general neurodegenerative field is the protein amplification assays. And here, there are a few examples of all the prion diseases. Just by chance, I picked a few works from Munich, which I thought were interesting, where they did the RT-QuIC assay in prion protein, showed for the first time that they really could generate genuine effectivity there, that it can be done on a quantitative measure, which we didn't have, or we don't have so far in the synuclein field. And this is something that came over also from the prion field, from Claudio Soto, who is a very well-renowned prion researcher into the synuclein field, and shows that essentially the synuclein co-pathology, at least in the Parkinson's disease cohort, can be measured very well, and we established that also in our lab and started to work on that a little bit. But first, we did other things, because this is very recent, and we tried for years. Well, no, I lost track. No, we played around with the synuclein amplification assay, and we have a number of samples of our local German DIAN participants, Munich and Tübingen. And we looked at all the samples we had of CSF from asymptomatic mutation carriers and mutation non-carriers. These are the numbers of the individuals. These are the numbers of samples. So several individuals had more than one sample taken, and all these samples were tested negative in the synuclein amplification assay. And then we looked at the symptomatic mutation carriers with the question, would they show something? And we found that from 25 symptomatic mutation carriers, 12% of the samples we got, and we didn't get only the Munich and Tübingen cohort, we also got very precious samples I will show you in a minute from the DIAN neuropath core. We found only 12% of those positive. But we found one that was positive at one initial sample, and then in all consecutive samples stayed positive. And that was the only one that had consecutive samples after being positive once. So it seems to hint towards once you turn positive, you can pick it up again. The samples we studied here are shown in relating to the onset and the CSF collection. And what you see here is the only 3 positive we found. What you see with the participant marked with a cross is the ones that came to autopsy. And the green crosses, I don't know how good you can see that, there's a lot of green crosses, are the ones that had Lewy body pathology at autopsy. What you can see is that most of those we didn't pick up. Actually, we only picked up one. And I think there are 2 things that differentiate this one from the others. One is it's one of 2 participants that had a relative short interval between the last CSF taken and the death, around a year in that case. There's another case that was a little shorter than a year, all the others quite much longer. And the other thing is the pattern of distribution. It was the only one that had diffuse widespread Lewy body pathology, while all the others had focal localized Lewy body pathology in the olfactory bulb only or only in the amygdala. So these are very, very small numbers, but I think one can assume that the pattern of distribution and the timing of CSF drainage can do something to the sensitivity, which admittedly is very low in this population. Now we looked into another data set, and that is we tried to gather all the data we could possibly get of autosomal dominantly inherited mutation carrier that came to autopsy and were studied with the question, do they, in addition to their normal Alzheimer's pathology, have Lewy body pathology? And of course, in such a study, you only get very, very basic clinical information. So we looked at something very basic, which is survival after disease onset. And we observed, to our great surprise, that adding on this pathology seems not to be very harmful. Or to the contrary, people with Lewy body pathology seem to survive longer. You can see this here in the mean survival, and you can see it here in the Kaplan-Meier plot. Aside from that, these cohorts were very, very similar, the ones with and without Lewy body pathology. The only other difference we saw was that the ones with Lewy body pathology seemed to be very typical Alzheimer's cases. So they had very little of clinical signs that one would associate with a Lewy body dementia or something like that. So, in fact, the ones without Lewy bodies were more Lewy body pathology, dementia-like than the ones with. And then we thought, okay, that is odd. Let's look how that is in sporadic Alzheimer's. And we went to the NAC cohort database, and there are thousands of brains that are very well studied from neuropathologists. And we compared more than 3,000 brains against another 3,000 brains with and without Lewy body pathology. And the difference is not that big, but it goes in the same direction. So that was interesting. Then we thought, okay, what about the pattern of distribution? You have seen there are several patterns of distribution, focal and widespread. What is when we we divide this group by focal and widespread, and then we found that the only ones that really profited, so to speak, from the co-pathology were the ones with the focal, and the widespread were quite level with the ones that didn't have Lewy body co-pathology. And we found a very similar pattern again in the NAC data set. So this leads to the question, what is it, cause or consequence? So do the people get Lewy body co-pathology because they live much longer and there's more time for aggregates to cook? Or is there something that predisposes or increases the chance of them having Lewy body from the beginning that could be beneficial in some way we completely do not understand? And so we looked at the genetics, and so what we first did, because the data is readily available basically, is we looked at APOE4, and we found that the chance of individuals in autosomal dominant, but also in sporadic Alzheimer's, to have Lewy bodies is higher if you have an APOE4 allele, at least one. And then Carlos Cruchaga did something very nice for us. He calculated polygenic Parkinson's risk scores in the Alzheimer's population. So he took the typical polygenetic Parkinson's risk score and he calculated them for us. And you see here that in the NAC data set, where we have quite some statistical power, you find a difference between the ones that do not have Lewy body pathology and the ones that have Lewy body pathology to have a higher Parkinson's polygenic risk score. Of course, in the autosomal dominant Alzheimer's set, the statistical power is very low, but you at least see that it could be coincidence purely, but it goes in the same direction. And then we should look again, what does the focal widespread do? So for the focal and widespread question, there didn't seem to be much of a difference if people had an APOE4 allele or not. But for the polygenic Parkinson's risk score, there was a difference. So at least in the sporadic, you can say that there is a higher chance to have widespread Lewy body distribution if you have a high polygenic Parkinson's risk score compared to those that did not have a high score. And now about Downs. And Downs is a little bit like prions for the Alzheimer's field. Many very important observations have been done in Downs very early on. And this is actually the only paper I could find that's ever looked at this in Down syndrome. But they came, and I think everyone knows the protagonists here, that they did fantastic work along their lives. They came to the same conclusion that is very similar in autosomal dominant and sporadic and in the Downs population, that about half of them have Lewy body co-pathology. And in this work, most of them had this focally restricted version of the Lewy body co-pathology. And so now, thanks to Juan, we got a real treasure to work with in Munich. We are doing the synuclein amplification assay on the Sampao samples, CSF samples of the cohort here. We are almost half through it. We have a very tiny CSF collection in Munich. There we focus on demented because we need a clinical indication, and found 2 out of 12 showed a positive result. We always do 4 measurements for 1, so this is 1 positive result with 3 of the curves going up, which we rate as positive. And from the Barcelona cohort, we only measured the very young ones so far. In the 96 cases tested, we found 4 positive, so about 5%, but I expect this to go up as we go to the other half that will be include the older ones. And we found 16 inconclusive, which is very unusual for our assay, so I think there is something more in it. There might be some more positive cases hidden in there, and inclusive are cases that have less than 2 of the curves going up, because then we don't rate them positive, but we want to repeat this, and the 17% is a really high number. And so the question is, what does it mean? And is that very odd or not that odd? And I think it becomes a little less odd if you go to the animal data that there are out there about crossing synuclein overexpressing mice with the typical APP-PS1 mice. And there is data there that, at least in these mouse models, they have a more benign disease course with even a more functionally better outcome if you do that. And with this, I'm happy to take questions.
Thank you very much. Is there any question from the audience?
Thanks. I guess for Dr. Jimenez, this is very interesting, the interaction of Alzheimer's pathology and Lewy body pathology. For Dr. Jimenez, is there, of all the sleep studies you did in Down syndrome patients, are there any REM behavior disorder observed?
Sorry, I didn't get your question. So other?
Is there did you see any REM behavior disorder with your polysomnography of Down syndrome patients, considering some of them may have Lewy body disease?
Yeah. So it's really seldom. So we got some of them, but really it's not really something that we are really finding with that. Even for sure not RBD, as with clinical symptoms and all, but even we don't find increases in electromyography, like losing of muscle atonia neither. So it's really almost clean. So we had some of them that we are...
So not never, rarely, I guess. Being interesting to see how that relates to if they have the Lewy body markers in their CSF, if you can do it's an interesting association.
May I comment on this? I think it would be very odd to see that, because obviously it's not the type of pathology that gives you a phenotype, but it's localization. And we know that in these brains, many times it's amygdala and olfactory only. And obviously that wouldn't give you a REM sleep behavior disorder. You need a brainstem pathology to have that. And so I think this pathology in the Alzheimer's context seems to work differently, and we can very safely assume that by the fact that the distribution is differently than in Parkinson's disease, where you have it very early in the brainstem, where indeed it does give you REM sleep behavior disorder.
This is also to Dr. Jimenez. So very nice presentation, everybody, very nice presentation. So I was wondering if you talked a little bit about with OSA, with treatment, with CPAP. Many of the patients, though, can't tolerate it. Have you also looked at Inspire or other means to have something for treatment for this very prevalent OSA that's seen in our patients?
Yeah, so I'm always saying that treatment, in this case with CPAP, you have to combine patient and caregivers, that this is really a treatment. So in our experience and the series of patients, but now we have a lot, if you combine the caregiver that this is really a treatment, and you have an adaptation of CPAP showing like kind of education, what for, so they can tolerate this treatment. And maybe it's important to asking that or do a follow-up. What are the inconveniences with the treatment? If it's because of the mask or because there's something annoying with them, and of course, like in general population, there will be subjects that they will never tolerate this treatment, or others that they will accept. So I think it's important to not just give the treatment and say bye, but just really a close follow-up with this patient, and especially for caregivers. I think we have to educate caregivers about this. And also, I will say that subjects with Down syndrome that we have, although we do not why exactly they have better or worse tolerance. But we believe, and I believe, that that treatment is doing something better for them because will improve their quality of sleep, because if not, they will remove if there will be something annoying, so they will stop the treatment, and they are not doing so. I don't know if this could be an advice.
Are there more questions?
Maybe online?
Online?
Okay.
I do have one for Lajos. So you observed a thickening of the retina and the choroid, and this may be related to neuroinflammation. Do you know if this neuroinflammation is because there are inflammatory genes in chromosome 21, or if this neuroinflammation is related to Alzheimer's disease neuropathology in Down syndrome?
Yeah, that's a really good question. I think to find this out, we need longitudinal studies, and retinal research in Down syndrome is it's very limited. We don't know much about. As you could see, we didn't know vascular changes. We didn't know anything before we explored the retina. So I think it would be worthwhile to do longitudinal study, doing with brain imaging and fluid biomarkers together, and look at over time. But there are studies on sporadic Alzheimer's disease showing amyloid pathology in the retina. So that could be a potential reason.
Okay.
I have a quick question about retinal imaging as well. Can you see any amyloid-β at all in Down syndrome, given the overproduction, throughout the brain, including probably the retina as well?
Can I see amyloid-β in the retina?
Yeah. Can you stain or give a amyloid binding compound and image that in Down syndrome?
Is it in vivo or in post-mortem?
Either.
So I'm not aware of post-mortem work in the retina and Down syndrome. So that's again a low-hanging fruit to look at. And another, there are companies developed retinal imaging technology that look at retinal amyloid. But I think this is very early to say whether we can image at this stage. There's, for example, hyperspectral imaging, retinal hyperspectral imaging, which there seems to be a pattern associated to a positive amyloid PET in the retina, but we cannot say whether that's due to amyloid or other hyperreflective changes. And one could be maybe the one that we would like to assess using adaptive optics, these inflammatory changes in the surface of the retina, which never been really, one study showed that in MCI, in sporadic cases. So these are really under-researched. Mm-hmm.
So I just wanted to follow up on the comment. It's just almost a suggestion, and I'm looking at Lisi because in the University of Kentucky, I think they've got a brain bank that not only they collect the brains, but they also collect the eyes. So the material is there, the brains have been analyzed. So I think it would be really nice to make this correlation between the eye and the brain. And my comment is, after not looking Lisi's presentation and your retinal, the thinning in the vessels, and you were Lisi this morning finding these breaches in, could there be a relationship between these findings, that Lajos is finding in the eye and what you're finding in the brain, and this is kind of a motivation for analyzing those eyes in Kentucky.
Yeah, I was looking at your data, and it's really interesting. So what's happening with these basement membrane structures, this thinning, it's also contributing to the hypoperfusion that we see in Down syndrome. It may be an explanation, and this maybe you can also we can work together.
Yeah, so that is what we are exploring now in the new study, looking at oxygenation level as well as the density of these microcapillaries, so we could detect hypoperfusion if there is, probably. So it's kind of interesting. And another thing on this point, I remember you mentioned bleeds, microbleeds, which we haven't explored in the retina, so that could be another potential. I mean, we did the ultraviolet field imaging, so we have a big retinal surface, almost 85% of the retina, so we'll probably be able to investigate it. But if there's anything similar in the retina.
And are you aware of, I'm not aware at all, but of some studies looking at the choroid amyloid angiopathy, maybe?
Yeah, that's because there's no. So from sporadic Alzheimer research on postmortem samples, there is evidence that there is amyloid-β in the choroid and in the retina as well, and around the vessels and in the vessels. So there's a group very enthusiastic about looking at amyloid-β changes in the retina in sporadic Alzheimer disease in the UCLA, and they found CA, so choroidal amyloid angiopathy in the retina, and pericytes loss associated to that. So, yeah.
Okay, thank you.
Just to follow up, we published about 9 years ago a case series of 12 participants who had oral curcumin shakes and did retinal imaging of amyloid plaques. And the challenge with that was the difficulty in having participants with Down syndrome focus for us to be able to actually do that scanning imaging to capture that. But in the paper, we published an image with the puncta where you can see the autofluorescence from curcumin, which is known to bind to fibrillar amyloid. I think the challenge is going to be protocolizing this and having participants with Down syndrome hold still in their gaze to be able to capture that high enough resolution.
Yeah, I think we use the same technique in one of these Down syndrome studies in Cambridge. It's from neurovision imaging, but now they don't need to drink the curcumin, so without that, but we didn't really get anything out of it, and now we're using the same technique in a deep and frequent phenotyping study, a UK-wide study on prodromal cases. That's a sporadic AD, and again, the company is not using curcumin. We will have about 300 participants in that study, and I'm looking forward to see what's coming out of that.
Hi, I've got a question from Michael. I don't know if I missed this, but did you look for effects of apolipoprotein on ApoE on cholesterol, the actual protein?
Sorry, I don't think we.
I can hear you, but I don't know that.
You guys can hear me?
No.
No, it's good? Okay, yeah. It's good. Sorry. So for the ApoE, we haven't looked, to my knowledge at least, we haven't looked if there is a difference specifically. But in the first paper I showed by Charles, they were, if I recall correctly, there were majority ApoE4 patients. There was one with ApoE3, and the rest was ApoE4. So, but it was. I think there were just four patients in this test, so it's not really robust for me to say anything, but that's as much as I can say.
No, thank you all so much for those talks. They were excellent. Maybe a general question to all of you in thinking about the discussion all day today and tomorrow, or where do you see across all of the different modalities and all of the different discussion points from your talks, where do you see sort of the biggest gaps or the biggest opportunities that can move your space or move your area forward in really trying to understand these markers or these targets as a potential therapeutic?
well, I can start with this. In my case, brain imaging would be really helpful for with eye imaging and the longitudinal settings to see changes over time. Because if we just look at the cross-sectional data, we have even more questions. So I think that would be really important. Brain imaging, fluid biomarkers, and multimodal high-resolution retinal imaging. Because retinal imaging has much higher resolution, we would detect much smaller changes, which PET or MRI wouldn't be probably able to see. But yeah, I think that's.
Well, I think what we really need, and that is very obvious, we need therapeutic agents that work. And then we need studies that are large enough to help us disentangle all this very complex pathology by taking one by one the components of these pathologies out. And I think we are living very exciting times where this starts to become possible on the A-beta part of the pathology. I think if I would wish for something, I would wish for something that works against tau, because we could use it further along, and even more to the core that is correlating very, very well with the clinical decline we see, and would disentangle even more things. But I think we have to join forces, build very large studies that really help us to understand that and use the agents as they come. And then study it with all this technology that has been presented and try to make the best of it. Yeah.
Yeah, that's very well said. I agree. And for the fluid biomarkers, it would be interesting to better understand what it's actually reflecting, to have also bigger sample sizes, and then if you can better reflect perhaps the progression of disease, then that could help in clinical trial design, for instance. For the fast progressors, for instance, that you really know how good it works or not.
Yeah, I would say that we also we need very well characterized models to do longitudinal study for when we have these therapies. We have already the biomarkers when and in which phase do we have to use it. And in the terms of sleep concerning Down syndrome population, I think is a really optimal population to apply all these studies, since we have, talking about obstructive sleep apnea, we have a population that they have a high prevalence of sleep disturbances. We know that it's going to be dementia there, and we have all the biomarkers, so sleep disturbances could also be as a secondary therapy to slow this progression.
Yeah, I completely agree with everything that was said. I think looking at the disease from different aspects and targeting different aspects is something that is very important. And I think because the A-beta theory has been put in question a lot lately, but thanks to the effect of the new drugs approved by the FDA, shows that there's indeed something there. But I also think that other fields should be pushed as well. Even though my work is more on A-beta specifically, I think GSM, so the gamma secretase modulators, are a good, I think, target, because not only you're not affecting the activity of different secretases that obviously do other things. So I think each target that is possible should be worked on.
Thank you. So if there are no more questions, we are on time. So thank you very much for all the speakers.
Thank you.
Thank you.
Thank you.
Mexican, Spanish, and Spanish.
A bit, yes.
So good afternoon.
No,
Before the next section starts, I will just comment some housekeeping notes. I would like to remind you that we have a guided visit to these buildings all over this area at 5:30. So those interested in joining us in the visit, please join us in the hall at 5:30. For those who are coming to the dinner at 8:30, we have an additional visit to the building where we will have the dinner that is called the Casa de Convalescencia. This is another building in this structure that's in the next, the entrance in the street, in the next street. And we will have this visit, optional visit, at 8 p.m. for those interested in joining us. And for the scientific committee, I will ask them to stay at the end of the session to have a photo. So please stop.
Hola, hola. Okay, thank you. All right, so thank you everybody for staying until the last session of the day. We have 4 great speakers today and 1 joining us online. And then we're gonna do the guided visit, so please don't fall asleep. It's a pleasure to co-moderate this session with Dr. John Rickman, and my name is Florencia Yulita. And we're going to invite our first speaker, Dr. Eric Johnson, who's going to talk about CSF proteomics defining the natural history of AD/AD.
All right, great. Well, it's a great pleasure to be here to talk to you today about some of the work we've done on AD/AD, and I just want to thank Juan and team for organizing a great conference in a wonderful venue. And I view my talk today as telling about what we did, but also setting up the next talk that Lídia is going to give to discuss some of the work we've done with her and Juan in collaboration on Down syndrome as well. All right, these are my disclosures. So before I talk about biomarkers, I'm going to talk about the brain, brain proteomics. And we've done a fair amount of work now in the Accelerating Medicines Partnership for Alzheimer's Disease on brain proteomics. And we did a study where we took brains from the Religious Order Study and Memory Aging Project, ROSMAP, as well as the Banner Sun Health cohort. And these were control brains, what we call asymptomatic AD. So these are individuals who passed away and have Alzheimer's disease by autopsy, by neuropathology at death, but they're cognitively intact. And then Alzheimer's disease patients. And we analyzed these 516 tissues and measured about 8,600 proteins. And so we have a lot of data here that we need to try to understand. And one way we can do that is to reduce the dimensionality of the data down into different pathways. And we use a technique called co-expression, protein co-expression to do that. And so we can take 8,600 proteins and relate these proteins to one another by how they vary across cases, down to, in this case, 44 different modules of proteins, groups of proteins that are related to one another. And then we can try to understand each group of proteins by its primary ontology, what pathways it's subserving. And that's what's shown on the right here in kind of a circular, what we call Death Star format here. So on the outside of this figure are the different ontologies for each of the modules, which are spokes in the wheel here. And then each of these modules can be related to different traits that you're interested in. For instance, in Alzheimer's disease, you can think about amyloid and tau, or cognitive function, right? And that's what the heat is shown here on these spokes. And so one module that was of particular interest to us that came out of this analysis was this one here called the matrisome, or kind of the collection of extracellular matrix proteins in brain, the M42 matrisome module. And the reason this was particularly interesting to us was because it was the module that was most strongly related to AD pathology in the brain, amyloid and tau. And it was not a large module. This is the entire module here of about 30 proteins. And the proteins that are highlighted in the middle are the ones that are real drivers of this co-expression module. So you can see that APP is one of them here. In mass spectrometry, APP is really a surrogate for A-beta. So if we had measured just A-beta peptide, that would probably be in the middle in this module as the driver. We have a protein called SMOC1, which was the one that was most strongly driving this module. And we also have ApoE in this particular module. So interesting group of proteins. If you look in models, mouse models, and in human brain for some of these proteins like SMOC1, you can see that they actually stain or co-localize with amyloid-beta plaques. Interesting, right? So we took a bulk proteomic approach, just to ground up a bunch of brain, analyze it by mass spec, analyzed it, the co-expression, and now we can see localization of certain proteins within the brain through this bulk approach. If you look at some work that Junmin Peng has done for these other molecules like MDK or NTN1, you can see that they also stain A-beta very well. In fact, almost as good as if you were to stain for A-beta itself for amyloid plaques. So some of these proteins are very well co-localized. Okay, so started talking about brain. We're interested in, of course, measuring all these different pathologies that we can define by proteomics at end-stage disease during life. So we need biomarkers to do that. So we decided to start in CSF. It makes most sense, right, to look at that biofluid first and to see if we can actually find some proteins there that might correlate with some of these brain changes. And so we did a discovery study at Emory with just about 40 people and tried to go pretty deep with our mass spectrometry approach to see what was increased and decreased in Alzheimer's disease. And then that's shown on the right here. It's a volcano plot. These are the ones that are up, these are the ones that are down. Then you can take each protein there and relate it back to the module in the brain that it would map to, right, if you were to put that into the brain, assuming many of these are coming from the brain. And then you can say, okay, so for instance, this protein, YWHAZ or 1433Z, this one falls into this module here, synaptic module. Or PEBP1 falls within this sugar metabolism module here that's correlated with traits. Or some of these, the postsynaptic density module here, MPTX and VGF. All right, so we did that, and we kind of selected about 59 proteins that were of high interest as potential biomarkers for Alzheimer's, and we made a targeted panel to measure those proteins. And we went into the DIAN cohort to look at autosomal dominant Alzheimer's disease in CSF there to see how these proteins were changing in ADAD. And as you know, the power of doing that is we can put ADAD into a longitudinal timeline based on cross-sectional measurements because we know in general when people will develop the disease, right? So now we don't have to have 30 years of following people. We can have a cohort, a cross-sectional cohort that we can put into a longitudinal context. And so we did that for 59 proteins, and these are the number of mutation carriers and non-carriers that we analyzed, and this is work that was done by Shijia and Caroline and Kathleen and Rafi in our group. And we analyzed then each measurement longitudinally by fitting it into a model. And I'm not going to go into the details there, but basically it's a Bayesian type model, a linear model, which is can adjust for nonlinear effects. So first of all, this was not from mass spectrometry, but just looking at the ELISA measurements for A-beta 42 to 40 to orient you. In the carriers here in red, you can see that they start higher earlier in life, which makes sense. They produce A-beta higher than controls. And then over time, this ratio decreases, and at some point, it becomes lower than the controls here. And if you look at this one that I mentioned before, SMOC1 is this driver of M42, you can see that it increases both in controls and in carriers, but more in carriers compared to controls, and that starts to occur quite early. And if you look at, I guess the shading isn't showing up here, but if you look at the difference between these two lines, then you can plot this and say, well, when is something statistically different between a carrier and a non-carrier? And you can see that for A-beta ratio, it's higher early, and then at about -18 EYO, that it is decreased. For SMOC1, we can see that it's increased in the carriers compared to non-carriers at about 29 years before symptom onset at EYO 0 here. So when we look at the 59 proteins then that we measured in DIAN, we found that 33 of them were different at some point across the EYO spectrum. And that's what's shown here in the heat map from the earliest to the latest, with this as being EYO 0. And you can then relate each of these proteins to the brain module that they would map to and get a sense of what are the pathological changes that evolve over the course of the disease. And I'm just going to cut this in half so we can look at it a little bit more closely here. This is the top half, this is the bottom half. In the first category, we can see that A-beta we can see is changed the earliest. But then we see these proteins there that map to this matrosome, M42 matrosome module, as being the ones that change next. In fact, even before we see an absolute decrease or difference in the ratio. So as this is going down, as plaques are starting to form, we see these proteins start to increase in spinal fluid. And then there are a number of proteins that are also increasing later. Here's p-tau217 right here. So these are the ones that are occurring even before p-tau217. And these are really the A-beta plaque matrosome changes here. And then we get into some synaptic and metabolism changes, also changes associated with stress response. Here's the PIB-PET measure, which is a little bit after p-tau217. You can see these some of these 1433 proteins evolving. And then we get into this part of the EYO spectrum where after that we have white matter and axonal integrity markers like NEFL, change total tau. And then immune changes after that associated with metabolic failure as well, so chitinase 3 like 1 or SPP1. And then finally, closer to symptom onset, we start to see changes in brain tissue volumes, and also some more changes in synaptic markers associated. So this is the kind of the time course or the evolution of these different pathologies that we can map back to the brain and how they evolved in autosomal dominant Alzheimer's. And this is a model then of how this would work. For instance, the A-beta plaque matrosome seems to increase over time, and in our data, it doesn't stop. It continues to increase even after clinical onset, which may be unique to autosomal dominant cases compared to LODE. But you can see that some of these other changes evolve in different ways and occur before the functional decline here at the clinical onset at the very end. So this is a model of the natural history, if you will, of the evolution of autosomal dominant Alzheimer's disease. So just to sum up, we can use protein co-expression networks to provide biological context for some of these biofluid biomarker changes that we observe in AD. And using proteomics, we can reveal multiple different pathways and how they evolve over the course of the disease. We see the proteins that are interesting, like SMOC1, in certain modules in the brain, are elevated very early in the course. And we actually don't know what these proteins are doing, and that's an area that we're working on to try to better understand how they are involved in amyloid formation potentially, or how amyloid may affect downstream pathways through some of these proteins. Just to sum up, a lot of people to recognize, the people that I mentioned here on the Emory team as well as others at Emory, of course, Diane and our partners in the Diane cohort at WashU and elsewhere, and then also all of our other collaborators and our funding sources. Thanks.
Thank you. So our next speaker will be Laia Montoliu Gaia, who's originally from Spain, but now at the Gothenburg University in Mölndal, Sweden. She will speak on proteomic analysis of cerebrospinal fluid and Down syndrome, uncovering shared and distinct pathological alterations in comparison to late onset and autosomal dominant Alzheimer's.
Thank you very much for the introduction, and thank you to the organizers for inviting us to present our results. Can you hear me? I don't think, yes. In this conference. Today I will present the results of a study that is kind of a follow-up of what Eric has presented before. And in this study, we aim to understand the proteomic changes leading to Alzheimer's disease in the Down syndrome population and how these changes were similar or different to those happening in late-onset Alzheimer's disease and autosomal dominant Alzheimer's disease. So I guess this is the slide why we are all here today, and this is Juan's fault, I guess. So when we represent the changes in AD biomarkers, both fluid and imaging, and also in clinical scores in DSAD compared to AD-AD, we see that these follow very similar patterns. And then we assume that the pathological changes in these two variants of Alzheimer's disease are quite similar. And just as a reminder, we have these three different variants of Alzheimer's disease. We have Down syndrome Alzheimer's disease that we know we have in Down syndrome we have a triplication of chromosome 21, then consequently a triplication of APP and an overexpression, and then that induces an increase in A-beta production. But we have autosomal dominant Alzheimer's disease, and we have mutations in presenilin-1, presenilin-2, or APP that also induce an increase in A-beta production. And then finally, we have late-onset Alzheimer's disease. We don't know the main cause of Alzheimer's disease, but we know that the main risk factor for developing load is allele 4 of ApoE. And that induces a low A-beta clearance. But in any way, these three variants induce A-beta accumulation and deposition that leads to tau hyperphosphorylation, neurofibrillary tangle formation, neurodegeneration, and eventually Alzheimer's disease. But how does chromosome 21 triplication affect AD onset and pathology? Because we have many other genes that are triplicated in chromosome 21, and we don't know really how these other genes are affecting the onset of the disease and the progression of the disease in Down syndrome individuals. So to answer this question, we designed a study in collaboration with 3 different centers, São Paulo Memory Unit, like they provided samples from the DAPNI and SPIN cohorts, and then we included different clinical groups, euploid controls, sporadic AD, and symptomatic prodromal and dementia Down syndrome, and then they also had measures for established AD-CSF biomarkers. Then at the University of Gothenburg, we did TMT proteomics. This is just a way to relatively quantify the levels of different peptides in different samples in CSF. And then finally at the Emory University, they applied the same model as Eric has explained in the previous presentation, based on the Bayesian statistical approach. And then they also compared our new data with the data they obtained in the Diane cohort. So in this proteomic study, we could measure 1,122 proteins in 365 cases. And then when we filtered these proteins, so we made sure that these proteins were present at least in 80% of the samples that were quantified. We went to like 840 proteins, and of those, 556 were altered in Down syndrome disease, whether increased or decreased. And then a large majority of those were altered previous to symptom onset. And in this study, we considered AYO 50.2 based on previous studies. And these are the examples of 2 different proteins that were increased or decreased in Alzheimer's, Down syndrome Alzheimer's disease. So we had APP that had higher levels in Down syndrome than controls, of course, and then we have neuropentraxin-2 that was decreased in Down syndrome compared to controls. So in the next step, we group all these protein and 29 protein co-expression models. And then the first thing we did was to correlate these different modules with CSF AD biomarkers. So we had total tau, p-tau, NFL, YKL40, and then the A-beta ratio. And then we observed that some of these modules showed positive associations with total tau, p-tau, NFL, and YKL40, and negative associations with A-beta ratio. And this included like the 14-3-3 MAPT mix module, glucose energy metabolism, immune response, and actin cytoskeleton. But then we also had modules that had the opposite trends, so negative and positive associations. And those included glycoprotein synthesis, neuron migration and organization, and cell migration. And then finally, we had models that were strongly elevated in DS, but not in late onset Alzheimer's disease. And those included the ones linked to the chromosome 21 APP as expected, but then also immunoglobulins, complement, collagen, and extracellular matrix. And this is what a bit the same shape as like Eric explained before. I already split it in two. So you can see in the x-axis the estimated year of onset, and in the y-axis all the different modules. And for example, we found interesting that the earliest changes were happening in the Golgi and the chromosome 21 modules. And then the modules that were very related to ADRI traits were changing in between -10, -5 years previous to age of onset. And then finally, we saw that some modules were changing quite close to age of onset, like the immune response and the neurogenesis and synapses that were decreased, in this case, not increased. And finally, we saw that some of these modules were changing later than the age of onset, and those included lysosomal function, endosomal function, and also glucose energy metabolism. So finally, what we did was, like, based on the previous study that Eric had performed, we took the list of proteins that measured, and then we compared how they were changing in AD-AD and DSAD. And what we observed, for example, was that SMOC1 and SPON1, that was like very relevant in Eric's study, they showed earlier elevations in AD-AD, and they were increased later in DS and closer to the symptom onset. But we saw some early relative decreases in Down syndrome compared to AD-AD for secretogranin, VGF, neuropentraxin, and lactaderin. Later I will explain why is this. And then finally, we also observed, interestingly, that some proteins were changing in opposite ways. So they were increased or decreased in DSAD and the opposite in AD-AD. And those including like lactate dehydrogenase, enolase 1, PARC7, and CAPDH. So to conclude, we observed that changes in Down syndrome AD share both common but also unique patterns compared to late-onset Alzheimer's disease and autosomal dominant Alzheimer's disease. But most proteomic changes in DS occur prior to the onset of AD symptoms. And in DS, we see early elevations in the levels of immunoglobulins, complement, collagen, and extracellular matrix proteins, and also decreases in synaptic proteins, neurofilament light, and lactaderin that is proposed to be a marker for CAA. So we believe, or this suggests, that this could imply that an early loss of blood-brain barrier integrity and cerebrovascular dysfunction in DS, and this should be considered when implementing like anti-amyloid therapies in this population, because we know this is a risk factor, a side effect of these treatments, and then we should have future studies addressing how this would affect Down syndrome individuals. I would like to thank everyone involved in this big project from the University of Gothenburg here in São Paulo, and also the Memory University. Thank you so much.
Thank you, Laia, for a great presentation. Our next speaker is John Ringman from the University of Southern California, and he's going to talk about the A431E PSEN1 mutation arising as a founder effect in Jalisco State in Mexico, from clinical presentation to an animal model.
Thank you. And thanks again to the organizers for inviting me to speak. And in case anybody's wondering, I have a nicer shirt. It's in my suitcase, which I understand is now in Spain, at least. So I've been working with families with this specific mutation in presenilin-1 causing Alzheimer's for many years now, and I'm going to give sort of an overview rather than talk about one study, but give an overview and some highlights that recent and unpublished. So I don't have to belabor this too long. We all know about autosomal dominant Alzheimer's disease. Here I just want to emphasize how there's over 185 or even 200 different mutations described in presenilin-1 causing the disease. But there's a few mutations that keep popping up, at least in my clinic, that represent founder effects. It can look like we do a lot of comparisons to late onset Alzheimer's disease, and there are many similarities, but there are differences. The age of onset, some higher incidence of myoclonus and seizures, spastic tetraparesis or paraparesis, this sort of atypical pathology of cotton wool plaques. So similarities and differences. Now, working in Southern California, I came to realize that I had patients coming through that tested positive for a specific mutation, this A431E mutation that at the time hadn't been fully characterized. Most of these folks could trace their roots to Jalisco State in Mexico, initially in this first year, 24 families, there were 9 families originally reported by folks in Mexico City, and then another 16 by us, unrelated, superficially unrelated in Southern California. So 24 families having the same mutation. Doing the genetics around the pathological variant, all carriers were found to have the same dinucleotide repeat allele, which was otherwise highly polymorphic, so showing that the family has inherited not just this mutation, but this chunk of DNA. And more recently, we now have identified or figured out that the A431E variant is on a background of Amerindian DNA. So this does originate in the New World. It was not a peninsulare who appears to have brought it over. So with what we're doing in Southern California and also with collaborators in Mexico, we've identified at least 100 different families with this mutation. And sort of looking at the family trees that we've been able to put together, as many as 1,260 persons are at risk among these families, the majority of them being in Mexico, concentrated in Jalisco State, but about a third of these that we've been able to identify are in the United States, with a concentration in Southern California. So this is the original paper by Yescas et al., in which she identified the cities from which their families in Mexico City originated. So this is Jalisco State, and this is Guadalajara is about here. So this is the Los Altos region of Jalisco. So phenotypically, this age of onset is around 40, 41, with some variability. This is particularly young. I've seen one person with this young and one person with this age of 54. Can present with early changes in memory, but also with executive function, and my collaborator Esmeralda Matute's group in Guadalajara has brought focus to the language deficits that occur early. About 40 or 43% get significant leg spasticity early in the course of the illness, and this is described with other presenilin mutations as well. On pathology, I'll say a little more about the pathology later, but they can have the atypical cotton wool amyloid plaques that consist mostly of A-beta-42, which actually displace surrounding parenchyma, almost space occupying. All of the ones who have come to pathology have at least moderate and many with severe cerebral amyloid angiopathy, although clinically relevant hemorrhages do not occur, at least not very commonly. So this is now turned towards some of the newer information on the fluortaucipir scan. So this is fluortaucipir composite images from the Diane cohort, in which you see the precuneus pathology and also in the parietal lobe, lateral temporal lobes. But there are differences. Here's the Paisa mutation from Colombia, which you see more medial temporal lobe signal. And what we're seeing in the A431E mutation is not so much medial temporal lobe signal, but a lot of this parietal signal and even some sensory motor cortex signal, which we'll get back to. So we're quantifying this better now, but this is just one analysis of a case compared to a late onset Alzheimer's using this REEB graph analysis by my collaborator, Dr. Yonggang Shi. What we see here is in the A431E case, in blue, you see much more signal, or more consistently abnormal signal in inferior parietal and superior parietal lobe, less so in the temporal lobe, but also in motor sensory cortex in that case. So here's this exemplary images highlighting that. So we've now been turned to the pathology. And using AT8 staining, Mike Binkowski has quantified the AT8 staining in regions of in the A431E mutation carriers, and also a couple other presenilin mutations we have for comparison, ones that don't cause spastic paraparesis at least. So you see a higher signal in the A431E in the occipital cortex in these cases, and also basal ganglia. But less, more relative to the A431E and these other mutations in the hippocampus. So what we're seeing on the fluoroscopy imaging is holding up, it looks like, in the pathological analyses. Now, the spastic paraparesis. Now, if that's not well understood, but this is an early paper in which we looked at 3 carriers of the A431E mutation who had spastic paraparesis and compared DTI to 7 persons otherwise matched affected by other presenilin mutations that did not have spastic paraparesis. We see this widespread differences in fractional anisotropy, with fractional anisotropy being lower in areas of motor function, perhaps, but also corpus callosum and other areas, showing that there's this association of widespread white matter abnormalities only detectable on DTI with the spastic paraparesis. So taking that a little further, now Ann Hineker has joined us at USC and is looking at the pathology of these cases closely. And we have the fortune of having spinal cords. What's interesting here is that you see this, in the corticospinal tract in the A431E mutation, you see this paleness, this lack of myelination in the corticospinal tracts compared to a mutation that, presenilin mutation that presents with a largely amnestic profile. But interestingly also, what's going on here? Looks like there's also a paleness in the dorsal column. So we're going to get into that. These folks don't have obvious dorsal column deficits, but we'll be looking at more, seeing if they have more subtle ones. But this argues that there's some effect directly on the axons or myelin. Does it represent anterior grade degeneration? I don't think we know, or is it primarily axonal? So I wanted to present this curious case, which we're all trying to understand. But this is a very unfortunate woman who was already at risk for inheriting the A431E mutation, her mother having been involved in our studies. As I said, the condition usually presents around age 40, even with a spastic paraparesis, maybe sometimes into the 30s. Well, at age 20, she'd started developing problems with spasticity. By the time we saw her at 26, she could barely walk, was cognitively intact, although with dysarthria, some slurred speech, but very cognitively intact. She had negative fluoroscopy and florbetaben PET scans, okay, but clearly had this neurological symptoms. We did genetic testing verifying she has this A431E mutation, but she also has a variant in APP, this A713T variant, which has been previously described to be a risk factor for Alzheimer's. In some families, it looks autosomal dominant, causative, but then there are people who have been described to be escapees, living to be 80 without dementia and having this variant, as did her father. Her father now is in his 60s, maybe early 70s, I think, but no obvious deficits. So what's going on here that I don't think we understand how this mutation we think is contributing to her early presentation, but without before the obvious deposition, at least, of amyloid plaques. So it could be that we're trying to understand this better, is the pathogenesis of the spastic paraparesis related to APP processing, but somehow independent of its deposition in the form of plaques. So I'm raising more questions than I'm answering here today. Because of the large number of these families, it gives us the opportunity to actually develop maybe a gene mutation-specific treatment. So Bart de Strooper has taken on the task of developing a transgenic mouse. He's done so transgenic for the A431E mutation. He's done it both on background of or putting in human APP, normal wild-type APP, but also the one with the Dutch mutation and then the Dutch mutation with an additional mutation. So this mouse so far has shown the development of plaques at 12 months, but further characterization of these mice are ongoing. He also notices significant gliosis, and we're still working out. They are still working on the behavior. So we're hoping that this will be a model that can provide a way of testing potential interventions, including this antisense oligonucleotides that he is working with, or we are working with Vico, a company, to develop and potentially use to treat this illness. So here's some of those early slides showing that this is a mouse heterozygous and homozygous for the A431E mutation. You see the gliosis. I can't make out which color is which, but there is amyloid plaques and inflammation present here. So just in summary, this A431E mutation is a large group of families presenting the opportunity to develop and implement a mutation-specific intervention. It has a specific phenotype with CAA and age onset around age 41 and a variable presence of spasticity. They have a somewhat atypical pattern of neurofibrillary pathology in the parietal lobes and occipital lobes and in sensory motor cortex, but decreased signal relative to late onset Alzheimer's and other presenilin mutations in the medial temporal lobe. The spasticity, though we see this tau signal in motor cortex, it's not clearly, at least as we can measure it, related to the spasticity as you can develop it in association with widespread DTI abnormalities and absence of measurable amyloid and tau pathology on PET. Though, I didn't show the numbers here, in this unfortunate 26-year-old, her DTI measures were markedly abnormal, despite the negative amyloid and tau PETs. And a mouse has been created and is being characterized, and an ASO therapy developed and tested for implementation in this population. So here are many of my collaborators contributed to this work and people ongoing we're working with in Guadalajara. And this is collaborators at USC and also at UC San Diego. In addition to these funding sources, over the years, we now have a grant from the Epstein Foundation to work on the pathology. I'm probably over time, but I had to show this. So I'll join you in Gibraltar in 2027 for the next one. So, thank you.
Thank you. So our next speaker is Lisa Vermunt from Amsterdam University Medical Center, and she'll talk about within individual trajectory of plasma GFAP in dominantly inherited Alzheimer's disease. Thank you, Lisa.
Thank you. It's really a pleasure to be here today, and the organizers have done a terrific job in bringing all this clinical, fundamental therapy for now and for the future all together in one conference. I think that's quite unique, and I really enjoyed it. I hope you can bear with me for being one of the last talks. So a lot of data today. These are the disclosures of our center. And my goal is to share some GFAP results in the DIAN dataset in the context of genetically determined AD. It's not my own joke, by the way. And highlight some research initiatives of Amsterdam. So Alzheimer's disease has a long preclinical or pre-dementia stage, and this is a real opportunity for preventive treatments. However, this pre-dementia stage is still quite unpredictable, and that hampers treatment development and appropriate care. So that's why many of us are working on biofluid biomarkers as a solution. And the familial form of Alzheimer's disease are really ideal for biomarker studies. Or, as already mentioned, we can study the preclinical trajectory, but importantly, to convince also people who are not in our field, is the biological overlap. It's already mentioned today, and here I also would like to highlight our example where we studied CSF proteomics in a small cohort of familial Alzheimer's disease patients and compare them to age-matched controls. And we find strong results, so you can really see Alzheimer, what is there, and it really comes to your face immediately. And what you also might appreciate is that many of the markers are really the same as in sporadic Alzheimer's disease. So that's really in line with what luckily the presenters before me were also seeing. And so I want to talk about GFAP. So we, and have shown this in Diane, and also many publications came out, also of the Down syndrome group, showing that GFAP cross-sectional levels start to increase about 10 years before the symptom onset. But how the plasma GFAP changes within individuals, that's not still well understood. And that's it's also needed to know to get really insight in what this might reflect and where you might be able to use it. So we want to test the hypothesis that the plasma changes within individuals associate with disease progression in familial Alzheimer's disease. And this is the study population from the Diane cohort. We used longitudinal samples of about 80 non-carriers and about 120 mutation carriers, most of them asymptomatic. There were many different types of mutations in this data set. The Dutch APP I excluded here. And the clinical syndromes are as expected. So about half of the asymptomatic mutation carriers are amyloid positive, and the MMSE scores are, of course, decreasing in the mutation, symptomatic mutation carriers, and the CDR sum of boxes is also as expected. And we see, again, the plasma levels are most increased in the symptomatic mutation carriers. And we have about 2 to 3 measures per person. And then this is the main graph. I think, when I saw it for the first time, I was really happy because, as you might appreciate, so in blue we see the non-carriers across the EYO slopes, and the slopes are really straight per individual. And then in pink we see the asymptomatic mutation carriers, and if you calculate it, it's about EYO 11, but this will differ slightly what kind of analysis you do. But we see consistent, real increases. They go towards above the threshold that we also use for amyloid positivity. And then the symptomatic mutation carriers have really much higher levels. When we looked into this a little bit deeper, we do see that in the mutation carriers that are amyloid negative, GFAP is not increasing. It's really has the same slopes or non-significant slope, similar to the non-carriers. And when the people are amyloid positive, then GFAP is really starting to increase. So in conclusion, I would pose this statement that GFAP increases reflect amyloid toxicity. Happy to discuss that further. And I think this really shows the close relationship between GFAP levels and disease progression in the late preclinical stage, and that's where we really need markers. So what I would like to highlight, because we're here today and tomorrow also to look for further collaboration. So Jana Dijkstra already showed the work which we do in our memory clinic. We've also started a new biobank to include all the family members from our patients. So this could be people with known mutations, but also if we don't know the mutations, or just their partners. And we are also setting up the Diane Ops study to be a site, and we were working with Diane on the TU trial. So I would like to thank all the collaboration, and specifically the participants, of course, for donating all their samples and undergoing all the scans. This is a photo of our lab. We are always happy to receive visitors or students who would like to do some time in our lab. Yeah, that's it.
Great. So our next speaker is pre-recorded. It'll be Nicholas Barthelemy from Washington University at St. Louis. Is going to be speaking on soluble tau phosphorylation and MTBP tau 243 changes in autosomal dominantly inherited Alzheimer's disease. I don't know if he's available for questions.
Yes, he's going to be.
Okay. Thank you.
Good afternoon, everybody. Thanks to the organizer for this opportunity to present our work. I'm Nicolas Barthelemy, and I'm going to present on behalf of Diane the result we have obtained regarding soluble tau phosphorylation and MTBR tau 243 changes in autosomal dominantly inherited AD. Here are my disclosure. So in 2020, we have already reported the trajectory of different phosphocytes, including 217, 181, 205, but also 202. We have demonstrated we can detect early changes of tau 217 and 181 hyperphosphorylation happening around 20 years before the symptom onset. We have also demonstrated phosphorylation at 205 follow a different trajectory than those 217 and 181 by being hyperphosphorated later in the course of the disease. Importantly, we have found 217 and 181, even if they are increasing over the preclinical stage at symptom, they have a trend to decrease, probably in response to the emergence of symptom, but also tau aggregation. And over the past years, we have also significantly improved our mass spectrometry assay, and we are now able to measure more phosphorylation sites. So we propose in this study to measure the trajectory of the phosphorylation at almost 10 phosphorated sites. And on top of that, we want to benefit of recent development made by Kanta Ori, who designed a mass spectrometry assay targeting a fragment of tau, which is containing the microtubule region on the repetitive domain number 1. And Kanta demonstrated this fragment is particularly increased in response to AD pathology in sporadic AD. As also using the BioFinder study demonstrated a really high correlation between MTBR 243 and tau PET signal. So we want to address in Diane what is really the trajectory of the MTBR 243, and we expect really because of this strong association with tau PET to detect a rise of MTBR 243 around the symptom. So to prove this hypothesis and so study the different phosphorylation on top of the one we have already described, we are going to use a sample collected from 2017 to 2022. Overall, it's more than 400 participants who were followed in the context of Diane Ops and Diane TU. Regarding the participants we are going to analyze in Diane TU, they are participants without treatment, means it's a participant enrolled in clinical trial, but we just measure the sample at baseline and under placebo. Overall, we have 240 participants with only cross-sectional data and 182 participants with longitudinal measure. For all those CSF measures, we are going to plot them according to the EYO, the EYO being calculated based on the age of the participant compared to the expected age of onset, knowing their mutation status. We are going to measure different tau concentration, p-tau to tau ratio on 9 residues. We are also going to measure the new microtubule binding tau 243 concentration, and overall almost 800 CSF samples were analyzed, and the goal is, as I was mentioning, assessing their trajectory over the EYO, but also using the longitudinal measure to assess the rate of change of those biomarkers. We want also to evaluate the suitability of those CSF biomarkers to potentially monitor drug effect in clinical trial enrolling dominantly inherited AD participants. We assume we can measure potentially the effect of anti-amyloid drug, and we expect, for example, in a response of CSF p-tau, considering the early change we have observed on the tau hyperphosphorylation in response to early amyloid deposition too. On top of that, the NTU is going to test different anti-tau drugs, including the ESI anti-tau antibody 2014. There's also some trial going to assess tau ASO, and in this context, we want also to figure out the CSF p-tau could be used to evaluate their effect, p-tau, but also MTBR 243. What we want is to have a good biomarker and to test actually those effects, and it means the biomarker trajectory has to be predictable. We want a biomarker with a natural trajectory due to the disease going to increase ideally. And so when we are going to test the intervention using a drug, we want to have an effect on the biomarker. So ideally to observe a decrease due to this intervention. And on the opposite, what we want to avoid is to use a biomarker which is likely going to have an unpredictable trajectory, as I was describing for some of the p-tau, kind of decreasing at the onset. And so if you have this decreasing and you start to do an intervention, the decreasing you are going to observe longitudinally is due to the natural trajectory or due to the intervention. So in this context, this biomarker will not be ideal. So we want to assess which biomarker will fit really this purpose. So here are the results we have obtained in the new cohort with 217, as previously reported, increasing during the asymptomatic phase. The flat line you observe here is for the value we obtained on the amyloid negative participant, mostly mutation non-carrier. At symptom, 217 is going to plateau and decrease, and the more severe the symptoms are, the more pronounced this decrease is. When we categorize participants according to the different clinical status characterized by the amyloid positivity and the CDR status, you can see this increased and plateauing effect, which is confirmed when we look at the rate of change. And for longitudinal value, we will see at asymptomatic phase, most of the participants have a positive rate of change. At symptom, some of them are going to go to plateau or decrease. And at more advanced stages, we get more participants having a negative rate of change. So looking at this, it seems 217 would be more ideal to track anti-amyloid drug treatment at asymptomatic phase because we can predict typically all the rates are going to be positive. 181 followed the same trend as 217. At the difference, the effect we observe on the negative rate of change at moderate stage of symptom is more pronounced. Regarding phospho-205, we confirm as before the increasing of hyperphosphorylation on this site happened later in the disease process and closer to the emergence of symptom. Unlike 217 and 181, we don't see the same plateauing or decreasing effect happening at the moderate stage of clinical symptom. So when we look at the rate of change, you can see mostly during all the stage of the disease, the rate of change of 205 is going to be positive, excepting for some participants. So in this context, it seems 205 is going to be more appropriate to measure potential drug effect symptom. When we look at other phospho-tau, it happened 111, 153, 28, and 231 seems to have similar trajectory to what we have observed for 217 and 181. So they respond to amyloid deposition, and at symptom they have a trend to plateau and decrease. And we have two phosphosites. 202 was reported before as not hyperphosphorated, and we found 181 is not hyperphosphorated due to in response to the disease as well. Now regarding MTBR243, as we were predicting, it seems the level are increasing really around the symptom onset, much later than what we observed for 205. When we look at the absolute value, you can see a constant increase over the clinical stages. And looking at the rate of change, we saw a pronounced increase for most of the participants when they are at the mild cognitive stage. But surprisingly, we found after more advanced stages, most of the participants are going to plateau, and some participants get a pronounced decrease in their rate of change. So we assess an alternative way to measure 243 by normalizing by tau, and we found by this way we are getting a more pronounced increase over the symptomatic stage, and looking at the rate of change, we limit in some way the plateauing negative rate of change we have observed more advanced stages. So we can consider potentially this ratio as a way to get the longitudinal trajectory of MTBR243 more predictable for clinical. So in conclusion, our new tau dataset confirmed the trajectory we have observed for 217, 181, 205, and 202. On top of that, the novel measure on 111, 153, 28, and 231 suggests they have a similar trajectory than 217 and 181. So they are early responder to amyloid deposition, and we found 199 is not hyperphosphorated. As expected in the novel MTBR tau 243 measure change much closer to symptom onset, likely at the time when tau aggregation occur. But we observe a negative rate of change for those values, particularly at moderate stage of the disease. And this contrasts notably with the previous report on sporadic AD reported last year in Biofinder 2, where most of the MTBR243 value for the tau PET positive were increased. We have to consider the change of MTBR in the dominantly inherited AD in a different way than sporadic AD. So regarding our finding and the utility of the different biomarker potentially for clinical trial on DIAD population, likely at the symptomatic phase, we can use the hyperphosphorylation on the 217 and the phosphorylation responding in similar manner. At mild cognitive symptom 205 and likely MTBR243 measure, including the MTBR243 to tau ratio, will be useful. At a more advanced stage, likely 205 and MTBR243 to tau ratio will be more predictable and more useful to measure potential tau drug effect. So thanks so much for your attention, and I would also want to thank all the people who contributed to this work, particularly for the tau analysis and the collaborator of Diane and Biofinder. Thanks again for your attention.
The floor is open for questions. Any questions from the audience?
Hi, great talks. I was wondering, so for the proteomic studies, did you find any sex differences in the proteins that you analyzed? And if you did, how do you explain these differences?
So, is this on? Sure, it's on. So in Diane, we actually didn't find that many sex differences. It's kind of like APOE. Actually, we don't see a lot of differences by APOE either in autosomal dominant. In the Down syndrome cohort, we see out of the proteins that we ended up analyzing over 100 of them are different by sex. So that seems to be a little bit of a difference there with Down syndrome compared to autosomal dominant. Yep.
I have another one. So this is for Lisa. Do you think GFAP in plasma is signaling, well, is telling us that astrocytes are damaged or they are reactive?
It's a really good question. I think about this almost every day. Yeah, there has not been so much data of that the pathologists stain like the amount of GFAP in the brain, and that you can then relate that to the plasma measures. I think so far, at least what I may be behind, but what's been related is GFAP to the common AD pathologies, but not so much to the astrocyte pathology. And one way that I want to look at this further is to look at what other types of proteins correlate, and if there are more astrocyte reactivity proteins correlated to GFAP increases in plasma, in CSF or in plasma itself, because then we may be able to know this better, because it's quite essential. I do think because of the dissociation between GFAP in CSF and GFAP in plasma in Alzheimer's disease patients, or in the development of Alzheimer's disease, that it's tempting to think that it does go directly or through the lymphatics and not through the CSF. Because the barrier is so open, right, with the plasma. Yeah.
Thank you.
There was a question at the back.
Oh, they're lovely.
Thanks for a great set of talks. I had a question for John. Thank you for sharing that really interesting, your patient with a really interesting kind of clinical manifestations. With this early spastic paraparesis before amyloid or tau PET have shown signal, I wondered if you'd looked at the CSF or plasma A-beta levels, because there can be this lag, can't there, I think up to about 10 years, and I think it'd be really important to unpick whether it's an A-beta or non-A-beta phenomenon.
Right, pending. We did obtain CSF on her. Yes, we have a few ideas about what it might show, but
and GFAP obviously would be really interesting. Based on Lisa's work, it would be, either way, it would be really interesting to know whether the GFAP is altered at that very early stage.
Something maybe you might know about, I've been wondering, is neurofilament light is being associated with axonal damage. Would that be different with spastic paraparesis or not? We tried to test that, but the person doing the assay hadn't developed it yet, and data didn't make any sense. So I don't know if that's been done, but that would be, I think, interesting. And I think it sort of speaks to the bigger question of these mutations do different things, and you might see different biomarker changes. And I think the DIAN data, for example, gives the opportunity to sort of try to dissect out what different mutations might be doing to various biomarkers. So I think more should be done in that and trying to understand how these different forms of Alzheimer's are similar and how they differ.
In spinal cord diseases, you see really increased levels of NFL.
Right.
Yeah, plasma. Yeah.
Hi, thank you so much. A question for John also. And I was wondering, you showed some abnormalities in the pyramidal tract. Do you know if there are also extrapyramidal tracts affected, such as the rubrospinal tract? And the second question is that, do you know if these patients also have an increased concentration of immunoglobulins in CSF? Thank you.
I don't think we measured immunoglobulins per se. Are you thinking of active inflammation, like immunoglobulins produced there?
Yes. Sorry. So, for example, in some cases in patients with MS, we observe a high kappa index.
Right.
In this kind of motor neuron condition. So I was just wondering if you have checked that also.
We have not measured that. It could be done. But your first question of the specific tracts affected, that is to be dissected. I don't have that data now, but we have brainstem on folks, and it's tricky. But Anne Hineker is working on, and Mike Binkowski are working on ways to quantify it. When you do these myelin stains, apparently there's a lot of variability between batches. So finding out ways to carefully quantify the myelin signal there is being worked on. And that is interesting because I've seen the spasticity in advanced stages. Some people get extensor spasticity and others get more flexor. And so there's differences somewhere. Yeah.
Thank you.
John, this is the second time I'm sort of seeing the data, and it just occurred to me, I didn't see it if you reported it last time or this time, but TDP-43, and whether TDP-43 could link these ALS-type picture, motor neuron disease, with the AD picture. Have you looked at that or reported that?
It's not been measured, no. It's an interesting idea.
I think you should measure it.
Sorry?
I think you should measure
yes. Now, if we have Rissman on in our ADRC, we have many new opportunities to explore these things.
I have a question for Lisa. For Laia. Yeah. We heard from Lisa today on her results of GFAP in AD-AD, and you recently published a paper in Down syndrome. So since we are here to bridge the two fields, maybe you want to comment on those results?
Yeah, I mean, I think you commented already a bit, but in that paper we observed that GFAP was increased earlier in Down syndrome, and then even earlier that amyloid-β, then CSF A-beta ratio going down. So, yeah, absolutely. I don't know, I don't remember exactly the age of onset, when the change happened, but you see something like 10 years before age of onset. And I think it's about the same. So, yeah, maybe we could overlap that data and see if it really coincides. Yeah, absolutely. So, yeah, because I think that the figure I presented in the very beginning doesn't include GFAP there, so maybe that would be interesting to do is see, how these two populations.
Yeah. It's just because it's to follow up on don't lose track. So in that paper, remember that we had the data from the Picohain project, and the lines were completely overlapping.
Exactly.
So I think it'll be the topic of tomorrow's session, the kind of the modeling and everything. So first of all, we have to be careful with the modeling. Depending on how you do the modeling, you can have very different results, especially in the streams. So that's one thing. And the other thing is that Diane is for all of us probably probably the gold standard to compare all the results, but sometimes they have different results. So for instance, in terms of NFL that have been said, in the DIAN, oftentimes the results are set to change 10 years max, even less, whereas in our cohort in Daphne, it was 20 years. But in the Colombian kindred, it was also 20 years. So Rayman et al. With Quiroz, they have 20 years. So sometimes it's great to have Diane probably as the most deeply phenotyped cohort as a reference, but it's worth checking other cohorts, other mutations. It could be watch out of the modeling, could be mutation specific, but I think that's why we are here. It's like we have to look to many places to really get the full picture. So sorry, I jumped.
Would it be possible to model depending on the mutations rather than the cohorts? That would be.
Question to the proteomics. So when you look at the results, I'm sure you say, well, that's good, that's obvious, that should be there. So do you ever think, well, what could be missing? And, you know, there may be some surprises that you haven't thought about that should be there, and why aren't they there if they're not there?
That's a very broad question. But I would say, you know, the analysis depends, one, on the depth of the proteome coverage, right? So what I was showing in the DIAN cohort, that was mainly with targeted proteomics on about 60 proteins. And then what Lia was talking about, we started with about 1,100 proteins there. And, you know, I think it also depends a little bit on how you measure them. You know, there's some variation in proteomic techniques, just like there is in ELISA-based assays as well. But, you know, one thing that we see that's quite interesting, I think, that Juan mentioned was that NEFL starting very early in Down syndrome. Also, lactidherin, which is very much earlier in Down syndrome compared to the autosomal dominant, and we think that might be due to CAA. So in terms of things that we would expect to see that we don't see, I would say in autosomal dominant Alzheimer's disease, I wouldn't say that there's anything that we don't see there that we haven't seen in sporadic as being altered. And in Down syndrome, you know, we need to look more closely, but I think there's a lot of interesting changes in the same direction, but as Lia mentioned, some of these metabolism markers are actually going in opposite directions. So we don't know why that is. That's pointing to some difference in the underlying biology that we should try to understand.
Yeah, something I can also say that looking at the data, something that surprised me a lot is that the lysosomal markers come very late, or much later than I had expected, because it's always discussed that in Down syndrome, the lysosomal pathway, there's a dysfunction of the lysosomal pathway, and you would expect that to happen very early because you have so much overexpression of APP. But I don't know why in the data set it shows up after symptom onset. So that was a big surprise to me. I don't know.
I can also add to that. So I think we often start to see a couple of markers that we know, and you replicate all the time. So that's really reassuring. The longer you're in the proteomics field, the more confident. But there are also still many different ways to look at it, and that will also determine a bit what we find. So, I think your team has really advanced methods to look into the modules. But you can also look on a cell type level, or you can, I don't know, zoom in on a different biological process. And there, I hope that many different people will pick up different approaches, so that will give us a more complete picture. Because just on the databases, I think maybe it's not to you, but not to everyone. The databases are as good. It's like an encyclopedia. That's how I see that. And if it's not known, then it's not in the encyclopedia, so we will not find it.
So I have a proteomics question. So going back to the topic of this co-pathology of Lewy body disease and autosomal dominant and other forms of Alzheimer's, is there any hint in all the proteomic findings of why that might be? Is it the lysosome maybe? I never hear alpha-synuclein being called out as a abnormal protein in these measures.
Yeah, it's really a great question. Alpha-synuclein isn't a great biomarker to begin with, even in Parkinson's disease, right? But But there are some proteins that look very promising in Lewy body dementia that we haven't really focused on or measured, I think, well enough in the autosomal dominant cases that may have co-pathology. So I think what might be helpful, and this is work that's ongoing, is some of these amplification assays to try to identify those cases that may have enough pathology in the brain to give us a signal there. I know if it's restricted to the limbic cortex, you just may not pick it up. It has to be more diffuse, but that could be one way to get us some additional information to look to see which cases may have we need to focus on for those markers.
And
sorry, I just want to, in the Down syndrome, when we do this comparison with Down syndrome and ADAD, this PARC7 protein. So I was like reading a bit, like sometimes it's what we were discussing with Eric before. You identify some proteins and you look and check for the function, but it's not super well established, or you don't really know the role of that protein. But I was reading a bit on the proteins that show different trends, and this PARC7 says that it's linked, that actually is called Parkinsonian, blah, blah, blah. Right. So it's involved in some oxidative stress processes. So maybe that can be a hint.
So that's in Down syndrome, you see that differently expressed.
It is also in late onset Alzheimer's disease as well. Oh. It's a good, and you can see it in the brain proteomics. So it's a marker that shows up all the time, but why?
Yeah.
Not clear.
And you wonder if only certain mutations or if mutations predispose differentially to Lewy body disease, might that be washed out when you're grouping them all, right? Again, looking
Absolutely.
At individual.
Yep. And the challenge, of course, there is that these are rare.
Right.
And so getting good statistical power to actually say there's a difference in some of these markers is challenging. But I think that's one thing that I think has been nice about the DIAN study, is that you can increase power, obviously, for these very rare diseases and get some sense, and then go back based on the bigger cohort and try to dissect the individual mutations a little bit compared to the rest of the group.
And there are also some nice Parkinson and DLB study. We have a DLB study, proteomics in CSF, and there are also other groups that show nice DLB and PD markers. I don't know by heart how they perform in the familial Alzheimer disease cohort, but that could be a really interesting, easier way than to have a targeted look, whether these signs are there. Can I also ask a question to Nicolas?
Is he online?
Is he there? Oh, he's not there. Okay.
Okay. Since we were talking about proteomics, we discussed today, you showed data on certain markers that perhaps stood out. How do you see that research evolving, and do you see any of these markers further translating into clinical practice?
So that's our goal. I think there's different ways you can think about it. With proteomics, you're measuring lots of different proteins, and you're trying to put those findings together into different pathways. And you could, I think, potentially do that in a clinical setting too, if you do it right. But also you can narrow it down into panels of individual proteins and look for particular proteins that are very well correlated to a certain pathology that you're interested in, and build that out. I think that's also probably a very promising approach. So we'd like to move this in to a clinical context, and ultimately that's not only to understand the disease but also use them in clinical trials. That's where we're going with that.
Yeah.
Mm-hmm. Yeah,
I agree. I think the clinical trials are the earliest adapters. And for AD, we have already pretty good plasma markers, but for the other dementias, it's virtually nothing, and also not in. Yeah, CSF has now the DLB has the RT-QuIC, but the rest FTD is not so good. So there, also to differentiate between the dementias is very helpful. And for clinical trials, I think the markers are capturing what Eric also said, certain parts of the biology.
So especially as trials diversify, so not only targeting A-beta, but also other targets, we will need good other markers for target engagements, like in the lysosomal pathway or in other pathways. And that's where I see a lot of purpose for these markers. And we make smaller panels, and we are also, a lot of PhD students in our group are working on developing single assays. So we have already quite a few.
Yeah, I want to add to that I think now we have good biomarkers to diagnose in AD, but the more treatments we will have, because if we think about oncology now, they use to predict the outcome of the treatment on someone, they really do a profile of the patient and see, is this treatment going to work in this person? So now we have few treatments, but in the future when we have more treatments, you will want to make sure that this treatment is going to work in this specific individual, so you will have panels of biomarkers saying okay, this person has this profile, should it go through this treatment or through this, this is how I picture it. I don't know if this is going to happen, but I think for sure we're going to need panels of proteins, not a single protein to say you have AD or you don't have AD.
Sure. Any other questions? No? You don't have more questions? No. Okay, so maybe we will close early, or 10 minutes early. One.
Yes, some housekeeping.
You can talk here.
Hi. No, yes, some housekeeping, just to let you know that at 5:30 we have the tour at the Modernist Hospital. I highly recommend it. It's a World Heritage Site. It's really beautiful. And for those that come to the dinner is, as you go up to the street from the main entrance, is at the end of the block. It's another really big building. It's the Casa de Convalescencia. There will be a short tour of that building too for those that want to come at 8, but the World Heritage Site is this one. The other one was done by the son of this architect and is not protected as UNESCO. It's nice too. I mean, certainly if you're into that, you're more than welcome. But if you have to choose, it's not the same tour, and I recommend this one. Okay? Thank you. And for those that do not come, we'll see you tomorrow. Thank you very much.